A very good afternoon to respected faculty, doctors, and honorable dignitaries. I am Dr. Sania Nisar, Senior Resident, Department of Pathology, GMC Srinagar, and I welcome you all to the Bleeding Disorder Consensus Meeting 2024, organized by the Department of Pathology and Hemophilia Daycare Center, GMC Srinagar and associated hospitals, under the aegis of Hemophilia Health Collective of North and Hemophilia Society of Kashmir, with the theme of changing landscape in hemophilia care in India. As we gather here, we recognize the profound impact that hemophilia has on the lives of individuals and families around the world. From the challenges of diagnosis and management to the ongoing pursuit of effective therapies, the journey of those affected by hemophilia is marked by resilience, courage, and hope. It is my honor to stand before you today as we embark on a journey of exploration into this complex and critical area of medicine. Hemophilia was first discovered in the 10th century when the physicians started to take serious interest in the people, especially males, who were bleeding to death after sustaining only minor injuries. Unfortunately, due to the limited technology of the day, it was impossible to research the condition properly. Numerous historical figures are thought to have hemophilia, especially the members of European royal families. In 1803, Dr. John Conrad Otto of Philadelphia began to study the people he called bleeders more extensively, recognizing it to be a hereditary illness that was most often passed on to the males from their healthy mothers. In 1937, hemophilia was officially divided into two types, A and B. It affects hundreds and thousands of people worldwide, many of whom are not fully aware of their condition and are not getting the proper treatment they need. Many people are not aware just how serious this condition is and how much more difficult and dangerous it makes the lives of those who have it. And this is where events like today come into play, for raising awareness, bringing attention to the issues related to the proper care to wider public. Today's meeting aims to bring together the healthcare professionals of India to discuss the latest developments, share personal experience, and explore future strategies for improving care and support for those affected by hemophilia. It is my pleasure to introduce the organizing chairperson, Professor Dr. Sheikh Bilal, Head, Department of Pathology and Hemophilia Daycare Center. Sir is a renowned pathologist and has made significant contribution to the field and is known for his dedication to patient care. I request Sir to take the stage and address the audience.
I request audience to be seated and a bit silence is needed. A humble submission. Thank you, Dr. Sania, for the kind introduction. And I am really delighted to see the stalwarts, in the audience. So, a very good afternoon to all. It is a great honor and pleasure for me to welcome you to the Bleeding Disorder BDCM 2024, which is being organized by Department of Pathology and Hemophilia Daycare Center, Government Medical College and Associated Hospital, Srinagar, under the aegis of HHCN and HSK. So I really am thankful for the delegates who have come across all the country, and they have taken out their time out of their busy schedule, and that too many of my friends were having the fear psychosis of Kashmir because they were the first time visitors to the Kashmir, but I assured them everything is fine because it is really the heaven on earth. What has been said that agar firdos baroe zameen ast hami asto hami asto hami asto. If there is somewhere heaven in the world, it is only in Kashmir. It is in Kashmir and it is in Kashmir. So everybody will agree me, and God has been also very great to us. He has given us a very pleasant weather all around. So the aim of this gathering, where we gather who are the participants who gather? There are the healthcare professionals, healthcare providers, the brilliant brains behind the medical science, the researchers, the advocates, the advocacy, the patient bodies. All they collaborate and coordinate. That is very important. The collaboration and the coordination between the patient groups, the doctors, the advocacy, the healthcare professionals, the researchers, whom much of the credit goes to the current era of the healthcare, what they are providing to a common human being. So this is all collaboration. These gatherings are very important to share the knowledge. You have to share the knowledge and share the expertise, share the experience, share the real world. There are so many things written in the literature, in the world, in the books and medical books and everything. But sometimes in your, hands-on practice, you have something different. So everything what you practice in your clinical practice is sometimes out of literature. So those experiences from the experts, from the end users, and all the people who are involved in the hemophilia care. So when this forum is an invaluable platform where we discuss, we learn, we share the experiences, the knowledge, and the expertise between among us, so that we can give a better, better healthcare and better quality of life to the people who are suffering with the hemophilia, which is definitely a medical disorder. And we should appreciate also, rather congratulate the people who are suffering from hemophilia and the families who are navigating through day in and day out of this bleeding disorder, which is a very much challenging medical disorder. If you compare it with other things, like there are so many medical disorders like diabetes, hypertension, malignancies, so many disease, pneumonia, so many things are there. But it is altogether different from those things. Because this is a bleeding disorder, the nature has been kind to us that our gene, factor 8 or factor 9 gene, is working well on the X chromosome, and we are not having any bleeding thing. But God has been given them some special status that the gene is missing and the protein is missing, and that protein is very important for the coagulation pathway, the hemostasis. Even if somebody gets an injury, and naturally there are so many primary hemostatic and secondary hemostatic, which our esteemed faculty, the brilliant brains, the brilliant speakers who have the who are of international repute, who are delivering their lectures at national and international levels. So we are lucky to have them with us and to learn something from this. So I again welcome Dr. Ruby Reshi. She is my mentor, and she needs a lot of applause for her, because she is the pioneer of the hemophilia in Kashmir. So she is a special guest for us, because she is a lady, Iron Lady, who has started the hemophilia care in 2011 in J&K. And we are at this only because she has initiated this thing. So a round this applause for Dr. Ruby Reshi. Thank you, ma'am. You have just enlightened our this audience by your presence. We are very much lucky. You have taken out your busy schedule. I know you are heading a medical institute. It is very difficult to take time out of that. And again, I am thanking you for coming and gracing the occasion. So this is the, about the hemophilia, we learn the expertise. The thing is that it is not the one man's domain, which I have been saying, and I am always saying that hemophilia or the bleeding disorder, which are being managed by the healthcare providers, is not single man's job. So there needs an important thing, what is called as comprehensive care. What is the new concept? Comprehensive care centers. So what is comprehensive care is all people are involved. From the lab physician, from the clinical hematologist, from the pediatric surgeons are there, surgeons, general surgeons are there, orthopedicians are there, physiotherapists, psychiatry counselors. So there are so many people who are involved in giving the care. So they should all give the care under one roof, and only aim is that previously what was the aim? It was the aim in the just as zero bleed, that they should not bleed. I mean, we should not have any bleed in that. So that concept has also changed. So zero bleed is there only, but the new concept is that we have to make them as non-hemophilic so that their quality of life, they can go to school, they can earn the labor, they can go for the higher studies, they can do the job, and they can be as a non-hemophilics. So that is the concept, the active lifestyle. So it is not the only thing that zero bleed, but there is a concept that the hemophilia care should be such a way that they should, live a very healthy, active, and quality life. That is the main concept of this thing, and these forums are for that. So we can learn, we can have the feedbacks, we can have any questions, queries. We are very much lucky that we have a lot of panelists, we have a lot of experts throughout the country, and who have a lot of experience in managing the hemophilia and the care, the challenges which they face day in, day out. So we will discuss. Everybody is open. Everybody is open there. They can ask questions. They can discuss. They can collaborate. They can share the knowledge, so that this science goes beyond the life, that so that we can. And there is much to do, because the science has such much. I mean, I am so much. Thrilled in sense that I should give a lot of credit to the researchers. How much money they are pumping in to increase the just to save the humanity. I mean, we have the things that previously it was called hemophilia, but to me right now I don't find that they are blood dependent. So there are monoclonal antibodies now. They are dependent on monoclonal antibodies. So maybe sometimes it may change as monoclonal antibody philia, like that name. So because the things are changing. So I know that they are very much dependent on blood and blood products. So there are a lot of challenges of TTIs. So after that, plasma-derived products came. After that, recombinant products, third generation products, then fourth generation EHL products, and now the non-factor, and then ultimately gene therapy. I mean, the people are working. The researchers are working day in, day out. They are using their blood and sweat, and we are enjoying that. But it is all salute goes to them and all the industry leaders who are just supporting these things to move so that we can reach that level. So this platform is for that, so that we can collaborate, we can discuss. That is why we have not kept much of the speaker sessions. I mean, the speaker sessions are very less. There are much of the panel discussions. There will be much interactions between the audience and the panelists. Anybody can ask any question, any query, any sort from the hemophilia or bleeding disorders, so that all sorts of things, we are in a learning process, and much is to be learned. So nobody is perfect in the world. So let us hope and wish all the best for the BDCM. Thank you very much for sharing the knowledge. Thank you.
And a fruitful speech. Assalamu alaikum, everyone. I am Dr. Afreen, postgraduate resident from the Department of Pathology, GMC Srinagar, and I'm your co-host for the day. It's my pleasure to introduce the Scientific Committee Chairperson, Dr. Naresh Gupta. Sir is also the Chairperson of Hemophilia and Health Collective of North. He is the stalwart of the Hemophilia Healthcare Center. I request Sir to come to dais and set the context of Bleeding Disorder Consensus Meeting 2024.
A very good afternoon. I am always happy to come here and to any hemophilia meeting. And I am happier to see the smiling faces of the audience. That speaks of their intimate association with the hemophilia that they are dealing with at their own institutes. Dr. Bilal has said everything. He has not said one thing. Hard work really shines. Hard work shines because there are few hard-working people. And it is shining today. If the weather outside is good, it is because of their hard work. Take it from me. If the weather is good inside with delegates from all over the country, it is because of the hard work of Dr. Bilal Ahmed Sheikh and his medical and administrative team to do such a good job. He also brought in the concept of diversity, or what I call all-inclusive participation. And this all-inclusive participation of all the stakeholders is very important. Over here, I'm finding that something that we wanted in 2007-8 has already matured now, and those are the hemophilia advocacy societies. We have Sandeep, we have Jaiswal, we have Majid from here. And Majid Qadri, I have been seeing he is not a dedicated person, he is devoted. They really have a passion for this hemophilia. These are the ones who need to go on board. So I congratulate you and your team and the other hemophilia stakeholders. Jaiswal is smiling. He did such a wonderful job in Jharkhand for the hemophilia. It is often asked, we have this body that we created, Hemophilia and Health Collective of North. So the idea was, when hemophilia was coming up, we need to consolidate. And the consolidation has been going on since 2007-8. And now, for the past couple of years, the whole armamentarium of treatment modalities that he has talked about is creating anxiety. It is creating anxiety amongst patients, amongst doctors, amongst their families, amongst the administrators, policymakers, and the financial advisors, whosoever are there. And one is trying to compete with the other. The idea is not to compete with the others. The idea is to collaborate everything. Everybody has got a role to play. And likewise, every drug has got a role to play. And in a resource-constrained society, we must ensure that we do it in a meaningful manner. All drugs are taken care of, all segments of hemophilia are taken care of, and all the available resources, whether it is human resources or money resources, they are appropriately utilized. And I think that is what the context of these BDCM and other meetings is. To create an environment for exchange, but this exchange should lead to some policies and protocols which can be duplicated everywhere. So that was the purpose behind creating these Hemophilia and Health Collective. And Dr. Bilal is a member, and Sujata is a member, but all of you are actually members. Professor Ruby Rishi, I would say, was one of the first members in 2011 itself, when this didn't even exist. And she was so dynamic, she called up, she says, Dr. Gupta, I have finished all my products in this 1 week. And we are going so fast, and that fast bullet train of Kashmir has not stopped. The purpose of HHCN is only this, that we bring everybody together, we create some consensus, and we document it. And some of the states have already adopted the first guidelines that we released under the HHCN banner on 23rd of December 23, 14th of December 2023. And those have been adopted by some of them, and I was given a feedback by Mr. Jaiswal that we should project it to all the groups that we meet every few months. There is a website called hhcn.in. On that website, these guidelines are uploaded. These are very simplified guidelines, very practical guidelines with decision-making tables, action tables, and everybody can go through it, and we invite all kind of feedback, suggestions, criticism, and constructive views that you would put across. So those guidelines you come across, we are working on the second version, and that will come through. When this group came up, Hemophilia and Health Collective of North, one question that used to arise in the minds of many of the delegates was, why North? It was not North-South divide. That has come in much later, and that has been brought in by the economists. World Economic Forum brought it, and the politicians brought it. It's not that. Our north is बहुत पुराना है. Remember the North Star? What is the important significance of North Star? Now, North Star gives you the direction from the times when we had nothing except our own body, eyes, and mind. North Star stands for giving direction. And North is where you take all these inputs of direction and go forward. That is the idea of, this is a, चेंज करते हैं सेट पे करते हैं. चलो कोई बात नहीं है. This will need. Thank you. So the north stands for the direction, and anybody who gives you direction becomes the north for you. And we want everybody to contribute to this direction, and that is how you start making the progress. In fact, if you look at this availability of treatment, the variation, the diversity in accessing these different treatments is not only a problem of India, it's a problem of America also. So the news chapters, new scenarios, we don't want to keep repeating what we have been doing for 20 years, but we want to talk about how do we go further from this. Unless we continuously make a progress, we will be nowhere, we'll be lost. As Alice in Wonderland, Charles Ludwig Dodgson, Lewis Carroll, commonly known as, said it, you have to keep running to stay stationary. So let us try to stay stationary rather than go backwards. Welcome to this meeting, and congratulations to all the organizing teams. Thank you.
Thank you, sir, for your kind words and your acknowledgement of our hard work. We are glad to have a stalwart like you with us today. I now request Mr. Syed Majid Qadri, President, Hemophilia Society of Kashmir, to address the audience and share his memories and learnings from the Bleeding Disorder Consensus Meeting 2023 that was held in Chandigarh.
और सबसे पहले मैं वेलकम करता हूं डेलीगेट्स और गेस्ट्स का, जिनको हमने पूरी इंडिया से यहाँ बुलाया. आज हमने सोचा इनको मोबिलाइज़ करेंगे, इनको जमा करेंगे और यहाँ अपने ख़यालातों का इजहार करेंगे और अपनी जो प्रॉब्लम्स है या अचीवमेंट्स है उनको शेयर करेंगे एक दूसरे के साथ. तो मैं शुक्रिया अदा करना चाहूँगा आप सबका, चूँकि वन बाय वन मैं नहीं कह सकता हूँ, वक्त की पाबंदी है. और सबसे पहले शुक्रिया डॉक्टर रूबी ऋषि, प्रिंसिपल एंड डीन मेडिकल कॉलेज बारामुल्ला, जिन्होंने हीमोफीलिया ट्रीटमेंट सेंटर की न सिर्फ संगी बुनियाद रखी है, बल्कि उन्होंने हमारे राइट्स के लिए हर फोरम पर लड़ा है और उन्होंने बहुत ही जिद्दोजहद की और ये बुनियाद डालकर वहाँ से प्रमोट होकर निकल गए. और फिर डॉक्टर बिलाल को बहुत सारे चैलेंजेस जो डॉक्टर बिलाल को मिले हैं उनको उन्होंने एक्सेप्ट किया. डॉक्टर बिलाल एक वो शख्सियत है, हम इनको डॉक्टर की हैसियत से नहीं देखते हैं, बल्कि एक फरिश्ता सिफत इंसान की हैसियत से देखते हैं, जिन्होंने उस डॉक्टर रूबी ऋषि की लड़ाई को कंटिन्यू रखा है, हमारे राइट्स की लड़ाई और हमारी जो डिमांड्स और मांग थी हीमोफीलिया पेशेंट्स की, उनका दिफा किया हर फोरम पर. बहुत सी ऐसी जगहों पर हमें लगा कि डॉक्टर साहब अपनी कुर्सी का ख्याल नहीं रख रहे हैं और सिर्फ वेलफेयर, पेशेंट्स की वेलफेयर के लिए काम कर रहे हैं और बात कर रहे हैं. बिलाकर लेकिन सच्चाई की जीत होती है और ये हर फोरम पर सुरखरू हुए हैं. मैं ये कहना चाहता हूँ, इस BDCM का मकसद है, ये सबसे पहले नॉर्थ में डॉक्टर संदीप वर्मा ने स्टार्ट की, क्योंकि हमें लगा कि नॉर्थ का जो पूरा जो रीजन है बिखरा हुआ है. डॉक्टर संदीप ने बोला हमारे अहदाफ, हमारी डिमांड्स और राइट्स एक है, हम बिखरे हुए क्यों हैं, हम क्यों न एक साथ लड़ेंगे, हम क्यों न एक फॉर्म बनाएंगे, उस फॉर्म को यूज़ करके हम अपने अहदाफ और राइट्स को हासिल करेंगे। उन्होंने शुरुआत की, वहाँ पर हमें बुलाया वहाँ पर, और हाथ में हाथ थामा, बोला ये हाथ कभी नहीं छूटेगा। ये एजाज़ इन्हीं को हासिल हो जाता है जिन्होंने ये वहाँ पर इसकी शुरुआत की, और डॉक्टर वरुण कौल साहब। क्योंकि मैं जब गया, मेरी एक आदत है, हमारी एक आदत है, हम अपने टीम के साथ हम जाते हैं। जब हम गए तो पेशेंट्स के साथ पहले इंटरेक्ट करते हैं, पेशेंट्स से पूछते हैं कि क्या हाल है यहाँ का, क्या मसला है, क्या चल रहा है। तो पंजाब के उस चैप्टर के सारे पेशेंट्स ने बोला हम शायद खुशकिस्मत थे कि हमें डॉक्टर वरुण कौल और डॉक्टर संदीप मिले हैं। जब से इन्होंने चार्ज संभाला, जब से इन्होंने काम करना स्टार्ट किया, हमारी जो लाइफ है वो बेहतर होना स्टार्ट हो गई है। तो वहीं से उन्होंने ऐलान कर दिया कि ये नेक्स्ट BDCM जो है वो श्रीनगर में आप मुनक़्क़िद करेंगे। बहुत, ये एक चैलेंज से कम नहीं था, क्योंकि हमने इसको एक मेगा इवेंट बना दिया। हमने सोचा कि हम पूरे इंडिया से लोगों को बुलाएंगे, पेशेंट्स एडवोकेसी ग्रुप्स को बुलाएंगे, HFI के प्रेसिडेंट को बुलाएंगे जो कि रिप्रेजेंट कर रहे हैं मुल्क की सतह पर हीमोफीलिया पेशेंट्स को। हमने उनको बुलाया और यहाँ पर एक प्लेटफॉर्म पर जमा हुए ताकि हम अपनी प्रॉब्लम्स को एक दूसरे के साथ शेयर करेंगे और अपनी एक्सपीरियंस को एक दूसरे के साथ शेयर करेंगे। क्योंकि ये बहुत ही टफ जो हमें मिला है टास्क, तो हमने कोशिश की, इस पर हम खरे उतरे और काफ़ी मेहनत की। मेरी जो टीम है हीमोफीलिया सोसाइटी को, स्पेशली जो हमारे 5 एग्जीक्यूटिव मेम्बरान हैं, जिनमें शकील साहब है, जिनमें महराज साहब है, आदिल साहब और परवेज़ साहब, ये पिछले लास्ट मंथ से मुझे नहीं लग रहा कोई घर गया है। तो हम श्रीनगर अपने ऑफिस के पास ही रात भर ये बैठा करते थे। मैं बीच बीच में तो गया, लेकिन ये लोग नहीं गए हैं, दिन रात काम करते रहे। और डॉक्टर बिलाल की गाइडेंस में, चूँकि इससे बढ़कर हमें कोई गाइड नहीं मिलेगा। डॉक्टर नरेश गुप्ता साहब, आपका बहुत बहुत शुक्रिया। आपने कहा कि मुझे खुशी होती है, मैं श्रीनगर आता हूँ, जब भी आता हूँ, और मुझे खुशी होती है। आप जैसे डॉक्टर्स की हमें ज़रूरत है और हमें आपसे नॉलेज लेनी है, और आपको हमारे डॉक्टर्स या बाकी डॉक्टर्स को अपनी नॉलेज देनी है ताकि हीमोफीलिया पेशेंट्स की लाइफ को आसान बनाया जा सके। ये हमारी खुशकिस्मती है, आप यहाँ आ रहे हैं, अपना कीमती वक्त निकाल रहे हैं। क्योंकि वक्त बहुत कम है, मैं ज़्यादा वक्त नहीं लेना चाहता हूँ और आपसे इजाज़त चाहता हूँ। बहुत बहुत शुक्रिया डेलीगेट्स और गेस्ट्स का, और अपने डिपार्टमेंट का, हीमोफीलिया ट्रीटमेंट सेंटर के डॉक्टर्स का, पैथोलॉजी से जो भी पूरा पैथोलॉजी डिपार्टमेंट हमारे साथ जुड़ा है, हमारा चोली दामन का साथ है। अल्लाह ताला इस साथ को रहती दुनिया तक कायम रखे, आमीन। और थैंक यू सो मच।
Thank you, sir, for sharing your valuable experience with us. Ladies and gentlemen, as we proceed with our first session, it's my pleasure to invite our esteemed chairperson, Mr. Prem Roop Alwa, to join us on the stage, and co-chairperson, Dr. Maganti Prasad, Mr. Jagdish Sharma, Mr. Deepak Singhal, to join the chairperson. With their vast experiences in hemophilia research and care, they will guide us through the enlightening discussion of hemophilia and hurdles, learning from the best practices in hemophilia from different states.
Check 1, 2, 3. Check 1. Good afternoon, everyone. Myself Deepak Singhal from Dehradun, representing Uttarakhand. Mr. Prem Roop Alwa, HFI President, and the chairperson over here. Dr. Maganti Prasad is here with us, and Mr. Jagdish Sharma from Jammu, Vice President HFI. I would like to call for the panel discussion Dr. Sandeep Verma from Punjab, Patiala. Mr. Samar Singh from Himachal Pradesh. Mr. Sayyid Majid is already there from Kashmir. Mr. Gobind Sharma from Punjab. Mr. Vaibhav Nehra from Delhi. Mr. Akash Kohli from Jammu. Mr. Akash Kohli. He is not there. Mr. Akash Kohli. Then next, Mr. Santosh Jaiswal from Jharkhand. Mr. P. Hemant Kumar from Hyderabad. And Mr. Ashutosh Sharma is already there from Haryana. Jind.
आप सभी का यहाँ पहुँचने पे तहे दिल से शुक्रिया, धन्यवाद। जैसे कि डॉक्टर नरेश गुप्ता बता रहे थे कि हमें कॉन्टीन्यूस प्रोग्रेस करना है और रुकना नहीं है। इसके लिए सर मैं कहना चाहूँगा कि जैसे पहले हम लोग हीमोफिलिक्स को डिफाइन करते थे कि दे आर हीमोफिलिक्स, अभी हमने उसके लिए वर्ड्स चेंज कर दिए, हम कहने लगे कि दे आर पर्सन्स विद हीमोफीलिया। ठीक है, उसके बाद हम चाहते हैं कि आने वाला फ्यूचर हो जब हम कहें कि दीज आर द पर्सन्स हु हैड हीमोफीलिया। तो दिस इज़ द चेंज वी वांट टू सी इन द सिनेरियो। तो हमारा जो अभी का सेशन है वो भी इसी तरफ जाने के लिए है कि हम हीमोफीलिया के ट्रीटमेंट के अंदर जो आ रही हर्डल्स हैं और जो बेस्ट प्रैक्टिसेस हैं हम उनको डिस्कस करें, ताकि जो बेस्ट प्रैक्टिसेस हमारे पूरे देश में फॉलो की जा रही हैं उनको हम बाकी स्टेट्स में भी लागू कर सकें, और जो हर्डल्स आ रही हैं जो पेशेंट एडवोकेसी ग्रुप्स जो फेस कर रहे हैं उनको धीरे धीरे करके रिमूव किया जा सके। जो हमारे पास जो पैनलिस्ट हैं ये 7 स्टेट्स को रिप्रेजेंट करते हैं, एंड जो हमारे पास जो चेयरपर्सन्स हैं दे बिलोंग टू कर्नाटका, आंध्र प्रदेश, जम्मू, उत्तराखंड। तो लगभग पूरे भारत की रिप्रेजेंटेशन इस टाइम स्टेज पे की जा रही है। जैसा कि हमारे पास टाइम है तो मैं चाहूँगा कि हर पैनलिस्ट से हमारी जो क्वेश्चन है वो जो हम डिस्कस करना चाहते हैं कि एक तो जो आपकी स्टेट के अंदर क्या क्या पेशेंट्स को क्या क्या दिक्कतें आ रही हैं, क्या क्या हर्डल्स आ रही हैं, हम वो डिस्कस करेंगे। सेकंड चीज़ जो है कि जो बेस्ट प्रैक्टिसेस आपकी स्टेट में फॉलो की जा रही हैं, जो आपको लगता है कि जो आपकी स्टेट की रिसेंट अचीवमेंट्स हैं, या जो हमारे और इसके साथ ही हम डिस्कस करेंगे कि प्रीनेटल डिटेक्शन के अंदर हम लोग क्या आगे कर रहे हैं सो दैट कि हीमोफीलिया के इंसिडेंट्स को भी थोड़ा सा कम किया जा सके। हमारा जो फोकस है वो इन्हीं चीज़ों के ऊपर रहेगा कि क्या क्या दिक्कतें ट्रीटमेंट के अंदर आ रही हैं और क्या क्या हमारी जो बेस्ट प्रैक्टिसेस हैं जो हमारी आपकी स्टेट से हम लर्न कर सकते हैं। ठीक है, आई विल स्टार्ट फ्रॉम मिस्टर समर सिंह फ्रॉम हिमाचल। I request the chairperson Premru Palwa and the co-chairs as well to interrupt wherever they feel they want to add on something and they want to ask some another thing or they want to give some additional information. So हम चाहेंगे कि आप भी अपना contribution साथ साथ में देते रहें। Mr. Samar Singh.
जी सर, थैंक यू वेरी मच। जहाँ तक हर्डल्स और चैलेंजेस की बात है, आई बिलोंग टू ए स्टेट विच इज़ एंटायरली हिली. The demography of the state of Himachal Pradesh is very hilly, and it is very difficult to travel from one place to others. तो जहाँ तक हीमोफिलिक्स की बात है तो सबसे बड़ी जो चैलेंज है वो हमारी डेमोग्राफी है. पहाड़ी स्टेट होने के कारण जो हीमोफिलिक्स हैं उनका जो मेडिकल इंस्टीट्यूशंस हैं वहाँ तक ट्रैवल करना जो है वो बहुत मुश्किल है. सेकेंडली, पहाड़ी इलाका होने की वजह से अभी भी जो सुपरस्टिशंस है, अंधविश्वास है, वो अभी भी जो है वो जो दूर दराज के इलाके हैं वहाँ कायम है. मैं आपको एक बात शेयर करना चाहूँगा कि अभी हाल ही में 2 और 3 पेशेंट हमारे ऐसे डायग्नोज हुए जिनकी उम्र 34 और 35 साल तक हो गई है. मतलब ये है कि वो आज तक वो सुपरस्टिशियस जो प्रैक्टिसेस थी, जादू टोना और दूसरे जो चीज़ें थी, उसी में लगे रहे। और जब कहते हैं एक्सट्रीम हो गया तब वो मेडिकल इंस्टीट्यूशन में गए, वहाँ उनका जब टेस्टिंग हुआ तो पता चला कि वो हेमोफिलिक्स है। तो आई थिंक ये पूरे इंडिया में ही नहीं, हिमाचल की बात ही नहीं है, इंडिया में भी और वर्ल्ड के बहुत सारे कंट्रीज़ में भी अभी ये मेन हर्डल है, वो है सुपरस्टिशंस। तो जहाँ तक अचीवमेंट की बात है,
अचीवमेंट एंड बेस्ट प्रैक्टिसेस जो आपकी स्टेट में
ओके ओके, तो जहाँ तक अचीवमेंट की बात है, आई एम हाईली थैंकफुल टू आवर मेडिकल फ्रेटर्निटी, द ऑफिसर्स हु हैव टेकन ए वेरी सीरियस कंसर्न ओवर इट। आज हमारे स्टेट में हर मेडिकल कॉलेज, 7 मेडिकल कॉलेज हैं, सातों के सातों मेडिकल कॉलेज में फैक्टर अवेलेबल है। हमारे जितने भी जो जोनल हॉस्पिटल्स हैं वहाँ फैक्टर अवेलेबल है। और तो और वी आर प्रोवाइडिंग द फैक्टर replacement facility at the nearest medical center nearer to the patient's home, चाहे वो PSC है, चाहे वो सिविल हॉस्पिटल है, चाहे वो जोनल हॉस्पिटल है। हम आज हिमाचल प्रदेश में जो हेमोफिलिक्स है उनको ज़्यादा दूर नहीं जाना पड़ रहा है, उनके जो डोर स्टेप्स है 4-5 किलोमीटर के दूरी पर ही उनको जो है वो फैक्टर मिल रहा है। एक बहुत बड़ी अचीवमेंट हमारे लिए ये भी है, हमारे हिमाचल प्रदेश में हमने ऑल एज ग्रुप के लिए जो है वो एमिसिजुमैब, हेमलिब्रा जो नॉन फैक्टर थेरेपी है उसका जो है वो हमने प्रोजेक्ट शुरू किया है। हमने ईडीएल में जो है वो हर फैक्टर को, चाहे फैक्टर 8 है, फैक्टर 9 है, रिकम्बिनेंट है, प्लाज्मा ड्राइव्ड है, हमारा एमिसिजुमैब है, EHL है, हर तरह के जो फैक्टर है वो आज हमारे ईडीएल में है। और जो हमारा स्टेट जो डिपार्टमेंट है वो प्रोक्योर करना शुरू कर दिया।
ये सुनकर बड़ी खुशी हुई समर सिंह जी के जो ईडीएल के अंदर आपके सारे हीमोफीलिया की ट्रीटिंग ड्रग्स जो हैं अभी आ चुके हैं और सभी ड्रग्स की प्रोक्योरमेंट हो रही है।
थैंक यू।
और इससे भी खुशी वाली बात यह है कि जो आप कह रहे हैं कि हम कोशिश करते हैं कि हर व्यक्ति के घर के पास उसको ट्रीटमेंट सेंटर अवेलेबल हो ताकि वो जल्दी से जल्दी ट्रीटमेंट ले सके। दैट्स अ वेरी नाइस अचीवमेंट। एंड उसके बाद आपने बताया कि जो नया ड्रग है नॉन फैक्टर थेरेपीज है उसकी भी जो अडॉप्शन है वो आपकी स्टेट के अंदर शुरू हो चुकी है।
मैं आई एम हाईली थैंकफुल टू आवर स्टेट प्रोग्राम ऑफिसर डॉक्टर कविंदर लाल जी हु हैड टेकन ए वेरी गुड इनिशिएटिव रिगार्डिंग दिस फैक्टर ट्रीटमेंट। थैंक यू डॉक्टर कविंदर जी।
इसके बाद मैं रिक्वेस्ट करूंगा मिस्टर सैयद माजिद कादरी जी से, वो कश्मीर का जी श्योर। दीपक सिंघल जी कुछ पूछना चाहते हैं जी श्योर।
समर सिंह जी, आपने जो भी आपने बताया बहुत रिमार्केबल है हिमाचल प्रदेश के कॉन्टेक्स्ट में। आपने बात शुरू करी सुपरस्टिशन से लेके, जिसमें काफ़ी लेट स्टेज में कुछ पेशेंट्स डायग्नोज हुए। ये इसका सुपरस्टिशन के अलावा कुछ डायग्नोसिस से भी कंसर्न मेरे को लगता है। तो अगर हमारे पास हिमाचल प्रदेश जैसे बहुत बड़ी स्टेट नहीं है, 1 या 2 मेन सेंटर भी टेस्टिंग के रिगार्डिंग हो, तो मुझे लगता है कि थोड़ा सा ये सुपरस्टिशन से डायग्नोसिस की तरफ ज़्यादा जाएगा।
डेफिनेटली दीपक जी, ये बात मैं थोड़ा सा एक हमारा नेगेटिव पॉइंट है। जहाँ तक इसकी डायग्नोस्टिक की बात है, मैं ये कहना चाहूँगा कि इसमें अभी हमें और ज़्यादा अधिक काम करने की ज़रूरत है। हिमाचल प्रदेश में अभी कोई भी हमारा मेडिकल कॉलेज नहीं है, इवन की जो IGMC सबसे बड़ा हॉस्पिटल है वहाँ भी इसका जो फैक्टर ऐसे तक की फैसिलिटी नहीं है। और इवन की जो हमारा इनहिबिटर स्क्रीनिंग है वो भी हिमाचल में अभी तक जो है वो कहीं नहीं हो पा रही है। हमने मेडिकल अथॉरिटी और अपने जो पॉलिटिकल लीडर्स हैं उनके ध्यान में लाया है, हमने इनसे रिक्वेस्ट भी करी है कि डायग्नोस्टिक के ऊपर जो है वो थोड़ा सा और अधिक बेहतर काम करे ताकि हमारे जो पेशेंट हैं उन्हें दूसरी स्टेट जैसे PGI चंडीगढ़ या एम्स यहाँ नहीं जाना पड़े। ये तो एक कमी अभी है।
मेन पॉइंट है आपका कि आपको डायग्नोसिस पे थोड़ा सा वर्कअप करने की
बिल्कुल
आवश्यकता है।
बिल्कुल जी।
क्योंकि आपको अगर यही नहीं पता कि पेशेंट इनहिबिटर की तरफ चला गया है या कौन सा फैक्टर है, कई बार फैक्टर 8 की जगह फैक्टर 9 की जगह फैक्टर 8 पेशेंट को देना पड़ रहा है
जी।
क्योंकि वो प्रॉपर्ली डायग्नोज नहीं है। तो वो चीज़ होनी बहुत इंपॉर्टेंट है
जी। जहाँ तक मैंने सुपरस्टिशन की बात करी थी, जो
आपकी बात समझ रहा हूँ, क्योंकि मैं ये चीज़ हम
नहीं डेफिनेटली
फेस करते हैं पहाड़ी एरिया में।
जी।
मेरा कहने का केवल ये मतलब है कि इसका डायग्नोसिस से भी रिलेटेड है।
डेफिनेटली।
इसके बाद मैं रिक्वेस्ट करूंगा मिस्टर सैयद माजिद कादरी जी से कि वो कश्मीर के रिगार्डिंग बताएं कि क्या क्या दिक्कतें आ रही हैं आपके पेश, जो आपके सामने आ रही हैं, और क्या क्या बेस्ट प्रैक्टिसेस जो हैं अपनी स्टेट के अंदर जो हमारे बाकी स्टेट्स के अंदर भी लागू की जा सकती हैं।
दिक्कतें तो बहुत ज़्यादा थी यहाँ पर, जियोग्राफिकल स्टेटस के हिसाब से बहुत मुश्किल हो जाती थी पेशेंट्स को ट्रीटमेंट सेंटर तक आने में। तो मैं अगर पास में जाऊँ तो बहुत सी हमारे पास ऐसी लोगों की कहानियाँ हैं कि पेशेंट हॉस्पिटल पहुँचते पहुँचते उनकी डेथ भी हुई है, बहुत सारे पेशेंट्स की। लेकिन आज कल अगर मैं आपको बताऊं, हमने यहाँ पर जो, जैसे कि मैंने आपको बताया कि डॉक्टर बिरिशी उन दिनों थी जब उन्होंने एक डिसीजन लिया कोविड में कि हम पेशेंट्स को होम थेरेपी प्रोवाइड करेंगे, जिसको डॉक्टर बिलाल कंटिन्यू कर गए। उससे क्या हुआ कि हमने प्रेफर किया कि प्राइमरी हेल्थ सेंटर या डिस्ट्रिक्ट हॉस्पिटल के बजाय अगर हम इनको होम थेरेपी डोर स्टेप देंगे, ताकि पेशेंट जो अर्ली सिम्टम्स जो ब्लीड के रिकॉग्नाइज वो करता है, वो उसी टाइम फैक्टर लगाकर, वो एक तो फैक्टर जो कंजप्शन है वो कम हो जाएगी, और दूसरा ये कि उनको इमीडिएट ब्लीड स्टॉप हो जाएगा। वो कायम दायम अभी तक जारी है, वो बहुत ही बड़ी अचीवमेंट है हमारी। और उससे क्या हुआ कि उससे पेशेंट्स की लाइफ जो है ना वो चेंज हुई है। बाकी रहा सवाल बाकी जो ड्रग्स यहाँ पर है, ये
जो सॉरी टू इंटरप्ट, जो आपने जो होम थेरेपी स्टार्ट की है या आपने ट्रीटमेंट सभी पेशेंट्स को अवेलेबल कराया है, उसका मोर्टेलिटी रेट के ऊपर क्या असर हुआ है?
मैं वही आपको बता रहा हूँ, वही पहुँच रहा हूँ मैं। तो हमारे पास सारे ड्रग्स ऑलमोस्ट अवेलेबल है, जिनमें EHL फैक्टर 8 फैक्टर 9 भी है, एम्सुजुमैब भी है। तो पिछले 3 या 4 साल की अगर मैं बात करूं कि एक तो मोर्टेलिटी रेट जो है ना वो 0 पर आ गई, जो हर साल 4 से 5 हमारे पेशेंट मर जाते थे वो 0 पर आ गई। नंबर 2, मैं आपको बताऊं, एक तो मोर्टेलिटी रेट 0 पर आ गई, जो डिसेबिलिटी बढ़ रही थी पेशेंट्स में उसमें बहुत ही कमी वाक़या हुई है। नंबर 3, एक बहुत बड़ी अचीवमेंट, मतलब मुझे खुद भी यकीन नहीं आ रहा है कि 5 जो CNS ब्लीड्स हुई है पिछले 3 या 4 साल में, हमने नोट किया है, वो 5 के 5 सर्वाइव करके बहुत ही अच्छे तरीके से।
दैट्स अ वेरी नाइस अचीवमेंट के जो
जी, तो वो GMC श्रीनगर में ही गए। लेकिन उसके पीछे एफर्ट्स है, वो मैं ये कहता हूँ कि ये हर जगह होना चाहिए। उसके पीछे सबसे पहले एक अहम रोल है, एक कैरेक्टर है उसके पीछे, वो डॉक्टर बिलाल है। मैं आपको बताऊँ कुछ एग्जाम्पल। हमारे पेशेंट, एक करगिल का हमारा बच्चा था जिनको IC ब्लीड हुआ था, वो दूसरे दिन हॉस्पिटल पहुंचा, अनकॉन्शियस था किसी दूसरे हॉस्पिटल में, यानी सिक्किम में जहां इसका ट्रीटमेंट नहीं है या फैक्टर अवेलेबल नहीं है, वहीं एडमिट कराया। तो डॉक्टर बिलाल ने फ़ोन किया रात को मुझे कि आपका कोई पेशेंट वहाँ एडमिट किया गया, मुझे कॉल आई तो आप ज़रा देखो। तो जब मैंने देखा तो डॉक्टर बिलाल को मैंने डिटेल्स फराहम कर दी, ये कौन सा पेशेंट है, इनको क्या क्या प्रॉब्लम्स है। उन्होंने बोला फ़ौरन शिफ्ट करा, बल्कि खुद ही डॉक्टर बिलाल ने कांटेक्ट करके उनको शिफ्ट कराया। फिर जब SMHS उनको पहुंचाया गया तो उसके बाद डॉक्टर बिलाल ने उनको पीडियाट्रिक हॉस्पिटल शिफ्ट कराया। तो वो अनकॉन्शियस था, लेकिन 24 घंटे के बाद वो कॉन्शियस में आए और उसके बाद उन्हें रिकवरी की तरफ वो गए और रिकवर हुए। मतलब ये होता है, मैं आपको बता रहा हूँ, एफर्ट्स इसके पीछे तभी मुमकिन था, तभी वो बच गए। इसी तरह एक और पेशेंट जिनको IC ब्लीड हुआ था, और रात भर डॉक्टर बिलाल कॉल पर होते थे कि इनका IC, या किसी भी डॉक्टर को रात भर इंस्ट्रक्शन देते थे। एक पेशेंट की मैं बात करूं, इनहेबिटर पेशेंट था जिसको ये लाइफ थ्रेट ब्लीड हुआ, तो डॉक्टर बिलाल ने कॉल किया कि एक पेशेंट है आपका एडमिट इस टाइम और उसको लाइफ थ्रेट ब्लीड हुआ, वहाँ PGs है, उनको पता नहीं, मैं कांटेक्ट कर रहा हूँ HOD के साथ जो मेडिसिन के थे, तो मैं देखता हूँ। और तब तक उसको फैक्टर ही नहीं लगा था, क्योंकि उन डॉक्टर्स को पता ही नहीं था। वो इवनिंग में, लेट इवनिंग में नहीं बल्कि अर्ली इवनिंग में वो एडमिट हुए, और उसके बाद उनको फैक्टर ही नहीं लगा 2 बजे रात तक। जब डॉक्टर बिलाल ने इंटरवेन किया और 2 बजे रात उनको फैक्टर 7 लगवाया और वो भी बच गए। 5 हमारे पास है ऐसे पेशेंट्स, ऐसे केसेस जो बहुत मुश्किल था जिनका सर्वाइव करना, वो भी सर्वाइव कर गए हैं। इसके अलावा सर्जरीज जो है, डॉक्टर्स जो यहाँ पर हाथ लगाने से डरते थे, नहीं जी हीमोफीलिया, यानी इवन एक्सट्रैक्शन करना होता था दांत, तो वो भी नामुमकिन होता था पहले कि कोई हाथ लगाने के लिए तैयार नहीं होता था। आज इतनी सहूलियत और मुझे लगता है कम्प्रहेंसिव की तरफ बढ़ रहे हैं। तो 200 से करीब हमने सर्कमसेशंस भी यहाँ पर की, जो छोटे बच्चों को हम मुस्लिम रिलीजन के मुताबिक करते हैं, और बाकी छोटी मोटी सर्जरीज भी 5 से लेकर 6 यहाँ पर हुई और सारी सक्सेसफुल हुई है।
Any question from the chair?
वेरी नाइस माजिद जी,
थैंक यू।
बहुत अच्छा आपने अचीवमेंट बताया। आपने कहीं पर भी कोई शॉर्टकमिंग नहीं बताई कि अभी हमें कहाँ पर कमी महसूस हो रही है, आगे और क्या इसमें इम्प्रूवमेंट करते हैं। यू आर ब्लेसिंग ऑफ डॉक्टर बिलाल, और डॉक्टर बिलाल जिस तरह डे एंड नाइट वर्क कर रहे हैं, मतलब अगर डॉक्टर बिलाल चाहे 3 दिन की छुट्टी पे चले जाए तो मेरे ख्याल से काफ़ी दिक्कत भी हो सकती है
सर
तो थोड़ा सा मेरा कहने का मतलब ये है, वो चीज़ है, और आगे क्या शॉर्टकमिंग्स हैं जिसको हम इम्प्रूव कर सकते हैं, उस पर भी थोड़ा गौर करें।
पहले डॉक्टर बिलाल के बारे में मैं बताऊं, ये मुंबई में थे, वोकेशन पर थे। हमारे एक पेशेंट, नहीं, मैं पहले उसका, पहले मैं चाहता हूं कि उसका जवाब भी दे दूं कि अगर इनकेस आप ये वोकेशन पर होंगे, अल्लाह ताला इनको सलामत रखे, बस उसी सूरत में हम अदरवाइज 24 घंटे इनके साथ कांटेक्ट में। ये मुंबई में थे तो वोकेशन पर थे, हमारे एक पेशेंट को ब्लीड हुआ। पहले जब मैंने इनको कॉल किया, ये जहाज़ में थे तो ऑलमोस्ट स्विच ऑफ होने वाले थे मोबाइल, तो उन्होंने बोला क्या बात है, मैंने बोला सर ऐसी ऐसी बात। उन्होंने वहीं से थोड़ा इंस्ट्रक्शंस दी, लैंड जब किया अभी वो उतरे ही नहीं थे तो उन्होंने कॉल किया और यहाँ के डॉक्टर्स को कॉल की। एक पेशेंट उसको सीरियस ब्लीड हुई थी। जब रात की अंधेरियों में जब सब सोए हुए होते हैं, तब ये हमें फ़ोन करके जगाते हैं, आपका पेशेंट सीरियस है, उसको ये मसला है, क्या करना है, और बाकी डॉक्टर्स को बोलते हैं। तो हम कैसे ये सोच सकते हैं कि हम कभी इनसे छूट जाएंगे या डॉक्टर बिलाल। नंबर 2, आपने बहुत अच्छी बात की और आपने मुझे याद दिलाया, मैं बेहद शुक्रगुजार हूँ आपका, कि हर्डल्स क्या है। हर्डल्स सबसे पहले मैं आपको बताऊँ, जो हमारी रिक्वायर बजट होती है वो अगर हमें फुलफिल हो जाती तो पेशेंट्स की लाइफ वाकई में मज़ीद बदल सकती है। इसमें बीच में हमें ब्रेक आती है, जो वो ब्रेक आती है, चाहे वो जो मेडिकल सप्लाईज कॉरपोरेशन जो सप्लाई कर रहे हैं एंटी हीमोफिलिक ड्रग्स, उसमें ताख़ीर होता है, यानी टाइम लगता है, या प्रोक्योरमेंट में ऑर्डर्स एग्जीक्यूट करने में, या फंड कमिटमेंट में, या गवर्नमेंट जब तक फंड रिलीज़ करे, तो उस दौरान बहुत सफ़र करना पड़ता है हमें, बहुत ज़्यादा उस खौफ के साए में हमारे पेशेंट जो है वो ज़िंदगी गुजार रहे हैं। इस साल भी 3 महीने ऑलमोस्ट ये बीच में जो ब्रेक लगा, लेकिन उस दौरान हमने भी कुछ सोसाइटी के बिहार पर परचेज़ करके पेशेंट्स को दिया है। तो डॉक्टर बिलाल ने भी बहुत ही महारत के साथ उस जो एक किस्म का मैं समझता हूँ कि वो एक जंग थी, उसका मुकाबला किया। हम जीत गए, हम इंशाल्लाह जीत रहे हैं और कोशिश कर रहे हैं कि ये चीज़ें भी दूर हो जाए।
जैसे माजिद भाई ने बताया कि बेस्ट प्रैक्टिसेस जो जम्मू कश्मीर में जो फॉलो की जा रही हैं, इसके अलावा कुछ बेस्ट प्रैक्टिसेस मैं इनकी सोसाइटी की खुद बता देता हूँ। जैसे कि इनकी सोसाइटी ने अपनी एम्बुलेंस रखी हुई है, जिसके ज़रिए ये जो पेशेंट सिक होते हैं उनको ये ट्रांसफ़र करते हैं एक हॉस्पिटल से दूसरे हॉस्पिटल से। कहीं कोई पेशेंट घर पे है तो सोसाइटी को फ़ोन आ जाता है कि भाई हमारे पेशेंट को सीवियर ब्लीड हुआ है, आप इसको जल्दी से जल्दी ट्रीट कीजिए। या तो ये घर पे फैक्टर लेके या मेडिसिन लेके पहुंच जाते हैं, या उसको पेशेंट को ट्रांसफ़र करते हैं खुद ही सिविल हॉस्पिटल के अंदर, जहाँ पे मेडिकल कॉलेज के अंदर, जहाँ पे भी ट्रीटमेंट अवेलेबल होता है। दूसरी चीज़ जो सोसाइटी के लेवल पे ये कश्मीर में कर रहे हैं, जो कि वाकई काबिल तारीफ़ है, ये लगभग 40 से 50 बच्चों की एजुकेशन को स्पॉन्सर कर रहे हैं, विच इज़ अ वेरी बिग अचीवमेंट। जो हीमोफिलिक बच्चे हैं, जो जिनके पेरेंट्स जो फैमिली जो है वो एजुकेशन अफोर्ड नहीं कर पाती, उनको फाइनेंशियल सपोर्ट भी दे रहे हैं, आइडियोलॉजिकल सपोर्ट भी दे रहे हैं, मॉरल सपोर्ट भी दे रहे हैं, विच इज़ अ वेरी बिग अचीवमेंट ऑन योर पार्ट।
थैंक यू सो मच लार्सन साहब। और इसके अलावा हम मतलब हमारे मैक्सिमम पेशेंट्स जो है वो डेस्टिट्यूट है, उनकी कैसे हम हेल्प करते हैं मंथली बेसिस पर, या इवन दो बस फेयर भी उनको हम देते हैं। और बहुत सी ऐसी जिनको मैं गिनना नहीं चाहता हूँ, इवन दो कोई टेस्ट कोई मेडिसिन इसके अलावा फैक्टर के अलावा बाहर किसी को लेनी होती है तो वो हम ही उनको प्रोवाइड करते हैं सोसाइटी के बिहाफ पर, और हमें जो पब्लिक फंडिंग आती है तो उसमें से ये हम बेयर करते हैं। और इसके अलावा एक और थैंक यू डॉक्टर साहब, आपने याद दिलाया, एम्पावरमेंट स्कीम के तहत अपनी सोसाइटी में जो बहुत ज़्यादा गरीब थे, हीमोफीलिया, किसी के घर में 2 बच्चे 2 भाई हैं जो कमा नहीं पाते हैं, इनको हमने छोटे छोटे दुकान और दूसरी किस्म की बिजनेस को खड़ा करके दे दिया और उनको एम्पावर कर दिया है।
वो कहते हैं ना कि खुद ही को कर बुलंद इतना कि अल्लाह भी खुद बंदे से पूछे कि बता तेरी रज़ा क्या है। वो वाली बात है कि सोसाइटी ने अपने आप को, अपने खुद को इतना मजबूत कर रखा है कि गवर्नमेंट सपोर्ट के अलावा सोसाइटी भी बहुत सपोर्ट कर रही है पेशेंट्स की। इसके बाद मैं चाहूँगा डॉक्टर संदीप वर्मा से, वो बिलोंग्स टू पंजाब, कि वो पंजाब के एक्सपीरियंसेस को शेयर करें।
थैंक यू। पहले हर्डल बताऊं सर?
जी जी।
हर्डल्स पंजाब में हर्डल का जो स्पेलिंग है वो छोटा पड़ गया है, हर्डल ज़्यादा है। सबसे ज़्यादा तो हमें फैक्टर सप्लाई की बड़ी ज़बरदस्त दिक्कत है। और जो हमने प्रोग्राम ये स्टार्ट किया है BDCM कि जहाँ बेस्ट प्रैक्टिस हो रही है उसको हम अडॉप्ट करें। इसकी एग्जांपल भी हमने दे दी अपनी स्टेट में कि यहाँ इन्होंने ऐसा क्या किया, जिनका जोग्राफिकली एरिया इतना टफ है उसकी बदौलत बाद भी यहाँ मोर्टेलिटी रेट 0 हो गया है। लेकिन अनफॉर्चुनेटली हमारे पंजाब में 2 साल में 16 बच्चों की डेथ हो चुकी है और उसमें हम अपने आप को कसूरवार मानते हैं। ये सबसे बड़ी हमारी हर्डल है कि हम उनके लिए, हमारे भाइयों के लिए कुछ भी नहीं कर पाए। और ज़्यादा तो यही है, फैक्टर सप्लाई का इशू है। और जो हमारी बेस्ट अचीवमेंट है, 2014 से हम लगे हुए हैं। हमारी अचीवमेंट है, जैसे माजिद भाई ने बताया कि हमारे लिए फरिश्ते हैं डॉक्टर शेख बिलाल जी। हमने भी जो अचीव किए हैं वो फरिश्ते ही अचीव किए हैं, बाकी और तो कुछ अचीव कर नहीं पाए। हमने फरिश्ते अचीव किए सबसे पहले बाबा फरीद की रहमो करम से, फरीदकोट मेडिकल कॉलेज से डॉक्टर वरुण जी, डॉक्टर नीतू जी, पटियाला से डॉक्टर RPS सिबिया जी, लुधियाना से डॉक्टर जसकरण जी। और ये हमारी अचीवमेंट है। और ये ऐसी अचीवमेंट है कि कोई लफ्ज़ नहीं है, बस ये है कि खुदा के आगे हर समय ये अरदास रहती है कि इनको परमात्मा हमेशा सलामत रखे, इनको कोई कमी ना रहे। क्योंकि ये कई बार हमें शक हो जाता है कि इनको हमारी पेन की इतनी कैसे महसूसियत हो जाती है। कई बार शक हो जाता है कि कोई हीमोफीलिया वाला भी नहीं ये पेन ले सकता। और कभी भी फ़ोन कर लो, ऐसे नहीं है, रात को कर लो, जिस मर्जी टाइम कर लो। यही अचीवमेंट है। बाकी नेक्स्ट BDCM में देखेंगे कुछ चेंज होता हुआ, क्योंकि ये कहते हैं कि जो एक दुआ होती है ग्रुप में हो ना, वो हमेशा कबूल होती है। दुआ वो कबूल होती है जो दिल से होती है। मुश्किल ये है कि ये बड़ी मुश्किल से होती है। तो हम तो यही आपसे सबसे दुआ ही चाहेंगे कि आप कोई करिश्मा हो जाए, पंजाब में कुछ चेंज हो जाए। बाकी और अचीवमेंट सर मेरे को तो कोई दिख नहीं रही।
इसके बाद मैं रिक्वेस्ट करूंगा मिस्टर गोविंद शर्मा जी से कि वो पंजाब की अगर कोई अचीवमेंट उनको ध्यान में आती है तो बताएं, और कोई हर्डल्स जो संदीप भाई ने नहीं बताई उनके बारे में वो थोड़ी रोशनी डालें।
हर्डल्स जो है वो तो संदीप भाई ने बिल्कुल ठीक बताई। और अचीवमेंट में भी जैसे डॉक्टर संदीप जी ने बताया कि हमें फरिश्ते मिले हैं, तो सच में वो फरिश्ते ही हैं हमारे लिए। डॉक्टर वरुण और डॉक्टर नीतू इतनी पेन लेते हैं हीमोफिलिक पेशेंट्स के लिए कि रात को हम 1 बजे भी वरुण सर को कॉल कर देते हैं ना, तो सर उसी समय कॉल पिक करते हैं और उसके बाद उसका ट्रीटमेंट कैसे करना सब कुछ हमें समझा देते हैं। लास्ट एक हमारे पास कुछ दिन पहले एक IC ब्लीड केस आया था, तो सर को मैंने रात को 1 बजे कॉल किया और सर सुबह मेरे साथ 6:30 बजे तक फ़ोन पे टच रहे। बच्चे को संगरूर से हमने CMC शिफ्ट करवाया, फैक्टर तक सर ने वहाँ प्रोवाइड करवाए। तो हम तो यही दुआ मांगते हैं कि सर से कभी भी हमारा नाता ना टूटे। थैंक यू।
इसके बाद एनी क्वेश्चन फ्रॉम चेयर? उसके बाद मैं रिक्वेस्ट करूंगा मिस्टर वैभव नेहरा जी से, जो दिल्ली चैप्टर के अंदर सेक्रेटरी हैं एंड HFI के भी EC मेंबर हैं। वो प्लीज़, जैसे कि हम डिस्कस कर रहे हैं कि हर्डल्स क्या आ रही हैं और जो बेस्ट प्रैक्टिसेस हैं।
Thank you, Larson. My area has been limited to Delhi, क्योंकि दिल्ली का रिप्रेजेंटेटिव बोल के इस पैनल पे हूँ। दिल्ली जो है गलत नहीं होगा अगर कहें कि देश का दिल है। हर एक फील्ड में एक पायनियर की तरह दिल्ली रहा है, सिर्फ हेल्थ केयर में नहीं, एजुकेशन में और बहुत सारी चीज़ों में। और ख़ासकर नॉर्थ, ज़्यादातर नॉर्थ को दिल्ली इम्पैक्ट करता है। हीमोफीलिया के फील्ड में एक पैराडाइम शिफ्ट तब आया था जब गवर्नमेंट हॉस्पिटल्स ने हीमोफीलिया केयर प्रोवाइड करनी शुरू करी थी। उसके पहले जो एरा था, हीमोफीलिया सोसाइटीज़ जो हैं पेशेंट एडवोकेसी ग्रुप के साथ साथ हीमोफीलिया ट्रीटमेंट सेंटर्स का भी काम करती थी। तो उस वक्त तक भी जब जो हीमोफीलिया सोसाइटी दिल्ली थी, उसका जो हीमोफीलिया ट्रीटमेंट सेंटर था, इट वाज वन ऑफ द बिगेस्ट एंड मोस्ट इंपॉर्टेंट सेंटर्स in North India. After the shift, when hemophilia care became primary responsibility of government hospitals, उसके बाद भी दिल्ली ने एक पायनियर का रोल प्ले किया. Instead of the chapters hemophilia treatment center, the role shifted to hemophilia day care center at LNJP hospital, and we were very lucky to have Dr. Naresh Gupta as the head of that whole Delhi hemophilia program. And इतनी केयर उन्होंने करी है, many of the small kids, he has mentored them directly, including myself. मतलब जब भी हम उनसे मिलते थे, वो हालचाल भी पूछेंगे, कहाँ पहुँच गए हो, चाहे सालों बाद मिल रहे हैं, he would keep a track कि भाई where have I progressed in my career. Apart from that, Delhi was one of the first states where prophylaxis was made available, and उसके लिए alternative explore किए गए. I was one of the first kids who was given prophylaxis. That was under a clinical trial project. So that was again Dr. Naresh Gupta's initiative. क्योंकि कई बार क्या होता है, clinical trial के लिए center approval में the doctors here know there are many standards that have to be met. So the Delhi hospital, LNJP hospital, got the clinical trial. We had 5 patients who were put on a clinical trial, and we could see what kind of a great difference prophylaxis made to our lives. And thereafter, through the budgetary funding, जो उनका normal routine है, उसके through भी एक low dose prophylaxis program दिल्ली में शुरू किया गया. So most of the things, well, I don't need to really specify best practices of Delhi, because Delhi centers have played a very pivotal role in training many other centers, not just in North India, but all over. But हर जगह picture हमेशा रोजी नहीं होती है. Supply chain issues Delhi में भी हमें face करने को मिले हैं. Our doctors have always been very proactive. Whenever such things come, they go out of their normal routines to make sure that supply chain issues are rectified. But that is the biggest issue. Time to time we face factor procurement issues. And some recent achievements have been like recently we have been facing some supply chain issues in Delhi. तो recently एक दो cases हमारे पास ऐसे आए जहाँ बच्चे का PWH का सर्जरी करने की ज़रूरत थी, and we were facing the government centers were facing some issues. So in that case, what has happened is that a different number of organizations came together. The surgery happened at GB Pant Hospital. The dosage was finalized and taken care of by the Lok Nayak Hospital. The AHF was procured by the Hemophilia Society Delhi using the Hemophilia Federation India's humanitarian aid program. So 4 different organizations came together and were able to conduct successful surgery. तो recent achievement मैं इसको इसलिए बता रहा हूँ because achievement is overcoming the hurdle, and the hurdle was supply chain issues. So that is how we were able to get it done. So that is all from my
Thanks,
side.
Vaibhav. Very nice, informative minutes from you. The thing is that कि जैसे उन्होंने बताया कि coordination के लिए 4 different organizations ने coordinate करके एक सर्जरी को अंजाम दिया, which is a very positive thing. जो हीमोफीलिया के अंदर हम देखने को मिलती है हमें कि सभी लोग जो हैं वो अपना बेस्ट एफर्ट्स डालने की कोशिश करते हैं, भले वो डॉक्टर्स हैं, हीमोफीलिया सोसाइटी है या HFI है, और जो ट्रीटिंग डॉक्टर्स एंड द हॉस्पिटल्स, द स्टाफ इटसेल्फ, सभी के कॉपरेशन से जो आज हीमोफिलिक पेशेंट्स की लाइफ जो हम नियर नॉर्मल कह सकते हैं या नियर नॉर्मल करने की कोशिश कर रहे हैं, वो सभी के कॉपरेशन से चल रही है.
I actually want to I want to add just one more point in here. There is another initiative which Loknayak Hospital has taken up. And this is something which has not become prevalent right now, but is extremely required. LNJP has been testing mothers of PWH for factor levels, factor assays of mothers of PWH. And this is very important because we generally feel that women are not affected by hemophilia. Now in my own case, my sister, who is a doctor herself, and she is based in Berlin, in Germany, she had a surgery. And post-surgery, her internal bleeds would not stabilize. So her husband called me up कि भैया ऐसे ऐसे हो रहा है, वो दिक्कत उसको आ रही है. I immediately it clicked because I knew she is a carrier. So I told him, get her factor assay done. So they did her factor assay and she came out to be a mild hemophilic. So this is another thing which LNJP Hospital, the Hemophilia Daycare Center at Loknayak Hospital has been doing now. They have tested around 100 women, mothers of PWH, for factor levels. And they have also come up with positive cases. So that is another of our recent achievements.
थैंक यू वैभव. एक दिक्कत हमेशा आती है कि समय की कमी हो जाती है हमें. तो जैसे कि टाइमर चल रहा है पीछे, मुझे अभी जो इवेंट मैनेजर वो बता के भी गए हैं कि सर टाइमर का थोड़ा ध्यान रखना. तो समय कम होगा, तो इसलिए जो बाकी पैनलिस्ट हैं मैं चाहूँगा कि आप जो अपने विचार हैं वो थोड़ा जल्दी में दे दें, लेकिन जो मेन मेजर पॉइंट्स हैं वो कवर कर लें. इसके बाद मैं रिक्वेस्ट करूँगा मिस्टर संतोष जायसवाल जी से, जो कि झारखंड से हैं.
नमस्कार, जोहार, सलाम. मैं सबसे पहले कश्मीर अध्याय को धन्यवाद देता हूं, मजीद जी को धन्यवाद देता हूं कि आपने मुझे एक अवसर अपने राज्य के कार्यकलापों के बारे में बताने का अवसर दिया. झारखंड आप सभी जानते हैं, झारखंड का मतलब होता है झारखंड फॉरेस्ट, मीनिंग इसका होता है लैंड ऑफ फॉरेस्ट. तो हमारे यहाँ बहुत सारी कठिनाइयाँ थीं. 2000 के बाद कुछ सुधरी हैं और आगे भी सुधरेगी. झारखंड में 2014 से हमारे यहाँ फैक्टर्स अवेलेबल है. उस समय इंडिया में ब्लड प्रोडक्ट्स एंड रिकमेंडेड टेक्नोलॉजी दोनों की फैक्टर्स मिलते थे. मैं हमेशा L1 की बात नहीं करता हूँ, मैं हमेशा क्वालिटी 1 की बात करता हूँ, क्योंकि क्वालिटी 1 ही होता है जिससे अगर हम कंपेयर स्टडी करते हैं. क्योंकि मैं शोधार्थी हूँ, शोध का विद्यार्थी रहा हूँ, मैंने MPhil किया, PhD किया. तो मैं जब भी कोई किसी चीज़ पे गौर करता हूँ तो मैं उसकी कंपेयर स्टडी करता हूँ कि इसका बेनिफिट्स एंड लाभ एंड आउटकम क्या है. तो इसी दरमियान हम लोगों ने रिकमेंडेड टेक्नोलॉजी पे ज़्यादा जोर दिया और अजंता मुझे सरकार से फाइट भी करना पड़ा, एडमिनिस्ट्रेशन से फाइट करना पड़ा. उसके बाद अंतोगत्वा हमारे बीच रविंदर अरोड़ा जी बैठे हैं, BPL के हैं, वो भी थे उस समय मौजूद. लेकिन हम लोगों ने अंतोगत्वा वहाँ पे रिकमेंडेड टेक्नोलॉजी शुरू किया. जो फर्स्ट स्टेट हो भारत में है जो हम रिकमेंडेड टेक्नोलॉजी पे आए थे. कुछ दिनों के बाद हमारे यहाँ थर्ड जनरेशन आया. थर्ड जनरेशन भी हम भारत के पहला स्टेट हैं जहाँ हम थर्ड जनरेशन से शुरू किया. जब हम टेक्नोलॉजी की बात करते हैं तो हम वक्त के साथ चलते हैं. जब हम टेक्नोलॉजी के साथ चलते हैं तो उससे दो फायदे होते हैं. एक तो रोगियों का जो लाइफ स्टैंडर्ड है वो बढ़ जाता है और साथ ही साथ सरकार का बचत भी होता है अगर टोटली हम देखते हैं तो. अभी वर्तमान में थर्ड जनरेशन EHLs और अभी हमारे यहाँ नॉन फैक्टर थेरेपी आई. हमारे यहाँ बहुत अच्छी टीम है, मेडिकल टीम है. हमारे मैक्सिमम जो डॉक्टर्स हैं वो सोसाइटी से एसोसिएट हैं. मैंने एक डे केयर का कॉन्सेप्ट लाया था 2016 में. डे केयर का कॉन्सेप्ट हमारे यहाँ था कि हर डिस्ट्रिक्ट में डे केयर हो जहाँ पे एक ही छत के नीचे एक अच्छे वातावरण में, जहाँ बच्चे फैमिलियर आए, घर के वातावरण में टीवी लगा हो, AC लगा हो, खेलने का सामान हो, पेंटिंग्स बने हो और फिजियोथेरेपी की व्यवस्था हो और इस तरह की सारी सुविधा मौजूद हो जो एक डे केयर्स में होता हो. पेशेंट को कहीं मूव नहीं करना पड़े और हम लोगों ने पहला डे केयर रांची में शुरू किया, सदर अस्पताल रांची में, जो हम लोगों ने 10 बेड से शुरू किया था, आज 40 बेड का है और उसमें थैलेसीमिया, हेमोफीलिया का ट्रीटमेंट होता है। प्रभात कुमार सर जी हमारे यहाँ बीच बैठे हुए हैं, मैं उनको धन्यवाद देता हूँ कि उनके कार्यकलापों से, उनके कार्य प्रदर्शी से ये सुना। वो 5 डे केयर सेंटर्स के बाद आज 24 डे केयर सेंटर हमारे यहाँ है। मेरा एक ही मकसद है, भारत के हर जगह पे डिस्टेंस कम हो, टाइम मैनेजमेंट इसलिए होना ज़रूरी है, उससे 2 फायदे होते हैं। एक तो कम समय में अगर फैक्टर लगता है तो फैक्टर्स भी कम लगेंगे और कम बजट में हम ज़्यादा लोगों तक चिकित्सा की सुविधा पहुंचा पाएंगे। हमारे यहाँ मैं आपको बता रहा हूँ, मैं अभी हर जगह जहाँ जाता हूँ, मैं पे डायग्नोसिस पे बात होती है, हम डायग्नोसिस को देखते हैं। रांची चैप्टर एक ऐसा है चैप्टर से इंडिया का, जो हम 22 ईयर्स से फैक्टर ऐसे का वीरा उठाया है। हम सारा फैक्टर्स अपने यहाँ चैप्टर्स में टेस्ट करते हैं, एसटीसी में करवाते हैं, फैक्टर 8 हो 9 हो, वैतसेदा अभी शुरू करने वाले हैं। विथिन हम जेनेटिक्स डिपार्टमेंट ऑफ रिम्स के सहयोग से पीएनडी और सीडी भी शुरू करने जा रहे हैं। तो कहने का तात्पर्य है कि सरकार के यहाँ बहुत सारी सुविधाएं नहीं उपलब्ध होती हैं, तो ऐसी परिस्थिति में सोसाइटीज़ को भी आगे आनी चाहिए, जिससे हम पेशेंट को लाभ दे सकते हैं।
धन्यवाद।
आपको 14 महीने की बात की पहले की घटना है। हम एक कॉन्फ्रेंस में जा रहे थे, HFI मीटिंग्स में, तो मेरी दुर्घटना हो गई थी, मल्टीपल फ्रैक्चर्स हुए थे, जिसके कारण हम 1.5 साल तक बेड पे थे। हम यहाँ से वहाँ तक नहीं जा सकते थे, जो कि हम रेगुलर प्रोफिलैक्सिस ट्रीटमेंट में थे, लेकिन हमारी ब्रेक थ्रू ब्लीड्स हो जाती थी, जिसके कारण हमारा हीलिंग बहुत स्लो हो रहा था। ऑल ऑफ सडन हम लोगों ने एक बात की, हमारे बीच हेमंत जी भी बैठे हुए हैं, हम लोगों ने हेमंत जी और हम लोगों ने बात की, और नॉन फैक्टर की तरफ हम लोग कहें इम्यूनिज्म की तरफ, मैंने डॉक्टर प्रभात कुमार सर हैं हमारे बीच मौजूद हैं, मैंने उनको रिक्वेस्ट किया कि सर आप मुझे देखना अगर चाहते हैं तो मुझे ले आइए। आप एक बात आप सोचिए, जो आदमी पूरे स्टेट में घूम के हेमोफीलिया का डेवलपमेंट कर रहा हो, वो 1.5 साल से वो डेवलपमेंट रुक गया हो, हमारा डे केयर्स नहीं बढ़ रहे थे, बजट्स का प्रॉब्लम्स हो रहा था, तो ऐसी परिस्थिति में मुझे लगता था इससे बेटर मुझे अगर मैं मर ही जाता तो ज़्यादा बेटर था कि मैं 1.5 साल से मुझे अगर यहाँ से वहाँ तक उठाना हो तो किसी की ज़रूरत पड़ती है। मेरे बेटे की IIM कश्मीर में हुई थी, वो नहीं जा पाया, तो ऐसे बहुत सारी जो फैमिली प्रॉब्लम्स भी शुरू हो गए थे। तो मैंने इम्यूनिज्म शुरू किया, डॉक्टर प्रभात सर के सहयोग से हमने शुरुआत किया। तो मैंने बोला कि मैं अकेला नहीं लगाऊंगा, मैं 21 को शुरू करूंगा पहले। तो हमने 21 को शुरू किए, जो ज़्यादा क्रिटिकल्स कंडीशन थे। हम बोलेंगे हमें वक्त के साथ चलना चाहिए। इम्यूनिज्म लगाने के बाद मेरी जो ज़िंदगी बदल गई, वो जितने भी डॉक्टर्स हमारे टीम में थे सदर अस्पताल के, मैं लोडिंग डोज के बाद उठ के खड़ा होके तब चल के आया 4 कदम, तो लोगों ने कहा कि ये दवा क्या मैजिक है। तो मेरे कहने का बात मतलब यह है कि हमारे यहाँ दूसरी बात, हम 2 चीज़ को प्रकाश डालना चाहते हैं। हमें हर फैक्टर्स की ज़रूरत होती है, लेकिन टेक्नोलॉजी की भी ज़रूरत होती है। टेक्नोलॉजी की इसलिए ज़रूरत है, जब हमने कंपेयर स्टडी नरेश गुप्ता सर ने भी प्रेजेंट की थी रांची में, और प्रभात कुमार सर ने भी बनाई है। हम लोगों ने जब स्टडी किया प्रीवियस केसेस का, तो हम लोगों ने देखा क्या कि जो फैक्टर्स थेरेपी पे थे, फैक्टर्स 8 पे थे, उस पेशेंट्स का जब हम लोगों ने, हमारे यहाँ क्या है कि जो भी पेशेंट्स होते हैं उनको एक नोटबुक दिया जाता है, उसमें उनके सारे ट्रीटमेंट की चार्ट लिखी होती है, कितना फैक्टर्स कब लगा, क्या ब्लीड हुआ, पूरा उसका उसमें ब्यौरा होता है।
जसवाल जी सॉरी मैं आपको इंटरप्ट कर रहा हूँ 1 मिनट के लिए, सॉरी फॉर दैट। एक तो संदीप भाई ना हमेशा जब भी पंजाब में जाते हैं एडवोकेसी करने के लिए, वो एग्जांपल देते हैं, केरला का एग्जांपल देते हैं कि वो भाई केरला ने ये कर दिया, जम्मू कश्मीर ने ये कर दिया, हिमाचल ने ये कर दिया, उत्तराखंड ने ये कर दिया। अगली बार संदीप भाई आप जाओ तो एक झारखंड का एग्जांपल देना कि भाई पंजाब वाले अब क्या झारखंड से भी पीछे रहेंगे, ठीक है। और दूसरा, मैं जायसवाल सर को थोड़ा सा रोकता हूँ कि सर अभी जो आने वाला समय है, डॉक्टर वरुण कौल सर ने पंजाब में, और जो संदीप जी हैं और हमारे कुछ और प्रिय मित्रों ने मिलके जो नोटबुक वाला कॉन्सेप्ट है, इससे आगे चल के हम लोग जो है डिजिटल डायरी के ऊपर जा रहे हैं कि जितने भी डोजेज होंगे वो सारी डिजिटली नोट हो जाएंगे और जिस भी सेंटर से लगेगा उस सेंटर से पता चल जाएगा।
बिल्कुल बिल्कुल।
तो उससे पैसे की भी बचत होगी और जो कोई पेशेंट गलती से ज़्यादा लगवा रहा है तो उसको गाइड भी किया जा सकता है।
बिल्कुल बिल्कुल।
सॉरी
तो,
मैं आपको इंटरप्ट करके मैं क्योंकि समय की बहुत कमी है। जी जी।
तो हम लोगों ने जो कंपेयर स्टडी किया, आई एम सरप्राइज्ड दैट कि हम फैक्टर थेरेपी और नॉन फैक्टर थेरेपी का जब अध्ययन किया तो 60 और 40 का डिफरेंसेस पाया हमने। 60% पैसे कम लगते हैं अगर हम नॉन फैक्टर थेरेपी का ट्रीटमेंट करते हैं। तो मेरे कहने का मतलब है हमें सारी फैक्टर्स की ज़रूरत होती है। जो लेस देन 1% है, जो स्कूल गोइंग है, जिनकी स्थिति क्रिटिकल हो गई है, वैसे पेशेंट्स को हमें नॉन फैक्टर थेरेपी देनी चाहिए। थैंक यू।
स्टिक टू द स्टेट, स्टेट के बारे में एडवांटेजेस एंड डिसएडवांटेजेस।
चलो
सिर्फ स्टेट में, झारखंड में क्या हो रहा है?
झारखंड की बात ही कर रहा हूँ भाई मैं।
सर सॉरी टू इंटरप्ट बोथ ऑफ यू। जसवाल जी मैं सॉरी आपके साथ फिर बैठ के डिटेल में वार्तालाप करेंगे क्योंकि आपसे सीखने के लिए बहुत कुछ है। ठीक है, मैं अगले आपसे माफ़ी चाहते हुए अगले पैनलिस्ट पी हेमंत कुमार जी को कहना चाहूँगा कि वो अपनी स्टेट का एक्सपीरियंस शेयर करें इन अ वेरी कंसाइज मैनर।
सो मैं पहले हर्डिल से स्टार्ट करता हूँ। हमारा हर्डिल, पहला हर्डिल हमारा है कि हमारा एंगेज स्टेट है पूरा इंडिया में, 2014 में ही बना हुआ है तेलंगाना। तो हमारे पास दो बड़े हर्डिल हैं। एक तो डायग्नोसिस का, ऑल्दो हमारे पास प्रीमियर इंस्टीट्यूट्स लाइक सेंटर फॉर सेल्यूलर एंड मॉलिक्यूलर बायोलॉजी मौजूद हैं हैदराबाद में और निजाम इंस्टीट्यूट ऑफ मेडिकल साइंसेस और दूसरे भी हैं बहुत सारा सेंट्रल गवर्नमेंट ऑर्गेनाइजेशंस। सो वो लोग डायग्नोसिस EDPND डायग्नोसिस का एकेडमिक लेवल में कर रहे हैं, मास लेवल में अभी तक शुरू नहीं कर दिया। तो हमारे पेशेंट्स को KEM मुंबई नहीं तो CMC वेल्लूर जाना पड़ रहा है, ये एक बड़ी दिक्कत है। दूसरा चीज़ है कि मैंने पहले ही बोला है हमारा एंगेज स्टेट है, सबसे नया स्टेट है पूरा इंडिया में। तो डिस्ट्रिक्ट लेवल में हमारा जो मेडिकल कॉलेजेस हैं ना अभी अभी सेटअप हो रहा है हर एक डिस्ट्रिक्ट में। तो अभी वहाँ फैक्टर अवेलेबिलिटी आ रहा है और डे केयर सेंटर्स जो है ना वो डिस्ट्रिक्ट लेवल में अभी अवेलेबल नहीं है।
हेमंत कुमार जी कोई आपकी स्टेट की जो कोई अच्छी प्रैक्टिस हो जो भारत के लेवल के ऊपर फॉलो?
वो वही बोलने वाला हूँ, पहले हर्डिल से स्टार्ट कर रहा हूँ। तो हमारा अचीवमेंट्स के बारे में आऊँगा अभी। तो पहले अचीवमेंट है हमारा 2 साल पहले हमने प्रोफिलैक्सिस स्टार्ट किया है प्रोजेक्ट ट्रायल बेस में। तो अभी लगभग 150 पेशेंट्स को हमने ऑनबोर्ड किया है प्रोफिलैक्सिस में। जो पेशेंट्स प्रोफिलैक्सिस में आया है उनका क्वालिटी ऑफ लाइफ बहुत इंक्रीज़ हुआ है। इसमें नॉन फैक्टर थेरेपी अवेलेबल है एमिसुजुमैब का और 1 मिलीब्रांड भी है प्रोफिलैक्सिस में, EHL फैक्टर भी हैं और दूसरे प्रोडक्ट्स भी अवेलेबल है। सो हर प्रोडक्ट का प्रोफिलैक्सिस भी हमने लगवा दिया है। ये बच्चों को भी हैं और फ्रीक्वेंट ब्लीडर्स जो होते हैं ना उनको भी अवेलेबल करा दिया है हमने। मगर ये अभी 2 ही सेंटर्स में अवेलेबल है, 2 ही सिटीज़ में अवेलेबल है। एक तो हैदराबाद और दूसरा वारंगल में। दूसरे डिस्ट्रिक्ट हेडक्वार्टर्स में भी शुरू करने के लिए हम कोशिश कर रहे हैं। एक अचीवमेंट है हमारा। दूसरा अचीवमेंट है इसके पहले 2 साल पहले हमारे पास बहुत ज़्यादा मोर्टालिटी था। लाइक पंजाब में था 10-15 लोग मरते थे हर साल। अभी हम ये फैक्टर अवेलेबिलिटी 365 डेज अवेलेबल करने का कोशिश किया है। वी अचीव्ड ऑलमोस्ट दैट। सो उसके बाद अभी हमारे पास डेथ रेट 2-3 लोगों के से ज़्यादा नहीं है। ये अचीवमेंट
वेरी नाइस टू हियर हेमंत कुमार जी। मैं एक तो जो अपने इवेंट कोऑर्डिनेटरों से रिक्वेस्ट करूंगा कि हमारे सेशन के लिए हमारे कम 3-4 मिनट और बढ़ा दिए जाएं। ये टिकर को देख के थोड़ी सी दिल की धड़कन भी बढ़ती रहती है और मैं रिक्वेस्ट करूंगा कि हमें 4-5 मिनट बढ़ा दिए जाएं।
तो और
सर सॉरी टू इंटरप्ट, आई वांट टू मूव ऑन टू द नेक्स्ट पैनलिस्ट। या इसके बाद मैं रिक्वेस्ट करता हूँ मिस्टर आशुतोष शर्मा जी से कि वो नॉर्थ के अंदर हरियाणा के जो अपनी बेस्ट प्रैक्टिसेस हैं, जो हर्डल्स हैं, वो उसके बारे में थोड़ा प्रकाश डालें।
नमस्कार सभी को। सबसे पहले मैं कश्मीर सोसाइटी का धन्यवाद देना चाहूँगा कि इस बहुत बड़े ओकेज़न में हमें इनवाइट करा, और BDCM को एक जो फॉर्म है हमारी उसको बधाई देना चाहूँगा कि हम धीरे धीरे जो हमारी सोच थी वो आगे बढ़ रही है। और आप सभी को मैं ये बताना चाहूँगा कि हमारे हरियाणा में बेस्ट प्रैक्टिस में ये चल रहा है कि फैक्टर की जो अवेलेबिलिटी है वो 22 हमारे जो डिस्ट्रिक्ट सेंटर्स हैं हरियाणा में, वहाँ पर 24/7 अवेलेबल रहते हैं। और दूसरा ये है कि पहले हमारे हरियाणा में नोडल्स को इतनी नॉलेज नहीं थी एक्टिव हीमोफीलिया के बारे में। तो जब से हमने CME स्टार्ट करी है, उसका सीक्वेंस स्टार्ट वगैरह हमने सीरीज स्टार्ट करी है एक CMA की हमारे ब्लड सेल के साथ में मिलके, तब से हमारे नोडल भी आइडेंटिफाई करने लगे कि हीमोफिलिक्स और हीमोफीलिया का ट्रीटमेंट कैसे करना चाहिए। ये हमारी बिग अचीवमेंट है, जिससे हम ये सोचते हैं कि हमारा एक फेज़ 1 की ओर हम कंप्लीट कर रहे हैं हमारा, जिसमें मेडिसिन है और आपका डॉक्टर अवेयरनेस, पेशेंट अवेयरनेस के साथ चल रहा है। हर्डल हमारी ये है कि अभी हमारे जो जितने भी पेशेंट्स हैं उसमें 30 to 40% पेशेंट जो हैं वो बेड रिडन की ओर भी जा रहे हैं, बेड रिडन होते जा रहे हैं। लैक्स ऑफ फिजियोथेरेपी सेंटर अभी हमारे डेवलप नहीं हो पाए हैं, और जो 80 बोन है, 80 बोन जो हैं वो गोइंग टू बी हैंडीकैप्स होते जा रहे हैं, फिजिकल हैंडीकैप्स ना। तो उस पर हमारा ये हर्डल है कि हम उनको कैसे उनको दोबारा मेन स्ट्रीम में लाएं, कैसे उनको आगे प्रोग्रेस कर पाएँ। और एक हमारा दूसरा हर्डल ये है कि हमारा कॉम्प्रहेंसिव केयर यूनिट्स, यानी कि सीरियस ब्लीड जब हो जाता है पेशेंट्स को या कोई सर्जरी रिक्वायर्ड है, तो उसके लिए हमारे लिए डेडिकेट सेंटर नहीं है हरियाणा में। उसकी ओर हम एडवोकेसी कर रहे हैं अपने सिस्टम के साथ बैठ के, उसको कैसे ऑर्गेनाइज करा जाए, कैसे एक डेडिकेट सेंटर बनाया जाए, इस पर हम काम कर रहे हैं।
थैंक यू आशुतोष जी,
थैंक यू सर।
वेरी नाइस टू हियर कि 24/7 अवेलेबिलिटी है मेडिसिन की, और CMEs भी आप अच्छी तरीके से कर रहे हैं। इसके बाद मिस्टर आकाश कोहली जी को मैं रिक्वेस्ट करूंगा कि वो जम्मू रीजन के बारे में जो बेस्ट प्रैक्टिसेस हैं, जो हर्डल्स हैं, उसके बारे में हमें बताएं।
थैंक यू सर। सबसे पहले मैं धन्यवाद करूंगा कश्मीर सोसाइटी का, और जिन्होंने आज इतना सबसे पहले मैं धन्यवाद करूंगा कश्मीर सोसाइटी का, जिन्होंने इतनी अच्छी तरह से ये ऑर्गेनाइज़ किया प्रोग्राम। उसके बाद मैं हर्डल की बात करूंगा जम्मू में। तो जम्मू में 2014 से हम फैक्टर लेना शुरू किया था, और उस समय हमें इतना ज़्यादा नॉलेज नहीं था इस प्रोग्राम के बारे में कि फैक्टर्स कैसे यूज़ करते हैं और इस फैक्टर्स का इफ़ेक्ट कैसे होता है। तो मैं धन्यवाद करता हूँ डॉक्टर के कोल सर का, जो इस समय हमारे बीच में उपस्थित है। अगर ये उस टाइम पे अवेयरनेस प्रोग्राम नहीं देते और इन्होंने 1-to-1 बुला के अपने ऑफिस में हमें पर्सनली गाइड किया कि इसको कैसे यूज़ करना है, इसको किस तरह से इसका इफ़ेक्ट हो सकता है, और इनकी टेस्टिंग के बारे में किस तरह से इन्होंने फ़ाइट की है, बाहर से बुला के ट्रीटमेंट सेंटर्स को, और वहाँ पे जाके हमारे प्रोफ्लैक्सिस को डायग्नोज करने के लिए सपोर्ट किया। फिर उसके बाद हमारा हर्डल्स आज दिन तक चल ही जा रहा है। हमारे हर्डल्स बहुत ज़्यादा हैं, क्योंकि हमारे जम्मू में डायग्नोस्टिक आज भी प्रॉपरली नहीं है, जिस वजह से हमारे जो पेशेंट हैं वो डायग्नोज ही नहीं हो पा रहे। आज भी हमें सपोर्ट लेनी पड़ रही है बाहर से टीम्स की, जो जम्मू में आके इस चीज़ को डायग्नोज करने के लिए आते हैं। और फैक्टर की बात करें तो हमारे पास फैक्टर्स अनअवेलेबल रहते हैं, पिछले 3 से 4 महीने हो गए हैं। हमें आज भी फैक्टर्स की शॉर्टेज रहती है। वो सप्लाई मैनेजमेंट जो हमारी JKMSL है, और या फिर हमारी जो भी एजेंसीज़ हैं गवर्नमेंट की, जिसकी वजह से हमें प्रॉब्लम आज भी फेस करनी पड़ रही है कि फैक्टर्स आज भी नहीं हमें प्रॉपरली मिल पाते। और उसके बाद एक हर्डल और बड़ी इंपॉर्टेंट है कि डिस्ट्रिक्ट वाइज हमारा ट्रीटमेंट आज भी नहीं पहुंच पा रहा है हॉस्पिटल में, जिसकी वजह से हमारे यहाँ पे डिस्टेंस बहुत ज़्यादा है, क्योंकि हिल्स हैं यहाँ पे बहुत ज़्यादा, और पेशेंट एक जगह से हॉस्पिटल में पहुँचना बहुत दिक्कत होती है, और रात को फ़ोन करते हैं, ना ही उनके पास ट्रांसपोर्ट होती है, और बहुत सारे किलोमीटर तक उनको पैदल चल के पहाड़ों से नीचे उतरना पड़ता है। तो वो एक बहुत मेजर हर्डल है कि जो डिस्ट्रिक्ट वाइज हॉस्पिटल में ट्रीटमेंट नहीं पहुंच रहा है, और पेशेंट का डिसेबिलिटी लेवल ज़्यादा बढ़ गया है कि जो उनको प्रॉब्लम फेस करनी पड़ रही है।
कोहली जी धन्यवाद, आपके बताई हुई सारी बातों पे हमने गौर किया, सभी पैनलिस्ट ने और सभी जो हमारे डॉक्टर्स हैं, जो यहाँ पे एस्टीम्ड गेस्ट्स हैं, सभी ने सभी बातों को बड़े गौर से सुना। मैं एक बात कहनी चाहता हूँ पंजाबी में कि साढ़े कोल दो कोल ने, साढ़े कोल दो कोल ने, एक वरुण कौल जी ने, एक के कौल जी ने। सभी पैनलिस्ट का मैं धन्यवाद करना चाहता हूँ। इट वाज अ वेरी फ्रूटफुल डिस्कशन। इसके बाद मैं चेयरपर्सन ऑफ द डिस्कशन मिस्टर प्रेम रूप अलवा जी को रिक्वेस्ट करूँगा कि वो इसको कंक्लूड करें।
This was a very exciting session. ये सेशन में हमारा इंडिया का डाइवर्सिटी वी कैन मेक आउट। सी स्ट्रेंथ्स भी पता लग जाता है, डाइवर्सिटी पता लग जाता है, मगर एक कॉमन चीज जो है is the relationship the patient and the patient body has with the doctors, and together how they have strengthened the state. हमारा मानना है, and what you have said is that जब patients, bureaucrats, patient bodies, doctors और industry वाले साथ में आ जाते हैं, anything is possible. Fantastic things, multidisciplinary care. There is a lot of learning for each state in the audience and here, that multidisciplinary एक जगह पे surgery हो रहा है, एक जगह पे women with bleeding disorders are being thing. Diagnosis is strong in some places, weak in some places. That's something which we will be going every year. We'll get better and better. One of the common hurdles is it's very evident that the states which are not progressed to the new generation products, यानी कि EHL and non-factor therapy, वो बहुत struggle कर रहे हैं. So the time has come that we have to talk about prophylaxis, like what you started. So there should be a time when you feel that hemophilia is not there. So that will happen only with prophylactic, with better product. Santosh said very well, quality versus price. I think we are in a good state. We'll have to go forward and keep improving. Thank you so much for all the panelists. Fantastic discussion.
Thanks, Prem.
I want to say a lot of things, but in time.
Since there is paucity of time, I request the stage coordinator, Dr. Sonia, to take over.
लार्सन जी, एक चीज़ मैं बोलना चाहूँगा। आपने बोला यहाँ पे कि ऐसा होना चाहिए कि हीमोफीलिया ख़त्म हो जाए, लेकिन मेरा ऐसा मानना है कि जिस क्वालिटी के प्रोडक्ट्स आ रहे हैं, जिस तरह का ट्रीटमेंट हमारे पास आ रहा है, आदमी देख के सोचे कि ये एक्चुअल में हीमोफीलिक है। लार्सन हीमोफीलिक है क्या? लगता नहीं है मेरे को हीमोफीलिक। तो हम उस स्टेज पे पहुँचे, तो दैट विल बी बेस्ट अचीवमेंट।
दैट्स द बेस्ट आइडियल सिनेरियो दैट वी आर।
जो हमने इन पैनलिस्ट से देखा है, एक कॉमन प्रॉब्लम है रेगुलरिटी ऑफ फैक्टर अवेलेबिलिटी। वो एक बहुत इंपॉर्टेंट चीज़ है। 24/7 365 days फैक्टर अवेलेबिलिटी शुड बी देयर। तो एक भी पेशेंट के साथ कैजुअलिटी नहीं होगी, कोई और दिक्कत नहीं है। थैंक यू सो मच।
थैंक्स अ लॉट एवरीबॉडी। थैंक्स अ लॉट।
And the sharing of the knowledge among the patients and then contacting the doctors is very important. That should be the first criteria to solve all these hurdles and other things.
Absolutely right. Absolutely right.
And first thing is, we are missing is, take the factor dose as early as possible. Going to the government hospital, waiting up to there is difficult. So they must be able to have at least one dose at their home.
मैंने एक बार डॉक्टर साहब के पास गया था, तो जैसा कि व्हेन इन डाउट इन्फ्यूज, जैसा आपने बोला कि इसको मैं समराइज कर देता हूँ कि जब भी डाउट हो सबसे पहले इन्फ्यूज करो।
Thank you, chairpersons, co-chair, panelist, and moderator, for your expertise in guiding us through this session. highlighting the importance of diagnosis and the need to overcome the various hurdles. Your insight and thoughtful moderation has enriched the session. For the next session, Changing Landscape of Hemophilia in India, Taking Cognizance and Preparing to Meet the Future Challenges, I request the chairperson, Dr. K.K. Cole, to take his place at the stage. I request the co-chairpersons of the session, Dr. R.P.S. Sibya and Dr. Neetu Kukar, to join the chairpersons. I request the chairperson, Dr. K.K. Cole, to kindly introduce the panelist and the moderator for this session.
Good evening. Now I will request, this is a very interesting, I think the event manager will again be requested to extend the session. Changing landscape of hemophilia in India. Very appropriately thought the theme of this event, keeping in view the totally changed scenario of hemophilia care which we are witnessing today. What we are doing and what we have been successful while dealing with hemophilia cases, we couldn't have imagined some 30 or 40 years back. We are entering in the era where we are progressing gradually towards the cure of hemophilia. Gene therapy, we are seeing coming shortly because one of the trials has started at CMC Vellore, but yet this will take time and many miles to go before we can sleep. I will call the panelist, Dr. Seema Sharma. Please do come. Dr. Ajit Kumar. Dr. Kumar. Dr. Sonal Shah. Yeah. Dr. Jaskiran Singh. Dr. Altaf Hussain Kambe. And Dr. Geetanjali Jindal. Now I will request the stalwart from Punjab, Guru Gobind Singh Government Medical College, Professor of Pediatrics, Dr. Varun Kaul, to be here. I may add one more sentence, that if somebody asks to a teacher, what is your assets? I will always say that students like Dr. Varun are my assets. I am very proud that he has achieved in a few years because of his dedication, commitment, and the depth of knowledge. And he is hardworking. Thank you, audience. Please, Dr. Varun, go ahead.
Thank you very much, sir. And it's a pleasure always coming to Kashmir. ये मेरी जन्म भूमि है. कर्म भूमि पंजाब बन गई, but जन्म भूमि मेरी कश्मीर ही है. So गर फिरदौस बर रुए ज़मीन अस्त, हमी अस्त, हमी अस्त, हमी अस्त. So this is said for Kashmir by Amir Khusro, and all of you are here and welcome to my birthplace. So thanks to Bilal sir, Ruby ma'am, and HHC and Dr. Naresh sir for giving me this opportunity to host this session for this particular session for changing landscape, and my teachers. So my teachers, my compatriots, my colleagues, and my seniors who are here to guide me and support me always. So we'll go with this changing landscape of hemophilia in India, taking cognizance and preparing to meet future challenges. मेरा काम बहुत आसान कर दिया पिछले पैनल ने. मैं कोशिश करूंगा कि हम हिंदी में ही बात करें, हिंदी उर्दू मिला के, ताकि सबको बात समझ आए. So क्या challenges हैं, कैसे हम हीमोफीलिया में आगे बढ़ सकते हैं, कहाँ पे हमारी स्पीड कम हो जाती है. जैसे नरेश सर बोलते हैं ना कि बुलेट ट्रेन हर जगह शुरू तो हो जाती है, बट कहीं ना कहीं उसमें वो ब्रेक लगती है. सो ब्रेक्स ना लगे और ये बुलेट ट्रेन फुल स्पीड में शिनकानसेन, what we call in Japan. So it runs in the same speed all over India. That is why we are here for this BDCM. So ये program was designed actually for the northern states, so that we can have a consensus for north. But I believe आज का ये सारा समागम देख के मुझे लग रहा है पूरे के पूरे इंडिया यहाँ पे है, and we can have this as a national platform meeting in the coming times also. Thank you very much for being here. So our panelists for the day, as it's not moving. It's not moving. The slides are not moving. Yeah. So panelists for the day, जैसे सर ने पहले बोला, डॉक्टर गुतांजलि मैम है, she is professor in pediatrics in GMCH 32. Dr. Sonal Shah, she is additional professor in pediatrics from MP Shah Government Medical College, Jamnagar. Then we have Dr. Seema Sharma. She is a professor and head of the Department of Pediatrics at RPGMC Tanda. So, ma'am, I was also there in Tanda, but not in the SRship. My wife was there, Sandesh. So, when Pankaj was there, I was also coming and going. So, I was in Jammu. So, so I know you from that time, Dr. Sanjeev Chaudhary. And Dr. Jaskaran Singh Bhasin, so he is one of our stalwarts in hemophilia in Punjab, and he is taking forward the baton, which we have all planned, and we want that all of you should take lead in these cases. So challenges are many. Challenges are many, what we have seen. So every portion of these 5 things is a challenge in itself. So how do we see all these challenges one by one? So may I take the first question to Sonal Shah ma'am, that the diagnostic challenges seen in hemophilia, what are your takes on this particular question? Can we have the mic, please?
So, thank you very much for inviting me as panelist. हिंदी में बात करें. हाँ. So, सबसे बड़ा चैलेंज डायग्नोस्टिक में है कि हमारे पर्टिकुलरली मैं गुजरात स्टेट की बात कर रही हूँ, तो डायग्नोस्टिक में लाइक फैक्टर 8 ऐसे, फैक्टर 9 ऐसे इनिबिटर कोई भी गवर्नमेंट मेडिकल कॉलेज सेटअप में अवेलेबल नहीं है. सो मतलब वी कैनॉट टेस्ट बियॉन्ड PT and APTT. So that is the biggest problem. So what we do, we like coordinate with the Hemophilia Society, the companies, the like CSR, and we like when we come across this kind of patient where we suspect, we outsource this thing. So that is the biggest challenge. Then another challenge is when the patients are diagnosed, after that screening for inhibitors. So वो भी एक सबसे बड़ी चैलेंज है. सो वो भी है. और तीसरी चैलेंज जो अभी पहले सेशन में भी बताई थी, एंटीनेटल डायग्नोसिस, बिकॉज मेरा सबसे बड़ा कंसर्न मैंने पहले भी रेज किया हुआ है, एंटीनेटल डायग्नोसिस. क्यों मदर कैरियर है पता है, बट बच्चे का एंटीनेटल डायग्नोसिस में भी दिक्कत आ रही है, क्योंकि हमारे PNDT की वजह से हम मेल फीमेल की पता नहीं कर सकते, इसलिए फीमेल बेबीज़ है तो भी और मेल जो भी है हमें मतलब उसका टेस्ट ही करना है, वो फ्रीली अवेलेबल नहीं है. ऑफ कोर्स प्राइवेट लेबोरेटरीज में सब जगह अवेलेबल है, बट उसके लिए पेशेंट्स दे हैव टू पे. सो वी हैव टू डू समथिंग. So these are all the biggest challenges, and plus we need to set up the labs, state level labs or center of excellence, where we can send these patients and get the things tested.
Thank you, ma'am, for a lucid explanation. Dr. Jaskaran, can I have your take on this, please?
Sir, basically the problems what we are suffering from, कि जैसे सर machines हैं, we are having the machines for checking doing all the coagulation tests. Even we are having the machine that does the factor assays. What we are lacking is the lack of reagents that are not available. So if we अगर हमें मिल जाते हैं वो reagents मिल जाते हैं, तो मतलब we can do factor assays at our district hospitals also. So that would be much easier.
So yeah, please, ma'am.
हमारे स्टेट में वही प्रॉब्लम कि डायग्नोस्टिक फैसिलिटी नहीं है, बट एमईसीजू में भी अवेलेबल इन प्लेंटी ऑफ अमाउंट, एंड यू कैन मतलब गिव टू ईच एंड एवरी पेशेंट्स ऑफ हीमोफीलिया. इतने लिबरली अवेलेबल है एमईसीजू में, पर डायग्नोस्टिक फैसिलिटी नहीं है.
That's nice to hear, ma'am. But I would like to comment upon this. Can I have any comments from Dr. Seema also? Yes. Exactly. We can send you some patients, ma'am.
Actually, in our state, again, we are facing the same difficulty. हमारे apart from coagulation profile, again, we are not doing Bethesda assay, we are not doing factor analysis. तो अगर कोई patient आता है तो either private labs or we need to send them to PGI. तो लेकिन हाँ, जिनको भी start करना है, it's after the diagnosis always.
Okay.
ऐसे नहीं करते हैं. तो लेकिन we do send them to if they can afford तो private labs में जाते हैं. But yes, what I feel is at least 2 centers should be there.
Yeah. So sir wants to say.
I will speak in English because Dr. Varun told both in English and Hindi. And at Delhi, whenever we have a national level conference on thalassemia, we request everyone to talk in English. So I will talk this English, Hindi as well as. This is a fact. लेकिन सबसे बड़ा ज़रूरी फैक्ट मैं आपको ये बताऊं कि अवेयरनेस अमंग द डॉक्टर्स, सर्जन्स, गायनेकोलॉजिस्ट, ऑर्थोपेडिशियंस, इनके लिए बहुत ही इम्पोर्टेंस है अबाउट दीज टेस्ट. What is the awareness? PT भेज दो, CT कर दो, bleeding time कर दो, LFTs and all. The concept of an accurate interpretation of APTT is not there. Okay? With the result, mild and moderate hemophilic are missed. They are only detected when they undergo some emergency surgeries, laparotomies, surgery is done, then the call goes to the surgeon, the patient is bleeding, he is going into shock. Then again blame comes to the pathology department. आपने PT ठीक नहीं किया, PTINR नहीं किया ये. Again that thing is repeated. But the basic thing, आपने APTT नहीं किया है, so you have missed this. Regarding APTT, जो ये reagents के बात बताते, availability of reagents is not that difficult. Procurement of a standard reagent is that which is important. You may get varieties of reagents, but they are not sensitive to the deficiencies of the level of factor 8 or 9. Some reagents which can only show prolonged results which are only up to 15%, up to 20%. But what about those who have 25% of factor 8 or 9? You are not able to. There are proper guidelines to procure these reagents, and those guidelines should be, in letter and spirit, they should be followed. So this is one issue. The other issue is, if we, in primary care centers, PT, APTT कोई बहुत बड़ी बात नहीं है. Coglometer नहीं भी आता है तो manually you can do it if you are here. But question again is, PT normal, APTT prolonged. So what is your diagnosis? और उस वक्त क्या करोगे? यही सोचोगे कि commonest is हीमोफीलिया ए, तो अगर अवेलेबल है तो दे दो जी, हिट एंड ट्रायल कर लो फैक्टर. नो. कैन देयर बी वन मोर टेस्ट विच वी कैन स्टार्ट at the periphery level so that we are able to distinguish factor 8, factor 9 deficient, factor 10 deficient, factor 11 deficient, factor 5 deficient. Sometimes we have combined deficiencies. So what that test we can do, which a qualified, trained technician can do it at primary health center. Is there any test? From audience, Department of Pathology postgraduates. I am talking about thromboplastin generation. Yes. Thromboplastin generation test, there are two stages. First stage is you have to form the prothrombinase complex. The second stage is to see the adequacy of that. So accordingly, if PT is normal, APTT prolonged, TGT shows plasma defect, you are sure you are dealing with factor 8 deficiency. PT normal, APTT prolonged, and TGT test shows serum defect, you are sure that you are dealing with factor 9 deficiency. PT and APTT prolonged. And then it could be either. What you have to see. Those are the issues. Okay? So, if the patient, sometimes you have 11 deficiency and 12 deficiency. What can differentiate between factor 11 and factor 12? If patient is bleeding, it is factor 11. Yes. If patient is not bleeding, even if APTT is prolonged, forget it. It is factor 12. So these are certain issues, and we can make it. This is not a huge or something big test that a technician cannot do it. This is my.
Thank you very much, sir, for the comments. And I would like to.
I just want to add.
Yeah, sure, sir.
It was an excellent synopsis from a great teacher.
Exactly, sir.
Excellent one.
Exactly.
It was like a teaching. You relearn so many things about pathology and other things also.
Yeah.
Now, the question comes to my mind. Sir has said that you need to know the hemophilics before they undergo before they undergo surgery. Now, there are consensus guidelines, there are set parameters. A 25-year-old going for an appendicectomy, who would do bleeding test and clotting test? I won't. A 50-year-old female going for a knee replacement surgery, would I do her bleeding test? If the guidelines are, if there is no history of bleeding in the past in that individual, doing these tests is absolutely not required. Unfortunately, there would be cases, few and far between. I remember 12 or 13 years back, a young medical representative going for some abdominal surgery at Ambala, and he bled like anything, and he was diagnosed as a de novo mutation, having hemophilia A at that point of time. But unfortunately, I shall not order everybody to undergo PTI, APTT, fibrinogen levels in all these cases. Why would I? I wouldn't. If there is no history of bleeding in the past. Yes, if there is history that he bled a lot while he was extracting his molars or something like that, a history of excessive bleeding after some trauma, then you need to do a complete hemogram. Yeah. You need to do not only a PT and APTT and then do those things, then you need to do a fibrinogen also and everything else also.
Absolutely.
And secondly, if the PT and APTTs both are prolonged, if you are in Punjab, think of chronic liver disease first and foremost.
Exactly.
Well, here we have to, understand that mild and moderate hemophilic will not bleed, and they don't have spontaneous bleeding.
So,
They remain undiagnosed for a long time. Yes, only fortunate people who meet an accident or had a fall, only that time they will be. And what about those who undergo surgeries who have not received any kind of trauma? And it is a medical legal case against surgeons also that you have not done an appropriate. We are talking about prenatal diagnosis. We are not able to find out mild and moderate cases with a simple test. What about prenatal diagnosis?
Sir,
this
I'll
is
come on to this, sir. So recently we had one patient, 67-year-old male. He went, knee joint replacement. So he was operated in one of the premier cities in Punjab, I'll not name, in a good institute, private institute, and he developed swelling, and the blood was constantly oozing. And previously, ISTH BAT was absolutely normal, and they did not do any preliminary screening tests, probably just PTI. They did not do an APTT. And this patient went to another premier city, and the orthopedician over there said that there is something they have done in the knee joint which needs again re-exploration. So again re-explored, took out that hematoma, went back again had the bleeding persisting, got an APTT done which was prolonged, turned out to be 12.7% mild hemophilia. So, this is recent, sir, just 4 or 5 days back. And we are now giving him factor support. So 67-year-old, no prior history, and
Now, my question is, why at all they order a PTA for that patient?
That is the problem, sir.
Why at all
That
why
is the
they order
problem.
a PTA?
That is the
Absolutely
problem,
no
sir.
need.
That is the problem, sir. So, so this is something which is important. Now, second diagnostic challenge which we see is the coagulation tests are not as easy as sir was saying. There is a lot of nitty-gritties involved. So, if a lab is doing a coagulation test, they should preferably enroll for an EQUAS program. So EQUAS is an external quality assurance system wherein you get the tests repeated, or you get the test plasma from a good institute who have a very good coagulation lab. So EQUAS is being run by CMC Vellore. So, you can have their samples tested in your coagulation lab, and they give you the results and tell you your percentage accuracy. So where you are lacking. So we in Faridkot are doing tests. We are doing assays, factor 8, factor 9, von Willebrand, and we are doing PTI, APTT. So we don't have, unfortunately, an EQUAS in place. But yes, with PGI, we are comparing our reports with PGI. So inhibitor screening we are doing. So it is almost at par with PGI. So, but we are very soon going to enroll in EQUAS also with CMC Vellore. Yes, sir. Sir, Mike, sir.
Samagam in the meeting, because in every case, even if there is any guideline, European guideline, American guideline, ASS guideline, any type of guideline, as guideline, it should be included. In my experience, it is in guideline, if preoperative, you must have prothrombin time activated for APTT screening, even the platelet count before doing surgery. I have lost many patients by doing this type of mistake, orthopedic surgery, or even cholecystectomy, appendectomy. In other cases also, especially in the case of hemophilia. So this message we go in the audience that you must have PT, APTT mandatory in a preoperative assessment of the patient, and how to do PT, it is very challenging, sir. To do PT, APTT karna, diagnostic karna science hai. To treat the patient is arts, some combination of science also. मेरा जो एक्सपीरियंस है कि मैं हाइब्रिड टाइप का हेमेटोलॉजी में दोनों काम करता हूँ, मैं ये कह सकता हूँ कि ये बहुत डिफिकल्ट बात है कि रिएजेंट का प्रोक्योरमेंट करना, रिएजेंट स्टोरेज रखना, उसको 2 to 8 पर -20 पर कब रखना, -40 पर कर रहा है, रिएजेंट टेक्नीशियन कितने एक्सपर्ट हैं कि डॉक्टर लोगों का पीपीटी में प्रॉब्लम हो, उसमें उस पर भी ध्यान देने की जरूरत है. केवल आप मेडिसिन लिख दीजिए तो बहुत आर्ट्स है, पेशेंट से बात करना और आर्ट्स है. सो PTFT must be done before any preoperative, not in hemophilic patient or hemophilic relatives. In general all patients. So this message should be
Thank you.
this should be consensus meeting, and it is my request, experience, just I have shared.
Thank you very much, sir. Thanks for your feedback. So, as is said by Sir Dr. Robert Hutchinson, from inability to let well alone and from making the cure of the disease more grievous than endurance of the same, good Lord deliver us. So, वो सीधी सी बात यही बोलते हैं कि अगर ठीक नहीं कर सकते तो खराब मत करो. So, periphery में यही problem होती है that they take a decision and then they decide कि वो ठीक था कि नहीं था. So take a decision which is in the interest of patient. That is very important. So primum non nocere should be our dictum, right? Now, Dr. Gitanjali, can you tell me what are the various therapeutic options available for the treatment of hemophilia right now, and what has changed with the advent of newer therapies, including gene therapy?
Thank you, Dr. Kaul. So when treatment of hemophilia we started basically with the blood products. So initially we started patients on fresh frozen plasma, and thereafter came cryoprecipitate when the knowledge came that factor VIII is in more amounts in fresh frozen plasma than cryoprecipitate. So most of the patients who are maybe we can say of our age have gone through this phase when they have received only FFPs and cryo for the treatment of hemophilia A and B. And though it could raise the factor levels to adequate amount to prevent bleeds, in some of the cases, not all of the cases, we had an ample amount of patients who went into viral infections or so. So this is not the best option, definitely. And then came the advent of factor replacement therapy when the factor concentrates became available for factor 8 and 9. And it started with the low purity first, second and third generation. We have gone to high purity where solvent detergent methods have been used and double purification is used for factor replacement. And now the newer one, recombinant factor products are also available. So we are now having in our kitty the plasma derived as well as the high purity plasma derived factors as well as the recombinant factors. So both of these are good enough in case of for any viral infections. Both of them are good enough. They will not spread the infections to the recipients. And then there are another added advantages of extended half-life products which are available with us. So like in the patients who are put on prophylaxis, we used to give multiple doses of factors to the patients, like thrice weekly or twice weekly or weekly in case of factor 9. So now with extended half-life products, we can extend the in-between gap of the treatments of our patients and reduce the number of visits to almost 7 to 10 days in case of factor 9 and around twice weekly in case of factor 8. So extended half-life products are also now available. And the newer therapies which have come up are the non-factor therapies, like which ma'am has already said that they have ample amount of emicizumab. So this is the newest non-factor therapy which is available, which raises the procoagulant level and increases the decreases the chances of bleed. And the benefit is it is subcutaneous and can be given even monthly to the patients. And the latest one is gene therapy, which is still under research, and it is still not available to our patients in the clinical setup.
Thank you, ma'am. Thank you very much. Yeah, Dr. Sonal wants to add.
मैं ऐसा बोल सकती हूँ कि मैं जब I had seen the whole journey of hemophilia being treated. When I was a resident doctor, we used to give FFP, cryoprecipitate, and we have seen patients becoming disabled, and they are now in 25, 30 years of age. And now, since last 1.5 years, since the emicizumab is available, I had started in 12 patients with inhibitor, and now we can say that they are they run, jump, play cricket, everything, and now they also say that we think that we had hemophilia, the patients had hemophilia, so we have seen the whole journey, and now totally the quality of the life of the patient has totally changed. We can say that because now they can go to school, अच्छे से जा सकते हैं, खेल सकते हैं, दौड़ते हैं, सब कुछ कर लेते हैं. मतलब those are with inhibitor patients. So and now I think disability has become a thing of past. So that's what I can say.
Yeah, Dr. Gitanjali, please. She wants to add.
I must congratulate ma'am for giving emicizumab to the patients. But we must have in our kitty Novo 7, bypassing agents like recombinant factor 7A and APCC, because these are also required in addition to the non-factor therapy sometimes, even in hemophilia A patients, and more required in hemophilia B patients. So all these factor therapies should be there in the kitty of a state so that we can decide which one to put on which patient.
I had started in non-inhibitor patient who is a child of 7-month-old, and child had head injury twice because he used to fall down and from the bed and twice, but not a single episode of bleed. So excellent. Right now child is around 2 years old and absolutely normal. Not a single bleeding episode. Occasionally, sometimes he gets bleeding occasionally from the nose. That's why whenever he gets cold or something,
Thank you,
he
ma'am.
gets occasionally
Thank you, ma'am. Thank you for your data and what you are sharing. And it's heartening to see that you are doing a wonderful job. But
Dr.
as
Kaul, मैं थोड़ा सा एक बात कहना चाहता था इसमें कि as far as hemophilia is concerned, diagnosis कोई मुश्किल नहीं है, and the lack is on maybe our part.
Exactly.
We are not able to recognize, especially the pediatrician. हम तो medicine वाले हैं, हमारे पास तो most of the time पकी पकाई आती है ना? So we need to educate the MBBS graduates who are sitting in the periphery to keep this in mind, that this is not septic arthritis. This is not septic arthritis. This is not, and adults also, medicine people also, we get so many cases कि सर इसको atypical RA हो गया है ना, single joint involvement, इसको retar हो गया है. So we must drill into their minds that hemophilia should be considered in all mono or oligo-articular pathologies.
Absolutely,
This is
sir.
most important thing.
Absolutely, sir.
Diagnose तो बिल्कुल भी मुश्किल नहीं है, 2 टेस्ट कराओगे, 1 टेस्ट कराओगे, आ जाएगा.
Sir, actually,
And the other thing is that the treatment part is also very easy, I would say.
Exactly.
ये नहीं है कि जैसे हम लोग हार्ट फेलियर ट्रीट कर रहे हैं, CKD ट्रीट कर रहे हैं, कभी क्या हो गया, कभी किडनी उड़ गई, कभी उसका लिवर का प्रॉब्लम आ गया है. I mean, बहुत साफ सुथरे केस हो सकते हैं ये.
Exactly.
The line of treatment, जो guidelines आप सब लोगों ने बनाई हैं, they're very easy to follow. Problem is of logistics, diagnostics and logistics. And to my mind, it's the financial problem which is the first and foremost thing. If we somehow can convince the government to give us these simple modalities, बहुत पैसे शायद नहीं भी लगते हैं, as compared to वो गवर्नमेंट बात करती है lakhs of crores में, हम तो कुछ करोड़ की बात करेंगे. If they are able to provide that, I mean, things can become very easy. I'd like to have the painless view on it. हम लोग जो diagnose करते हैं, जैसे आप लोग pediatrician आप लोग देखते हो patient को VSD with failure आ गया, congenital stenotic heart disease आ गई, हमारे पास cirrhotic with HCC आ गया, HR hepatorenal failure आ गया. So those cases are much more difficult to treat. It is not a problem कि doctor treat नहीं कर सकता ये. डॉक्टर तो बड़ी इजीली ट्रीट कर सकता है. आई मीन दिस इज वन ऑफ द इजीएस्ट ट्रीटमेंट आई कैन एवर थिंक ऑफ. मुझे कभी आज तक इतने हमारे पास 140-150 पेशेंट है, मुझे आज तक कभी किसी ने फ़ोन नहीं किया कि सर बता दो इसमें क्या करना है. नेवर आई हैव गॉट अ कॉल. इवन माय रेजिडेंट फर्स्ट ईयर रेजिडेंट नोट्स एवरीथिंग के ये आ गया जी, ये लगा हुआ है चार्ट, इतना दे देना, बात खत्म. सो आई वुड लाइक टू हैव अ पेनलेस व्यू ऑफ दिस कि हमारी मेन हर्डल्स हैं क्या इसमें. मेरे ख्याल में जो ये 2 ही आ रही हैं, तीसरी मेरे ख्याल में आ नहीं रही है.
आई थिंक सर हमें ना ऑर्थोपेडिशियंस को भी सर एजुकेट
You also
करना चाहिए.
Okay.
Yeah. Because
the thing is that you are absolutely right. The thing is, to my knowledge, the biggest test for diagnosing bleeding and bleeding disorders is the history.
History, yes.
History is the biggest test. It is said that what mind doesn't know, eyes can't see. So if you don't have that differential in your mind, that a patient comes with a swelling knee or sometimes pain abdomen, or epistaxis, or bleeding, or menorrhagia, whatever. So if the clinician doesn't have that sense of having the concept of coagulation cascade, or primary hemostasis or secondary hemostasis, so he has to ask the question, So the thing is, unfortunately, our surgeons are still asking for BDCT, which is an obsolete term. So BDCT should be abandoned. It is only for the platelets and primary hemostasis. And when you are going for the surgery, don't go for the BDCT. Don't go for this platelet. Go for the PD and APTT, which is very much. And even in our setup, it's a tertiary care center. Still our surgeons are writing PT INR. They are omitting APT.
Sorry to say. Tertiary care institution.
That thing has to be.
मैं खुद मानता हूँ मैं मतलब for the last 4 years I am delivering lectures to almost the entire state. तो मैंने सब कुछ कवर कर दिया. आज तक hemophiliac टच नहीं किया मैंने. My fault also. So let us all say that we are going to educate our postgraduates in all specialties, especially pediatrics, medicine, orthopedics, and the right branches. Gynecology. So let us all make our undergraduates also aware about this pathology. वो restricted pathology के बाद पढ़ने के बाद second year third year के बाद कोई hemophilia discuss नहीं करता है.
Sir, I would just like to make a brief comment. Sorry, sir, to interrupt. Actually, before the new NMC curriculum was introduced, we used to have 2 lectures of thalassemia and 2 lectures of hemophilia in pediatrics. Now it has been decreased to just 40 minutes for thalassemia and 40 minutes for hemophilia. So in 40 minutes covering hemophilia or thalassemia is...
For that matter, NMC ना जो है जो guidelines है ये बंदे बैठे हैं SPM, pharmacology, anatomy. हाँ तो वो थोड़ा सा ना NMC is I mean हमारे तो यहाँ पे इतनी बड़ी चीजें उड़ा दी myopathy, myositis, cardiomyopathy सब कुछ खत्म कर दिया उधर. But I would request you not to go by those guidelines. Guidelines are always meant to guide us.
Exactly, sir. But sir, the lectures have to be divided like that.
We have to
anyways.
adjust ourselves according to that. I hope Dr. Atri will share my view with you.
Only 15 lectures, main focus on anemia prevention program.
Yes.
The hemophilia is totally out. The malignancy is totally out actually. So
They
the
have
subject
totally,
is restricted actually. So we have to take the practical classes just for their awareness actually. Otherwise,
Yeah.
if we go to theory is the great limitation now. A new syllabus in the NMC. No thrombocytopenia, no hemophilia, no lymphoma, no myeloma, no leukemia. And then it is the hematology.
You see, ये हाल पूरी hematology का है.
हाँ सर, पूरी hematology का, बिल्कुल.
How many lectures we take in hematology at undergraduate level? And then in medicine. You see, hematology is a very important, and they say there are certain lesions, but I can tell you that hematology is most embarrassing subject. In Jammu, they had deleted thalassemia in dental colleges. The Dental Council of India, they deleted it. When I got the syllabus, I objected to it, wrote to the university and the concerned one. I said that orofacial and craniofacial deformities are the characteristic features of thalassemia. How you can ignore this important topic to dental students? What are you talking? And then I had to give them the lecture to the Vice Chancellor, to the Controller, and the concern. And they had to change it. They added this topic on my repeated request. The question is, hematology is being taught very little, number one. At the same time, hematology questions are asked very little in examinations as well, except in Jammu when I was there. Hematology used. The same is the awareness about the diagnosis of leukemias. Forget about bleeding disorders. The only thing which they remember later on that somebody says, AML blast or lymphoblast, यार एक ही होता है. That is why these are the situations. Pathology department is this, I define pathology not by the medical researchers or the stalwarts. I define pathology. जिस तरह एक किसी वाज़वान में आप नमक मत डालिए, उसको निकाल दीजिए. I don't think कोई भी चखेगा उस वाज़वान. You make so tasty dishes without salt. So pathology is the basic thing. We have to strengthen the pathology.
Absolutely, sir. So,
a very close cooperation between pathology and allied departments, है ना?
Absolutely, sir.
नहीं तो all the time क्या हो जाता है, PGs वो गलत मलत sample लेके भेज देते हैं, फिर वो pathology वाले हमें गुस्सा होते रहते हैं, है ना? Always get a stinker from the pathology department, ये क्या भेज रखा है?
So
ये तो clot ही नहीं कर रहा है.
So we have got a tinkerbell already from the organizers. Yeah, we are going too slow actually. So.
There's a sunshine too. Arthritis is a topic which we are supposed to cover in pediatrics, and we are covering hemophilia in that. We can do that.
Okay, wonderful, ma'am.
So even biochemistry people are teaching thalassemia also, and they are doing vertical integration according to
Anemia.
the new NMC
AIT,
curriculum.
anemia AIT. We do it.
Yeah,
We have
they,
selected a
do
thalassemia case
call
only,
the
ma'am.
pediatric people for teaching thalassemia.
Yeah, ma'am. That's a thalassemia
And-
case we have integrated in that
And we have
AIT
a full
only.
lecture on hemophilia also.
As per the
Theory lecture.
Like in my institute, for all surgeries, they go for coagulation profile, and before going for surgery. I mean,
That's wonderful.
this is for all the cases. That is, sir, PT, APTT. We go up to that, yes, sir.
Ma'am,
Yes.
actually, before taking a major.
That's what I have seen, I have observed. Details I can give you later on. Yes, sir, that is for all the surgical cases. That's my observation. No, sir, for surgical. Surgical. I mean, it's for OBG also, it's for ortho also, it's for surgery also. Sir, details I can share, like, I don't know the details, but for all the surgeries, they do this test.
So for this, for the sake of time, can we just like take the questions
Yes,
later on?
This was a message for the madam from Gujarat. He forgot to tell him, but he told me. When you were saying we have plenty of emicizumab, तो इन्होंने फौरन मेरे कान में कहा थोड़े से मुझे भी दिलवा दे पंजाब के लिए.
Oh. So, when we talk of the antegrade steps, so there are some retrograde steps which have happened. So, Dr. Jaskaran, can you just briefly take us through the latest WHO statement on the essential drug list vis-a-vis clotting factor replacement?
Basically, what has happened is that what we are using now, we are using clotting factor concentrates. But WHO has added cryoprecipitate in the core medicine list, and CFCs as an alternative therapy. So, yeah, basically they are going backwards.
They are going backwards.
Yeah.
This is absolutely, I think, badly thought.
So
We
in
should
India,
go
thankfully,
for
we are
non-factor
not
therapies.
affected by this dictum. So this is probably true for the African countries, wherein they don't even have the components. They are giving whole blood to their patients. So probably there it is more of importance. So best modality of treatment, just one word, ma'am. Dr. Seema.
I would say, I can't say one actually. It's a basket full of complete therapeutic range. Some require some. But in present day, I would say it's emicizumab. But sometimes they need FIBA. And some people, they require EHL. And again, it depends on state to state, what is available with them. And they have to go accordingly, what they have actually.
Dr. Sonal will differ from you, exactly.
So it's always prophylaxis, best treatment, either available non-factor prophylaxis. If factors are not available, emicizumab is not available, then factor 8 prophylaxis. So it has to be prophylaxis because even before availability of emicizumab, we were giving prophylaxis, factor VIII prophylaxis for almost 5 to 6 years. We had continued even during the COVID time also, and like the bleeding rate was so low, and not a single patient has become like developed any deformity or joint problem or anything. So it is always prophylaxis, factor or non-factor, depending on the availability
So
in
because,
your.
because this forum is meant for the administrators, so I would like to put in a word over here. We should desist from using the word prophylaxis, ma'am. So we should use the term regular replacement therapy, because once you talk prophylaxis, they understand this kind of vaccination. क्या है, एक बार लगाया, तो regular prophylaxis काहे को? So regular replacement therapy is probably the best word we should use while using this term. And one more thing, so persons with hemophilia B would like to have some difference over here. So Prem is here, so he'll say, भाई मेरे साथ नाइंसाफी हो रही है. So they are probably.
Yeah. So basically, sir, regular replacement therapy ही sir देनी चाहिए हैगी है. Either in the form of CFCs or in the form of non-factor therapy like emicizumab. So the thing is कि उनको अगर regularly मिलता रहेगा, so they will not bleed. So अगर वो bleed नहीं करेंगे तो वो अपनी normal life जी रहे हैं, जैसे एक normal human being जीता है.
Absolutely. So question to.
We have started like emicizumab in low dose. So as recommended, we are not right now giving 6 mg per kg. We are just giving 3 mg per kg once a month. But still, no one is like bleeding. So initially I used to give 6 mg per kg, but after interaction with the experts, then since last 6 months I have decreased the dose so that we can have the enough supply. But there is no intermittent bleeding or nothing is there, even after decreasing the dose. 6 months, low dose. And 6 mg per kg I was using, I am using since last 1.5 years. So 1 year 6 mg per kg, now 6 months we have decreased to 3 mg per kg. So
there will be always a threat of life-threatening bleed, because you will have it. Even if one patient develops it, it is a tragedy.
But you must have enrolled in some program. There must be some study going on.
Yeah, we are conducting the study, and it's a state level study. It is going on. Yeah, it is going on.
Must have been approved by the ethical committee.
So,
yeah, it's.
Sir wants to come in. Yeah.
Yes, yes.
Why did you take the decision?
So that
you have
we
plenty of emicizumab.
Yeah, but
State
so that.
government is providing.
Yeah.
No, I'm not talking about against low dose therapy intermediate. I'm not against that. You do whatever you like. What made you do it? You wanted to save money for government?
See, basically, so that patients can get it for a longer period, we can save on the dose. I know it is available for freely, and we can started now. We have enrolling the patients without inhibitor also, so we can accommodate them also. So that and last time when I think NHU or somewhere we had discussed that, and people have agreed even 3 mg per kg is good enough to, and since last 6 months I have not faced any patients with bleeding. And previously before emicizumab they used to bleed so much.
So,
it's a state level study going on.
Sir,
There are
I would like to come in on this, sir. So there was a paper published by Dr. Rucha. So she is from ICMR, and there was a collaborative study between KEM and ICMR. So they have done both the drug levels as well as the effect with the help of newer generation thrombin generation assays like TEG and ROTEM. So they have seen that the effect remains, but not to the tune of higher trough levels. So usually when we talk of full dose, it's 16 to 20%. So they are talking of around 10%. So it's still mild. It is still mild. But as Sir rightly said, that there is always a chance of life-threatening bleeds, especially those in inhibitors. So we should avoid lowering the dose in inhibitor-positive patients. Rather than for the non-inhibitors, we can think of probably after the initial loading.
One patient had developed minor bleed. So in that patient, I had shifted to 6 mg per kg. So that's what.
It's a dynamic changing thing. So.
What has been the trough level?
So that is impossible.
So emicizumab levels are not.
That will tell you the protection level of your study. without that, I don't think how the committee has approved.
So if we go theoretically, sir, so 16% it goes to 8%.
No. My teacher, Dr. Arya, used to always say that having studied all the books, always remember one thing. Every patient is not a textbook.
Exactly. Yes.
This you must remember.
So why are we not able to give RRT to all, regular replacement therapy, Dr. Seema? If it is the standard of care, regular replacement therapy, why we are not able to give to all?
Sir, again, it's a logistic issue. All are not having it.
It's going on, ma'am, please.
So it's a logistic issue basically. In certain states, yes. Like in my state, in last 4-5 months, there's a sea change. Now we are having everything on EDL. But previously we were not having. But again, like what I've seen in the last session, like most of the states, they are having so many constraints. So that's the main reason actually. That's what I think.
So budgetary
That's one.
constraints, as Dr. Sibi already put it in two simple words, that it's just the logistic, the budgetary constraints and the knowledge dissemination.
Yes,
so if
and
these two
this-
things are there, then there is no, prevention.
And the second reason what I feel is the separate budget should be there. If the budget is there, then the regular supply, even I think we are going to face it. The regular supply requires, the dedicated budget towards the hemophilia.
Absolutely.
That is not there.
So Dr. Gitanjali, are we ready to face the challenge of one nation, one treatment,
So that
in
is
this?
the ideal situation. We must strive for it, but I think we are still far away from that because state is a health is a state subject, and every state has its different policies of different budget allocation and different kitty of factors and non-factor therapies which is available. And though we are all in this forum agreeing for the profile factor regular replacement therapy, but still we are not able to procure it. Even at my center, I am still not able to procure the regular replacement therapy for my patients, not the non-factor therapy also. So definitely it is the thing which we should aim for, and we have a national program also for blood disorders. So maybe we can, I don't know what is, we should strive for it, but still I think we are far away from it.
So the priority right now, yeah, Dr. Parul, ma'am.
Sir, one question, sir.
Yes, please, sir. So Dr. Parul is professor in medicine from GMRS Ahmedabad.
End of your completion is because the budget matters comes, I cannot stop myself to stop telling my comments, because NHM from Government of India, they allot equal grant to all the states. The things is that the observation of them are like this, okay, there is an underuse of the grant given to the state, and this is they are going to audit also as well. So these are the some things they are doing to do for this thing, that it utilize adequately for the patient. The important thing that doctors should have a knowledge how to utilize it, and they have a capacity to convince the authorities. So I think budget and all these things are not an issue. That is what I feel. The only thing is that some of the states or some of the doctor or somewhere there is a lack of communication. All are ready to work. That is why we are here today. Only thing there is some communication gap. So I think one nation, one treatment policy is definitely possible. That is what I want to say. Thank you.
Little bit different from you actually regarding NHM. I am from Haryana. We requested so many times to NHM. NHM never give the budget to our medical colleges. And what is the reason? Because there are so many other medical colleges. Their excuse is if we have to give budget to your medical college, we have to give the budget to other medical colleges also, where there are no specialists. So I will say still the primary or the main challenge is budgetary constraint. That is a primary. Rest of the reason are secondary. Whether it's awareness is there, logistics is there, are secondaries actually. Main is budget. Sir is sitting in the Dr. Sibia in the Punjab. The government is not giving budget. Only factors are there. There are no MSUJF. There are no like FIBA and 7 also. I think for few months only it might be available. So main reason is budget, budget and budget. Everywhere it is the problem.
So same question for the panelists. If given a choice, what one challenge out of all discussed challenges would you want to straight away address? Doxy.
Same, regular supply of
For
factors.
regular supply, you
Madam,
need Maya.
I'm Dr. Prasad from Vijayawada. If you give emicimab, even for inhibitor or non-inhibitor patients, if there is a breakthrough bleed, how to manage? You have to give factor 8 if there is a non-inhibitor, or if it is a inhibitor patient, factor 7. Because how to measure the strength of the clot with emicimab, already he has taken.
So, like the patients who are with inhibitor and they are on 12 patients are there and they are on emicizumab since last 1.5 year, and there is not a single incidence of breakthrough bleed, I can say that. So, and but right now, till now, I have not faced. I had faced one minor bleed problem, but that subsided just without any giving. It was not required because it stopped within few hours.
If
only.
there is some trauma or major incident.
Yeah, we give factor 7. We have factor 7 supply also. So we do that. We do the factor 7.
And then how to assess the strength of the emicizumab clot? Already started the process. And how much dose of factor 7 we have to give?
Sir, yeah, it's usually we do the clinical assessment. We can't have the.
But emicizumab already created a clot. Is there any risk of thromboembolic?
So right now, till now, no
So not with factor 7, not with factor 7, but yes, we try to give the lower dose. We give lower dose and they respond, sir. So we had some patients who developed bleeding because of trauma. So we gave them just one dose of 45 microgram per kg and they responded beautifully. So with this, I would like to thank all my panelists. We have already overshooted our time and Dr. Bilal is looking at me. Please stop. So I would like to have our chairpersons for the final comments. Thank you, sir.
Yes, thank you, Dr. Varun and esteemed panelists. I think the job of Punjab is being shortly taken care of by the trial which the Ahmedabad has started. If that is possible and successful, half of the factors will go to the Punjab.
I think challenges start from the very beginning in hemophilia. That is, Dr. Bilal has said, it should start from the history. That is one of the important points. First point of diagnosis is history. Then in diagnosis, as everybody said, before operation, we should always go for PTI and APTT. Both are must. BT and CT are obsolete tests. These are not required at all. Third one is diagnosis. Once it's diagnosed, then we should go for the factor study. Then what is the percentage of factors? Then after that, if it's detected, then after that, inhibitor studies. If inhibitors are there, then we need to know about the treatment part. Which all treatment we need to give, whether we need to give factors, whether we need to give factor 8, 9, factor 7 or emicizumab. This is the all challenges are at all levels. We need to face them carefully and treat the hemophilia patients.
I think the biggest challenge still would be for us because these diagnostic centers and availability of these factors is mainly in cities. It is not available in the other areas. One, and the home therapy is absolutely this time very rare. And if we are able to, solve these two problems.
So we believe if Srinagar can do it, we all can do, because Srinagar is giving home therapy since last 5 years. Yes. Thank you. So we can have one quick photograph and then we can leave. So otherwise they'll just.
Faculty who are going to check out tomorrow are requested to please check out early morning at the time of breakfast. And one more request that it takes minimum of 3 hours to reach the airport because there's a lot of traffic jam. 1 hour for the traffic and 2 hours to be at the airport because of security checks at the airport. So please consider that when you're leaving for the airport.
So just one word from our Andhra colleagues. So Andhra Pradesh was saying that when they were in the panel discussion, so they are giving 10,000 rupees as maintenance therapy, maintenance money for all the patients with bleeding disorders, including sickle cell, per month.
Thank you to the chairpersons, co-chairs and panelists and moderators for such an knowledgeable session, highlighting the various diagnostic challenges, importance of basic tests like APTT, need of standard reagents, regular replacement therapy, and following the guidelines in Latin spirit. We'll now have a short tea break of 15 minutes. Thank you for your patience so far. We'll see you after 15 minutes.
Upcoming session, I'll request the chairperson of the session, Dr. Naresh Gupta, to take his place on the stage, and I also invite the co-chairpersons, Dr. Ruby Khan, Dr. S.A. Mirza, to join the chairperson.
Welcome back after the much needed kahawa and the coffee and the tea. We'll start the next session. I'm sure it is going to be as stormy as the previous ones, which is good for everyone. For that session, I invite Dr. Ruby Khan, who is sitting next to me. She is actively involved in hemophilia in Madhya Pradesh and is holding many portfolios for hemophilia and thalassemia and sickle cell and blood disorders in Bhopal. And we have Dr. S.A. Mirza. Okay, so while they are coming, we heard so much of discussion about कि हीमोफीलिया का इलाज कैसे करें. किसी को इतनी सुविधा है, डॉक्टर सोनल शाह का आपने देखा कि एमिसुजुमैब ही मिल रहा है. It is flowing like water in the taps. सुधीर अत्री जी को नहीं कुछ भी मिल पा रहा है. हालांकि डॉक्टर सुधीर अत्री का जो सेंटर है, theirs was the first center to tap NHM funds for hemophilia. You may not remember, that time it used to be NHCM, whatever they used to call it. So NHM funds have been used, and the demand on them is increasing because the product line that's available for treatment has expanded. Once it expands, everybody wants to grab it. Everybody, I mean, the industry would want to grab it first. They would influence the patient, they would influence the doctors. Not only they influence positively, they might also cross-influence. The patient becomes confused. The doctors who are new entrants or even the old ones remain uncertain. And they remain uncertain because if too many products come in a short while, these studies have not been done. वो जो research होनी चाहिए, तो आ जाती हैं. और एक साथ होती है तो comparative study तो आती नहीं है. अभी तक भी पूरी knowledge नहीं है. तो lack of knowledge की वजह से और information की वजह से doctors भी थोड़े से uncertain रहते हैं और anxiety हो जाती है. जो administrators हैं, procurement वाले हैं, they have a different angle. पर यूनिट कितना रुपए का है बता दो, जो सस्ता है वो ले लो. क्वालिटी ऑफ लाइफ का जो कॉन्सेप्ट है मेडिकल ड्रग्स में कभी रहा ही नहीं है. इट इज़ वन ऑफ द फ्यू ड्रग्स. एंड देन वन टॉक्स अबाउट क्यों ये बार बार इतना खर्च कर रहे हो, जीन थेरेपी दो ना वंस फॉर ऑल. सो वी हैव मेनी ऑफ दीज जिनके बारे में मन में बड़ी दुविधा है और उसको सॉल्व करने के लिए एक बड़ा साइंटिस्ट चाहिए हमें. And that scientist we have from Amrita Institute of Medical Sciences Research in Kochi, Professor Neeraj Siddharthan. Sir, he is very clear in his mind and he is going to transmit some clarity to us through his talk on what is the future of hemophilia, factors, non-factors, gene therapies, and beyond. What is in it for India? Professor Neeraj.
It's working. Right, sir? This is forward. Forward is this. No, up. This is forward. And this is the point. Point down. Okay, sure. We have used little time because we are 1 hour late. Okay. Good evening, and thank you very much, sir, for the gracious introduction. And I thank the organizers for this wonderful opportunity to be here in Kashmir. I come from
We have Professor Mirza, who has also joined us as a co-chair.
Thank you, sir.
Sorry for the interruption.
No problem, sir. So I come from far south, birthplace of Shankaracharya, Kaladi. That's my place, and so I saw the Shankaracharya Sarvajna paid here, so happy to be here today. Okay, so coming to the topic, So this is the slide deck that we're going to see. So first, I'm asked to talk about the future of hemophilia by Naresh sir. So first we start from the past and see how the past was. So you can see that, the hemophilia, the medical care rapidly advanced in the last century. People were treating with plasma, cryoprecipitate, we heard earlier. And in 1970s, we had plasma-derived factor concentrates. Then in 1980s, HIV struck. Then we had viral inactivation coming in. Then we had in 1990s recombinant factors being developed. And then we had in 2000 a lull period. And in 2010 onwards, in that decade, we had extended half-life and then non-factor concentrates and gene therapies starting. Okay. So this is a very interesting article in Indian Pediatrics by Professor Tulika Seth. So she describes the last 50 years of hemophilia care in general as a golden era, because so many things have advanced during this period. So from the past, we come to the present, and what do we have in the present? So probably in the last decade or so, we had earlier panel discussions. We had poor diagnostic facilities. Now it is better, if not the best. We had treatment with whole blood, plasma, cryoprecipitate, then plasma-derived, recombinant, extended half-life, and now we are in emicizumab. And we are able to diagnose, I think most part of the country, inhibitors, and we are also able to treat some of those inhibitors well. So if from nil to something like acceptable. Transfusion transmitted diseases like HIV, HBsAg, and HCV,
we are able to prevent now with best practices of moving more to recombinant, less of transfusions, more of NAT testings, and now we have drugs, good antiviral drugs to treat it also, so prevention and treatment. So that is what we are doing in the present. So with this, Dr. Vijaykumar sir is here also. I wanted to actually try and see what last decade happened in the center that we practice. So this is 2015 and 2024. As you can see, we have taken children with hemophilia. And number of children from 16 had increased to 26, those who are able to access the HTC. And most of the children who are able to access the HTC, all of them, in fact, are on prophylaxis, whereas none were on prophylaxis a decade back. So that is a significant jump in the schema of things. And you can see the age at initiation of prophylaxis is reduced from somewhere between around 10 to 6 or around 7. And if you look at the clotting factor concentrate consumption, it has increased from thousands to 1,900. And the annual bleed rate come down from 11 to 1. And you have the HHS, the joint scores also improving, the fish joint score also improving statistically significant. So all these have improved in the last decade. So if you remember, most of us started with low-dose prophylaxis. This was a paper that we had published on low-dose prophylaxis, which had resulted in significant decrease in the joint bleed rate. But still, the joint health was not improved at that time. So now, if you can see, in 2024, the HHS and fish values, which were not significant, have now become significant. So something different has happened. The low-dose prophylaxis in 2015, and now what happened? So when we actually looked at how the practice went, every child was followed up regularly in the comprehensive care clinic, and we were documenting the breakthrough bleeds. Now, once a certain number of children do not have the breakthrough bleeds, but those who have the breakthrough bleeds, first intervention that we did was the days of prophylaxis were changed based on their peak physical activity. Like if you have a sports day in the school, the prophylaxis will change to Thursday if it is a Thursday is a sports day. And then educated the parents and CWH on organizing the peak activity. Like don't take factor in the evening, but take it in the morning. And if you want to do a peak activity, if the child wants to play football, play it on the day of infusion and not 2 days after that. So organize your peak activity. That was the first step that we did. Again, after that, if the breakthrough bleed was present, then we increase the frequency. Rather than going up on the dose, maybe with twice a week, factor VIII prophylaxis was changed to thrice a week. Even then, if the breakthrough bleed was there, then we had increased the dose of the factor concentrates on a particular day. And in spite of that, if the patient still bled, by 2019 we had emicizumab available, and so emicizumab was initiated. In this, we didn't have the extended half-life in our inventory, so this was how we had managed. But extended half-life is now available. There are different ways by which factor half-lives are increased. You can do a glycopegylation, or you could do an FC receptor-based the extended half-life, and you have the factor VIII. Factor VIII extended half-life, the half-life is slightly increased, but it's significantly 4 or 5 times increased for the factor IX, which all of us know. Now, if you look at the results, you can achieve a higher trough level for factor IX, and then more reduction in the infusion number for factor IX extended half-life product. So between factor VIII and factor IX, clearly the extended half-life works much better in the factor IX deficiency. Okay, now we have an ultra, extended half-life of a product, or for the just got approved for hemophilia A. So you have the standard half-life, extended half-life, and very extended half-life or ultra kind of. So if you look at the infusion rates, you can see that the standard half-life, we used to infuse 2 to 3 times a week, or maybe up to 4 times a week. Whereas if you have the ultra half-life, you can have once a week infusion for the factor 8. And factor 9, of course, extended half-life, you can infuse once a week or once in 2 weeks. And this is how you look at the pharmacokinetics. You can see the trough. The trough is very important. And you need to give frequent doses for the standard half-life, whereas for the extended and the ultra, you can give much lower frequency, which is going to improve the compliance of the patient. For these products, the adverse reactions included hypersensitivity and mainly inhibitors. Most of these products have the propensity to cause inhibitor positivity. Thrombotic events are quite rare, except in probably hemophilia B. So that's about the clotting factor concentrate. Now we come to bispecific antibody. This is emicizumab. It does mimic the factor 8 by bringing together the 9 and 10, and then it results in a coagulation cascade and the clot formation. So over the last decade or so, there have been several studies, Haven studies, which looked at this drug, which can be administered subcutaneously, weekly, once in 2 weeks or once in a month. And it can be even given to factor 8 with inhibitors. And recently the Haven 7 trial also told us that it can be safely used in infants to initiate prophylaxis in infants. The significant, most of you would have experienced emicizumab and the zero bleed rates that Dr. Varun had just mentioned about the trial, the study from NIH and KEM, which looked at the lower doses. I'm sure many states are now looking at the lower dose, half dose. And in fact, if you look at bringing down the dose to 1/4 also, I mean, there have been reports on bringing down the dose to 1/4. You can have actually free, there was a classic statement by Manucci was that you can free more hemophiliacs with such an approach probably. So it remains to be seen how low we can go, and but this is a very exciting period for us. Now, how do we monitor when you give emicizumab? Emicizumab, as a practice, we do not monitor the laboratory, right? But APTT can get shortened with emicizumab, you know that. But you don't have, you have your Bethesda test, you should unaffected by it, and one state APTT is affected by it, and thrombin time is not affected by it. So it's like you need to be aware of which test gets affected by it and not. And how to monitor the emicizumab thrombin generation or emicizumab levels, that's a topic of hot interest and probably debate. I'll not go into that. But as you can see here in that graph, that unlike a clotting factor concentrate, you have a steady level. You had a high trough and a high peak and a trough for the factor concentrate, but you have a steady state for the emicizumab. You don't have a fear of inhibitors in emicizumab. You don't have a fear of hypersensitivity reactions, but you have a fear of thrombotic events with emicizumab, especially if you are using it with a higher dose of APCC. Otherwise, the thrombotic events have not been reported. Now, extended half-life, emicizumab, and now what you can see is rebalancing the hemostasis. So you have anticoagulant proteins and procoagulant proteins. So if you have a factor 8 deficiency, and then you have more bleeding, but then you remove a procoagulant protein and try to rebalance the hemostasis. So there are many other non-factor replacement therapies which are rebalancing the hemostasis. Some of the studies have already been conducted. Concizumab is one such, which is anti-TFPI. And this has been approved in Australia and Canada. Just now, FDA, I think the last week, had FDA approval for marstacimab, which is again anti-TFPI. Fitusiran has undergone clinical trials and is awaiting an approval now. Now again, like emicizumab, the steady state levels are similar in non-factor concentrates, and the problem, of course, is the hypersensitivity reactions and thrombotic events. Now we come to gene therapy. There are several trials of gene therapy, and now at least 3 products have reached the level of approval. You have factor 8. Usually the vector used is adeno-associated virus. As you can see, there are ongoing trials in factor 9 as well, and some of them have, one of them at least has received an FDA approval. Now, yeah, so basically, if you look at the good thing about gene therapy is that you get a higher levels of factor, but early stages, now the limitation is that many patients in many trials, after an initial good level, the factor levels tend to drop after year 1 or year 2, and at least in hemophilia A trials, there was a heavy problem of transaminitis, and also thrombosis and malignancy have been reported with the gene therapy trials. So this is, again, you can achieve a steady state, but then it's not infinite. At present, it looks like it comes down a little later, although it may still be above the severity level. And you can see that thrombotic events can be there, elevated liver enzymes can be there, and malignancy also have to be looked out for. Where are we in India? That's one part of the, so here the first gene therapy trial is undergoing, a phase 1 trial is on in CMC Vellore, and we will look forward to the early results from this trial. I think it is likely to be presented in this year's ASH meeting. So if you look at the different agents that we talked about, this is how they look at the hemostasis. So obviously looks like standard half-life factor is inferior now. Extended half-life factor is difficult, and so the pendulum is swinging towards non-factor concentrates and gene therapy as of now is what I feel. Now, when in future, if a hemophilia patient comes to us as a physician, then how are you going to counsel? So what are your priorities? How do you, between EHL, gene therapy, non-factor concentrates, how do you choose? So there are this is straight from WFH. If you look at the different qualities or like which can be affected by the 3 therapies, it looks like gene therapy and non-factor replacement therapies have more greens and yellow compared to the reds of the replacement therapy there. So that will be very interesting. The other thing, what can happen in future, I was saying, we have a multidisciplinary approach to the treatment anyways, but how is this multidisciplinary approach going to change? We all have limitations. So infrastructure is limited. How can we get physiotherapy, physiatrists, nurse, dentist, and hematologist together when life is becoming more busy? Is it possible for every center to do this? Is there infrastructure for that? So the multidisciplinary approach is, I think, likely to become more digital. You have Zooms and Google Meets and all. So we have tried this out, and there has been different publications about how this can be done. The multidisciplinary approach can be done easily for a patient visiting any one department. Quickly, you can have the other departments involved in a digital way. So that brings us to the use of another innovative care delivery, that is use of telemedicine or remote monitoring and consultations. So I would like to cite the example of the webinar series done by IIHAD, which was started during the COVID time, where people were not able to come together to this, and it is still continuing. And we have also the nursing webinar series and also the MSK webinar series still ongoing. And looks like people are interested in this format. So, so that's also something I think that will continue in the future. And also seeing patients through telemedicine, especially where you have difficult terrains, and I think Kashmir is, of course, a difficult terrain here. So it would be helpful if telemedicine facilities are there. Again, we had a feel of telemedicine during the COVID, and it's still helpful to continue the telemedicine. And our hospital, we have a help from ISRO, and then this is a solar panel, the telemedicine unit, which can go to virtually any distant place. Even without this, of course, you could do telemedicine very easily now. During the COVID, we had an important meeting conducted involving different stakeholders in Kerala, which ultimately resulted in starting emicizumab usage for the patients as early as in 2020 as a state policy. So telemedicine, virtual things really help, and it needs to be explored more, is what I feel. And so a few genetic profiling. I have 2-3 more slides. So genetic profiling of a patient is probably another thing, because you have some patients who have severe factor levels, but still they are not bleeding. Why they are not bleeding? Why are they really severe? So we have a exome sequencing, whole genome sequencing, and all that, which can tell us actually in a refined manner whether this patient is likely towards the bleeder or towards which part of hemostasis is tilted to. Now about patient-centric care. Another thing is, like, we are giving factors, but are we actually giving the patient-centric care? So we treat bleeds, muscle bleeds, we treat pain, we treat joint problems, but down there, the impact on life, the personalization is actually what the patient is actually doing. The different job, he may be a mechanic, he may be somebody is a computer engineer, or he may be a student. His requirement, every patient's requirement will be a little different. Somebody may want to do cricket as a career. So this personalization of care is the next level we are likely to come across in the future, which we are not at present doing, but that's something which is we're likely to do. Then clinical trials. The clinical trials are, now we are probably having some clinical trials which are coming from the multinationals, but probably not enough of the new clinical trials come to India. Phase 1 and phase 2, phase 3 and phase 4 are the 4 phases. Phase 1 is basically you find out the safety. 70% of them move to phase 2, where you look at the safety and also you select the dose. And then you have the phase 3, which compares with the existing standard usually. And then the post-marketing is the phase 4. So of late, we have started with phase 4, then phase 3, and now phase 1 trials also, like the gene therapy is now a phase 1 trial. And that's probably the way to go in future, especially in India. Lastly, the digital health tools. Tweet. Okay, so look at tweets actually reaches a lot of people. Maybe it's not that popular in India yet, but it is becoming popular. If you want to convey a message, you can see during hemophilia days, during major meetings, people actually look at a lot of tweets. So that's for the healthcare professionals to engage them with a new information. Tweets do help. And also mobile apps. There are different mobile apps which help in hemophilia management, especially some of these like HemoTracks and Hemolog have been quite popular. So India is quite advanced in digital technology. So it's only a question of us working with some of those digital people to bring in more quality to our patients with these mobile apps. So, not sure, so this is a card test which was developed by ICMR. This is a rapid card test, and we had used this card test in in a high range camp that we did recently. This is like just requires a drop of blood, and if you have 2 lines there, that's a positive test. And if you have only the control line positive, that's a negative test, and that's for hemophilia A, factor VIII deficiency. It's quite useful, especially to screen patients' relatives also. And finally, the access to care. Of course, we should have equitable access to care. WFH donations, we cannot end without acknowledging the WFH donations, which had gone a big way in empowering people to get the clotting factor concentrates. And India is one of the major countries receiving the humanitarian aid program. And as we look at it, you can see that it is indeed making an impact. The people with acute bleeds getting treated are coming down, and people with prophylaxis or regular replacements are going up. So I think it's time to end now. So Tulika Seth Madam mentioned last 50 years have been golden era, and I think we should say that the next 15 years would be a crowning glory. Thank you.
Well said at the end. Thank you, Dr. Neeraj, for that comprehensive overview of all the modalities currently available and will be available in future. So to start with, I would like to ask you a question, like if you on today, if we have to tell our governments or tell our the healthcare providers, what should be the ideal factor replacement therapy at this juncture, considering the requirements, like now we currently it's not just survival, it's about good physical activity also. One is that. Second is, now with the kind of prophylaxis we are using, like we are telling them, like you said, you just mentioned, like we let them do the maximum physical activity on the day 1. So, but if the kind of factor we are giving, how much factor recovery will come at that particular day? So depending on which type of physical activity only to be, if they can take it for, they can go into a contact sport and they can come with an head injury. So we should not give a misconception also. At the same time, how would you answer these 2 questions and for the benefit of the entire, so that can be put into our practice?
Yeah, thanks for these questions. And I will start with the second question first. So rightly said that, okay, so when the children want to have physical activities, children usually didn't ask for physical activity when they were not on prophylaxis. They were saying, okay, this is our life. We are confined to doing these things only. Once they're on prophylaxis, they start thinking about, what is their limit? Okay, what is their limit? So we have to obviously draw a limit. So they want to actually go for sports every day. So what we actually tell them is that don't do it every day. Okay, restrict it. You have a timetable for your studies. Keep a timetable for your sports also. We don't encourage contact sports as such, but do the sports only on those days where you are taking factor in the morning. And when we would also ask the parents to have a word with the teacher that, okay, certain things needs to be addressed. So the NHF has given some activity list. So for us, National Hemophilia Foundation in US actually beautifully given a lot of activity lists which are high risk, intermediate risk, and low risk for bleeding. So I would suggest that as a reference. So that those activities which are considered high risk is better avoided in that. The first question regarding what should be our target for the patients, is it that the trough level of 1% or even more, or what should be? I think it's the improvement is a continuous process, right? So resources, whatever said, our resources are still limited, is what I would say. We don't have unlimited resources. So we actually go by the bleed rates initially. So we had 11 bleed rates and it was reduced to 1. So whenever the bleed rate is more than 1 or 2 or 3, we try to bring down the bleed rate to 0 and don't worry about the trough level at all. I mean, just bring down the bleed rate to 0. If the bleed rate is 0, then only you think about what more can you achieve. I'm not sure whether we have reached there, but emicizumab has given us a push in that direction where the bleed rate is 0 and you could actually aim for doing more things. Yeah.
सर डॉक्टर नीरज, हमारी ऑडियंस को ये बताइए, वन ड्रग हैज अचीव्ड 0 ब्लीड रेट, वो कहते हैं फिर उसके आगे क्यों चाहिए कुछ?
आगे क्यों चेंज करना है?
नहीं, क्यों चाहिए आपको? आपने तो खत्म कर दिया ना. व्हाट डज 0 ब्लीड रेट मीन टू द कॉमन पर्सन और टू द हीमोफीलिया पेशेंट, डॉक्टर, सोसाइटी? एडमिनिस्ट्रेटर कहेगा आपने तो दे दिया ना.
हाँ.
डॉक्टर सोनाल शो को बोलेगा आपको लैब वैब कोई जरूरत नहीं है. 0 हो गया ना. अब तो
लैब कोई जरूरत नहीं है,
कोई जरूरत नहीं. मॉनिटरिंग आप बोला जरूरत नहीं है. तो 0 ब्लीड रेट का मतलब 0 ब्लीड है वो ठीक नहीं है. इट इज इंटरक्वार्टाइल रेंज में वो करते हैं जो कि मिडिल 50% लेता है और आउटलायर्स हटा देता है. ठीक है. नाउ टेल मी, हम लोग जो बात कर रहे हैं वो ये कि स्टैंडर्ड हाफ लाइफ, एक्सटेंडेड हाफ लाइफ, नॉन फैक्टर, जीन थेरेपी, ड्रग्स जो है उसमें क्या फ्यूचर है इंडिया का? यू थिंक वी हैव फाउंड द होली ग्रेल? यू थिंक नॉन फैक्टर इज द थिंग?
Generic, I mean, so I was actually, morning we were having a conversation where think about if generics come with drugs like emicizumab from Indian pharma. So, the cost is the issue. Now, if the cost comes down if we are able to manufacture generics, sir.
We have generic medical colleges. Let's not go into that. आप एक बात बताइए, जो हीमोफीलिया है उसमें फैक्टर 8 की डेफिशिएंसी है 85% ऑफ हीमोफीलिया में. व्हाई आर वी नॉट एबल टू क्रिएट द सिनेरियो वो ब्लीड ना करे? आपके पास एक्सटेंडेड हाफ लाइफ भी है.
Which is exactly what we did, sir.
नहीं, वो ब्लीड तो सब में होता है ना. एमिसिजुमैब भी होता है, एक्सटेंडेड में भी होता है.
नहीं, तो
आर वी मिसिंग इसी मल्टी डिसिप्लिनरी अप्रोच आपने बोला, उसके अलावा मेडिकल अप्रोच में आर वी मिसिंग समथिंग एंड वी आर नॉट लुकिंग फॉर इट एंड वी आर नॉट लुकिंग एट इट, जो कि हीमोफीलिया को जरूरत है नहीं मेडिकल ड्रग्स में. आपका क्या विचार है? मतलब अगले 50 साल में हम क्या सोच के चलेंगे? हम इसी पे चलेंगे मल्टी डिसिप्लिनरी, या कोई इनको जो क्योर है? आपने ये भी बता दिया सबको कि जीन जो थेरेपी है वो जो क्योर आप मान के चल रहे हैं वो शायद है नहीं, इल्यूजनरी है, क्योंकि उसमें कुछ महीने 6-8 महीने 1 साल के बाद जो है आपको हो सकता है दोबारा कराना पड़ेगा. तो आप क्या सोचते हैं? Have we reached the perfect target?
No, sir. I think we have not reached the perfect target, which means we'll need a shared decision making with the patient. If the resources are there in the future, everything is there. Everything has a positive or a negative thing. So if you have emicizumab, you will have to take it as a continuous injections. You have a thrombotic risk there. So gene therapy has, probably gives a higher level initially, but then it drops, then you have other problems with gene therapy. But you have to probably, and if you look at the extended half-life, of course, extended half-life, you have to take very frequent injections and you have a trough coming down, you are likely to bleed. So which patient likes what will be also a question. Sir. Like if I like something, it may not be what my colleague likes or the other patient likes.
So you are leaving it to the patient and the groups. अब हम उनको से वो देते हैं कि वो अपनी विजडम आपके ऊपर.
सर ये डिस्कशन के दरमियान आया कि मोर देन 1%, आप जानते ही हैं हम लोग का टारगेट है कि मोर देन 3% लाना है, आइडियली मोर देन 5% विद प्रोफाइलैक्सिस. वो तो एक बात
फेल हो गया वो तो.
और दूसरी बात है सर,
अभी 12% की बात कर रहे हैं.
प्रिवेंशन की फ्यूचर ही है, तब तो एंटीनेटल टेस्टिंग हो, जेनेटिक टेस्टिंग हो, उस पर पॉलिसी बनाए.
आई थिंक हम लोगों को मूव नहीं करना चाहिए. जो डॉक्टर बिलाल ने बड़ा वाइजली टॉपिक रखा है वो है कि जो ड्रग्स है ना, वी आर नॉट टॉकिंग अबाउट कि बाकी क्या करोगे, वो तो करोगे. ड्रग्स में स्टैंडर्ड हाफ लाइफ, एक्सटेंडेड, नॉन फैक्टर, जीन थेरेपी, इसका क्या फ्यूचर है यहाँ पे? बाकी आप सपोर्ट करोगे. ड्रग्स के बारे में कोई सवाल?
एमिसुलिमाब के बारे में मेरा बहुत एक्सपीरियंस नहीं है, बट 2 पेशेंट्स आर इन माय कांटेक्ट. वो डॉक्टर वर्मा की कृपा है कि
नहीं, वो
उसके कारण
वो तो डॉक्टर सोनल
लेकिन डॉक्टर सोनल सिंह उनसे हम सोनल से बात करना चाहते हैं. अगर आप एमिसुलिमाब देते हैं तो हाउ ही डज मॉनिटर द only clinically or any special clinical laboratory test that is available, a common discussion in various forum that is used, because what is the basis on which you are monitor the effectiveness of emicizumab.
Got it.
Unless अगर इसको नहीं करेंगे तो फिर हम कैसे differentiate करेंगे? It is different from other.
Got it. We are running short on time. This question we will not take because she answered it. That does not need so much of monitoring. Any one more last comment or question? ये तो बड़ा इंटरेस्टिंग टॉपिक है.
Actually, the thing is that the science has moved far advanced, so we have to accept that reality. And I have already said that the contribution goes to the researchers, right? Because the blood products and then standard EHL and non-factor therapies, even the non-factor therapies are doing very good, and the things are moving on now. The anti-TFPI, fluticasone, antithrombin 3 and other drugs are coming. Mimetics are coming, which is a once in a 6 months. So if it is once in a 1 month, now the drugs are coming once in a 6 months. So obviously that will be preferred. So those things are going on. It depends upon the compliance and adherence of the drug. If the drug has a good compliance and adherence, I think that, and the cost effective, and I think that will be chosen in the upcoming future.
Yeah, he talked about more extended, ultra extended half-life. So let us conclude by saying that after hemophilia was detected to be having factor 8 deficiency or 9 in small number, replacement of the factor concentrate, which was recombinant, that means pure, would tell us and take us to the end of it. कि आपकी ये कमी है, हमने भर दी है, अब आप बिल्कुल ठीक हो जाएंगे. ऐसा नहीं हुआ. कई कारण थे उसके. We will not go into that. Phospholipid factor reducing the half-life was one of the issues. So they came with extended half-life, जो कि factor 9 में, जिसमें BWF का रोल नहीं था, ज़्यादा सक्सेसफुल हो गया, पर उसमें भी ब्लीडिंग पूरी तरह से नहीं खत्म हुई. हीमोफीलिया ए में भी नहीं खत्म हुई. एमिसुजुमैब, नॉन फैक्टर थेरेपीज और जो आगे भी आने वाली हैं, उन सब में भी ज़ीरो ब्लीड नहीं आएगा. अगर वो ज़ीरो ब्लीड नहीं आ रहा है तो उसका कोई कारण होगा. एंड ऑल्सो रिमेंबर कि जो फैक्टर 8 है उसके रोल सिर्फ ब्लीडिंग रोकने के लिए नहीं है, उसके रोल कुछ और भी हैं. कुदरत ने अगर उसका जो प्रोडक्शन है बाकी फैक्टर से अलग रखा है, साइट भी अलग रखा है, और उसको नॉन स्पेसिफिक एक्यूट फेज रिएक्टेंट की कैटेगरी में डाला है, तो उसके रोल्स और भी हैं. I think we must work on science, basic science, as Dr. Kaul was saying, pathology, basic science would take us further. Until then, we'll have to play around with these factors, and as everybody has said, we'll make it more compliant by making it more acceptable to the patient so that they are more adherent, and they are taking adherent, their results are much better, and we have to make them safer. Thank you so much for showing us the future.
Thank you.
Thank you, Dr. Siddharth. We close this session.
Highlighting the importance of multidisciplinary approach, need of telemedicine, genetic profiling, and the importance of WFH donations. Thank you to the chair and co-chairs. Our next segment, hemophilia, shaping policy and protocol, learning from innovative approaches of care leading to positive impact on persons with hemophilia. This will have 2 sessions, learning from Kerala and learning from Jammu and Kashmir. I request the chairperson, Dr. Rakesh Sharma, to join us on the stage. Dr. Rakesh Sharma. Meanwhile, I request the co-chairpersons to take their place, Dr. Parul Bhatt and Dr. Sanjeev Dingra. Okay. I'll request the co-chairpersons to take over as the chairperson is not here momentarily. I request the co-chairpersons to introduce the speaker. First the speaker from the Kerala and then the speaker from Jammu and Kashmir.
Good evening, everyone. Very interesting topic, and thank you very much, Dr. Bilal sir and his team, to inviting me here as a to chair this session. The first, however, so many questions in the mind how this discussion will go on, but we will try to make it smooth one. So first session will be learning from the Kerala for hemophilia shaping and policy and protocol. So question will be taken at the end of both the case scenario. Then we will have a very good discussion. Thank you.
And there is no second.
She is from Kerala, Dr. Heda B.
Am I audible? Yes. Can you just start the slides? So first of all, good evening to all. We are running late by 1 hour, I think. So I will quickly finish. And first of all, I thank Hemophilia Society of Kashmir and the Hemophilia and Health Collective of North for giving me this opportunity to talk on this topic, that is the learning objectives from Kerala, the experience sharing of the hemophilia care in Kerala. Before going to the topic proper, I have a few disclosures. The first one is that I'm not the proper person to talk on this, because this talk should be ideally done by our NHM state office, and the nodal officer is Dr. Rahul. In his absence, I am doing this talk on the behalf of the NHM state office and the technical advisory committee. And here, so before So before going to the talk, I have a few acknowledgements. So first, the NHM Kerala State Nodal Office and the Medical Services Corporation of Kerala State for supplying the drugs. Then the Nodal Officer, Dr. Srihari M, who started all these decentralization process. And Dr. Rahul UR, who is the current Nodal Officer of the State NHM and the office staff. And the next and the most important is the Technical Advisory or Training Committee, which include Dr. Vijay Kumar sir, Ajit Kumar sir, Dr. Srinath sir. All these three people are present here, and they are the senior members of our technical committee, and they are experienced. They have long years of experience. Even when I started doing my MBBS, from that time onwards, these people are starting to see and treat patients with hemophilia. Then of course, Dr. Neeraj Siddharthan, who was the previous speaker, who is also giving some technical advices to the state. And Dr. Devakumar sir, Dr. Sheila madam, who are not present here, Dr. Harit Prasad. Then all practicing hematologists in Kerala, then all the nodal officers, all the nurse coordinators, all the pathology doctors, pharmacists and other paramedical staff, then all the hemophilia chapters. We have 7 chapters in Kerala, and our dear patients. Because this program have evolved because of the collective effort of all these group. So here we are, as Dr. Neeraj already pointed out, in the southern end of India, and we have 14 districts which are distributed in a north-south direction, and the state capital is Trivandrum, and our NHM state nodal office is situated in Trivandrum, and we have to control the whole state from the state of Trivandrum. So in the healthcare system in Kerala, of course, in any other state, we have the government healthcare system and the private healthcare system. So first is the Department of Health Services of Kerala, under which all the district hospitals, taluk hospitals, and the FHCs, CHCs, all these hospitals come. Then there is the Department of Medical Education, under which all the medical colleges are there. Then there is the private sector, of which one of the pioneering institute which has been treating hemophilia in Kerala is the AIMS Kochi, from where Dr. Neeraj Siddharthan is. Then other hospitals like ICRA, KIMS, MIMS, then Jubilee Mission Hospital. There are a lot of private hospitals in Kerala who are treating hemophilia in a standard manner. And the healthcare for hemophilia in Kerala is with a public-private cooperation, that is which I want to say, and the NHM state office is collaborating with all the government institute and also even with some private institutes for giving comprehensive care to the patients with hemophilia. And little bit of the hemophilia treatment history in Kerala. So the hemophilia treatment was taken up by the government of Kerala, even from, as I can remember, from maybe some 2005 to 2006. That is in the first decade of this century. So this was a part of repeated efforts of the chapters, that is the advocacy groups. They have approached the government regarding the cost of treatment, the cost of factors. So the government took a policy that the hemophilia treatment will be taken up by the government. So they utilized various funds for this, and the government started providing free treatment for hemophilia, I think from 2005-2006 periods onwards. Later on, they shifted the funds to the Karunya Benevolent Funds. So the money for the Karunya Fund was from the Lotteries Department. Hence, all the medicines were procured through the Karunya Fund, and it was made available through the KCPs, that is the Karunya Community Pharmacy Outlets, which is present in almost all taluks and most of the towns in Kerala. And all the drugs for hemophilia, which was then available, that is the factor 8, factor 9, and FIBA, was made available through the Karunya outlets. And in 2014, Kerala government has included factor 8 and factor 9 in the essential drug list. In 2014, etc., there was a limit. For all the patients, the treatment was free, but free only up to the limit of 2 lakh rupees. But in 2015, the government announced that all these 3 drugs, factor 8, factor 9, and FIBA, can be provided free of cost for lifelong. That economical cap of 2 lakhs was taken off. So lifelong free treatment for all hemophilics was announced in 2015. And years later, the NHM has taken up hemophilia care throughout India. And in 2020, as part of that NHM program of hemophilia, the state has launched this program called Asha Dhara. So this Asha Dhara, that's the name given by the state. So in Malayalam, Asha stands for hope. Dhara means flow. So this is a flow of hope for the hemophiliac patients in Kerala. And so in 2020 August, this was launched, Asha Dhara program was launched as a comprehensive decentralized management program for hemophilia throughout Kerala. Apart from hemophilia, disorders like hemoglobinopathies like thalassemia and sickle cell was also included in this list. So this is the website of the Asha Dhara program. And Dr. Srihari, who was the previous nodal officer, was instrumental in this decentralization program. And Dr. Lahul Yuvar is now carrying over on the work which was initially started by Dr. Srihari. So, what are the pillars under which this Asha Dhara NHM program is running? First of all, they created a digital patient. Yeah.
Sorry for the interruption. I extend my welcome to our guest of honor, Professor Dr. Ifat Hassan Shah, Principal and Dean, Government Medical College, Srinagar and Associated Hospitals. Thank you, ma'am, for your presence.
Okay. So, the first what they did was they formulated a patient registry, which was available online. Then they established the hemophilia treatment centers, which were the district daycare centers or the DDCCs, 1 in each center. Then 3 regional hemophilia treatment centers, HTCs, were established. That is in Trivandrum, in Alva there was 1, in Calicut there was 1, in additional Thrissur there was 1. So these were different districts in Kerala. And this HTC in Alva has started functioning long back in 2014 as a proper HTC. Even though the care of hemophilia was there in Trivandrum Medical College, Calicut Medical College, etc. for several years, a proper comprehensive care sort of HTC, physiotherapy, etc. was first established in HTC Alva. Apart from that, the taluk hospitals, all the medical colleges, everything was properly arranged to care hemophilia under the Asha Dhara program. Then during the COVID times, they run the e-Sanjeevani OPD or the telemedicine sort of treatment for hemophiliacs, because during that there was this lockdown and patients were not able to travel. So e-Sanjeevani, e-medicine consultation was given during that time. Then the next fourth thing the program did was they trained all the doctors and nurses in the DHS and DME, that is the health services and the medical education, for equipped them with adequate knowledge about hemophilia. Then they appointed one dedicated staff nurse coordinator in all these treatment units. Then they asked the KMSCL to ensure a continuous 365 into 24 supply of all the drugs for hemophilia based on the previous year's consumption data. And prophylaxis for children less than 18 years was started as a part of Ashadaram program in 2020. Even before that, prophylaxis was regularly given in HTC Alua, in the Hemophilia Treatment Center in Trivandrum. Srinath sir had some patients, Vijay Kumar sir had some patients, Ajit sir had some patients in Calicut. So everybody was running their own group of patients from various funds. But in 2020, under this program, all this was uniform and made available throughout Kerala for this prophylaxis less than 18 years children. Then the state appointed a state nodal officer as well as the technical advisory committee to make all the policy decisions. Then they established an Ashadhara web portal so that all the treating doctors and nurses can access all this data. So the record keeping and data management was efficiently done by the NHM office. So they provided the reporting format for drug consumption, for the clinical records, all they provided recording formats. Some of these was based on the treatment records from the HTC Alva. Then the treatment records of patients, consumption of factors, etc. All these data are digitally captured by the NHM office, and they are maintained, and these data are analyzed on monthly basis. There are monthly review meetings, online meetings, in which these data has to be presented by the treating nurse coordinators and the doctors. And they brought in regulations to ensure that no patient is consuming factors injudiciously. When previously the Karunya program was there was little bit of overconsumption of factors, which was causing an economic burden. So this was removed by the inception of this program. Then there was periodic training programs, treatment protocols for hemophilia and all the other disorders was established, periodic online meetings and offline meetings, difficult cases, everything was discussed in the technical committee. So policy making, implementation and continuous monitoring is the pillars on which this program now stands. For example, if there is a patient who have a high factor consumption, the NHM will capture this data. Then they will put this query to the doctor. So this patient is having frequent bleed, is prophylaxis a better mode, or why he is consuming so much of factor. So this has to be answered by the treatment doctor, nurse coordinator and the technical committee. So they are analyzing all the problems related to hemophilia care. So the diseases included in this program are hemophilia, von Willebrand's disease, factor 7 deficiency, thalassemia and sickle cell disease. So the comprehensive decentralized treatment under Ashadhara program now covers the on-demand treatment and the prophylaxis. And in addition to the HTCs and DDCCs, they already provide help to hemophilia. They also provide the treatment for thalassemia and sickle cell disease. Then all these are the different treatment units and their duties are well described by NHM. What facility has to be there in each hospital is predefined. And these are the 14 DDCCs which are available in our state. And the function of each of these hospital in the various domains of hemophilia care, like prevention, treatment, screening, lab diagnosis, all these are well laid down. So
Excuse me, Dr. Hita.
Huh?
Please, because we have shortage of time, so please wind up in another 1 minute. Huh?
Okay. So, so the roles and responsibilities of all the hospitals and all the personnel are well defined. And this is the timeline of our prophylaxis from where we started from fat rate prophylaxis. And now we have moved down to emicizumab prophylaxis to all children in 2024 September. So, so this I think, and they have covered, the NHM is supporting surgeries for all patients with hemophilia in medical colleges as well as the hospitals in health service. And they have provided, this is the first knee replacement surgery in the government sector, even though it has been done in the, and these complicated surgeries in hemophilia are also taking place in our all government hospitals through the factor support by the NHM. And other factor deficiencies are also covered under NHM program, so that we are able to take up now all the cases in private hospitals as well as the government hospitals. And some complicated cases like ALL in a patient with hemophilia was treated by Amrita Institute with the help of the NHM as well as the WFH factor support. And rehabilitation facilities also provided in all the government hospital, especially pioneering works by the AIIMS Kochi and HTC Alva. Genetic diagnosis facility we are planning to start in Trivandrum. So there is a policy for bedridden patients also. So these are the different works done by hemophilia NHM program for the various aspects of hemophilia care. So these are the different training programs, photographs from the different training programs and chapter meetings. Okay,
Thank you, Dr. Hita. And so, yeah, we have listened from the southernmost part of our country. Now we will be listening from the northernmost part of our country. So I would invite Dr. Bilal to tell us the story from Kashmir.
ये presentation नहीं, ये नहीं, वो दूसरी presentation, BDCM वाले हैं, ये this one. With the permission of chairpersons, can I proceed? Can I proceed with the permission? Okay. So, respected PMC Dean, GMC and Associate Hospital Srinagar, and Principal GMC Baramulla, Professor Ruby Reshi, delegates, faculty, a very good evening. We are running very late, but still I will try to, just compile my presentation in a very crisp way. So, the hemophilia shaping policy and protocol is a learning from innovative approach of care leading to positive impact on this thing. So, it is the necessity which is a mother of invention. So, we have just got this, this is the theme of the year, equitable access for all. I mean, we have to, every person with hemophilia has an equal rights of access, so that we can also recognize all bleeding disorders for the management. So hemophilia will not go by the way that it is a, it's an inherited X-linked genetic disorder where you have the factor A deficiency or factor 9 deficiency, which is a hemophilia A or hemophilia B, and there are so many bleeding disorders as well, but majority 80 to 85% of the bleeding disorders are hemophilia A, which is a factor A deficiency. So these are all their challenges they are facing throughout their life because of the factor deficiency, because of the clotting factor deficiency. They have all sort of life-threatening bleeds. They have joint bleeds and muscle bleeds and all that. So we'll not go that. So this this is the epidemiology, and 1 in 5,000 or hemophilia B 1 in 20,000. So by that we just estimate the prevalence or incidence of the hemophilia. India is the second most largest country for the hemophilics, because the second largest population of hemophilics live in India, and only 20% are diagnosed. So that is we know that is a diagnostic challenge we are discussing from the since afternoon, that diagnosis is a big challenge, where we are still missing 70 to 80% of the persons with hemophilia as per the literature, as per the incidence and prevalence. So it is our state scenario. If we have a 90 lakh population, as per the 1 in 10,000 population, if you'll see, so we should expect a 900 people in our. So, but at our center we have right now 429 people which are registered. So still 50% or 50 to 60% people still we are missing. But thanks to the administration and support and all that, because we have a good coagulation lab, we are, yearly detecting, monthly we are detecting new 1 or 2 newly, hemophilics because of the coagulation lab and the clinical super specialties we have all around with our associated hospital, which is associated with us. So this is the global standard of care, regular replacement therapy, which we are discussing. We will not discuss this thing. So this thing we have kept in mind, and that is why this is the journey of the hemophilia in Kashmir, which started in 2012 by a bill in Honorable High Court, where the government was forced to give the budget for the hemophilics, and the drugs were available there, and the hemophilics came, and we were just registering them. So this is the curve. This curve I show in every presentation. So you can just see. I will go back. Yeah. So you can see that 2012 we have just 90 people registered, and in 2017 we just established a coagulation lab in our central laboratory, and you can see the curve is going up. So this is the diagnostic part. When you have the good diagnosis and good clinical practice, I mean the referring from institute or the super specialty which are associated hospitals with us. So our curve is going up. I mean monthly basis we are registering new 2 or 3 patients with the bleeding disorders. So this is the scenario 304 are A and 2049B and different types of bleeding disorders registered with us right now. So this is the graph, and these are the male female gender distribution. Among hemophilia A 304 we have 145 which are severe, 59 moderate and 100 are mild. Age distribution less than 18 you have 134, and more than 18 we have 170 people. And this is only the blessing we have, the administration, government and the corporation. I mean the end user, we are giving the requisition, they are giving us enough budget. That is why we are working as an European standard. I mean we have all the severe hemophilics on regular replacement therapy, and 157 of hemophilia A are on regular replacement therapy, and 27 of severe hemophilia B are on regular replacement therapy. And the new molecule which came in 2021 June we have started, which is monoclonal antibody imicizumab, and that has shown a wonderful results, which is because just like diabetes you need a subcutaneous insulin, so similarly you need a subcutaneous hemostatic agent, which is a monoclonal antibody imicizumab, which we have had experience of more than 3 years. So which is in European countries there, and we have 110 persons with severe hemophilia on this thing, and we have also published it, and soonly it will be published in Hemophilia Journal. This study that this imicizumab 3 years experience on our severe hemophilia A with or without inhibitors. So that shortly that will be published. This is the hemophilia B scenario. 27 they are on prophylaxis, and von Willebrand, even we have severe type 3 von Willebrand, they are also on prophylaxis. So this is all because of the support of administration, government, and they are listening to us, and they are giving us the things budget, and that is why from last 5 years we don't have any sort of mortality, and we are doing minor as well as major surgeries from there. So then this is our administrative where we deliver. This is the ward, hemophilia ward, where it is full of ward. Before when 2012 to 2019 our treatment was on demand. It was not regular replacement because of the limitation of the budget and availability of the factors, and where we had also the limitation of the diagnostics at that very point. But the trend has changed. It all credit goes to Professor Naresh Gupta, who along with Professor Ruby Reshi, who started the program of awareness in 2012. So I still remember, ma'am was dragging me, you come along with me, and I was just, backtracking, but she was a good mentor for me, and he started, even in India, 2007. Professor Naresh Gupta is the stalwart in India of hemophilia care, and he has really, the whole contribution to the India goes to the Professor Naresh Gupta. So, so these are awards. So this is a necessity, what I said, we learned the home therapy. When the COVID came and the 370 lockdown came, we had enough factors, but we are not able to deliver them at home. So what we did with the help of patient support group, we had ambulances, we had factors, so we had all the registries, we had contact number, we had addresses of the patients. So we were delivering them the factors at their doorstep. So we are not knowing at that time what is home therapy. So that made us that there is something, now the new world is saying that it is something home therapy. So that was the innovation, that no, it is better, because the patient who is bleeding has to come from the home, because ours is a very tough geographical terrain, and there is less of connectivity. And there is not like metropolitan cities, you have all 24/7 traffic. So the climate are very climatic extremities are there, so that people don't travel far away from that. So that has given us good thing that we keep a record of that. We give them vials, we have a proper registration system, and we don't give them the extra dose until they return the empty vials. They return the empty vials to the center. Our medical officers, who are in the hemophilia daycare center, they ensure it, whether whatever vials we have issued to them for 2 months or 1 month. So if they give us back, then we give the second lot. And we continuously have the call phone numbers. We remind them, you have twice weekly, thrice weekly, and all that. This is about the factor therapies of the home therapy we are talking about. For the non-factor, we don't give the home therapy. We call them once in a month because that is very easy. Once in a month they have to travel and they have to just give the injection at the center and they go back home. So this was the learning experience in this lockdown. This is the, at doorstep we are just delivering them with the help of patient support group. And also we are, training caregivers because we have to empower these people. Because there are many, apprehensions at our medical college also. Sometimes in emergency department, late night, sometimes the hemophilic comes with a bleed. And even our nurses, even doctors are apprehensive. I mean, they are just taking it as just like a ceftriaxone, which has an anaphylactic reaction. So it does not have that. So they don't have that awareness. So that awareness has to get generated. No, look, this is a factor, this is a protein, so you don't have to worry. It will have no reaction. Kindly, it is available there 24/7, and in emergency you can use it. And they are reluctant. And then I counsel them, please do it. There is no problem. You can induce. So that is why we want the patient and the caregivers to have the self-infusion training. We have done a program, what is called as that was a HOPE project, where we have done a self-infusion training with the help of patient support program. We acquired a nurse, and at our center, even at the doorstep, they were training patients, people with hemophilia as well as their caregivers, how to infuse, how to do the things, when the non-factor was not available. So the factors, because there is a lot of challenges of finding the vein and pushing the drug into it, and we gave them the training of self-infusion. That was also very important, and then the patients don't have to go to the medical shop or don't have to beg somebody, kindly give me this injection. So you have to empower really for the self-infusion training. This is a self-infusion training we are giving the patients and the caregivers at our center, so that to empower. This is the MPT vials they give to our medical officers back, and then we issue the second lot. So this has given us really think that the indirect cost has definitely decreased. I mean, they don't have to travel, they don't have to come with the emergency bleed. A lot of hospital resources are used, a lot of factors are used, our manpower is used. So that cost has totally been taken off because of the home therapy and because of the regular replacement therapy. So they don't need, and we have achieved a ABR of 0, which is just comparable to the European standards. So this is the patients who are on prophylaxis, hemophilia A, B, both. All severe hemophilics are on prophylaxis. So this is the achievement. I mean, when you have the available drugs, you can see how the major surgical procedures we are doing. From January 2021 till date, we have performed with the help of our all super specialty departments, whether it is pediatric surgery, whether it is general surgery, whether it is urology, whether it is gastroenterology, whether it is neurosurgery. They are doing a tremendous job. I mean, they had the apprehension, because previously what has been said earlier, that whenever a patient comes with hemophilia to the surgery, there was so scared that nobody was going to touch. There was some sort of fear psychosis that if you touch a hemophilic, you will bleed to death. So that fear psychosis has gone because of the continuous awareness, continuous, these medical educationers, we are trained, and much is needed more, still is needed more, so that our all doctors get about aware of this, that no, there is nothing else, everything is available. So you can see the major surgeries. We have performed 14 major surgeries, and we have performed so many these minor surgical procedures, even dental procedures. We are doing that. So it is only because of the availability of the super specialty hospital with us, associated hospitals with us, because ours is a tertiary care center, and these are the emergencies we are dealing. So from 2020 to 2022. So 3 ICHs we have managed their survival from 20 to 22, muscle, RTA bleeds, and GI bleeds, and 41 emergencies we have dealt in, and with the grace of God, all have survived. So this is the observation of the home therapy, that number of OPD daily visits are very drastically decreased, number of emergencies are decreased because of home therapy. Daily activity score, I mean the school absenteeism, labor loss, that has totally decreased, loss of work, and indirect cost has totally decreased, and the patients are very much happy. So you can see the smiling face of our persons with hemophilia. This is the now scenario. You have empty wards. You can just compare the previous because they are at home and they are relaxed. So take home message is hemophilia is not a disease, it is a genetic bleeding disorder, just a deficiency of clotting factor. Regular replacement is a global standard of care which has been proved. And comprehensive care centers are the important things, what we call as multidisciplinary treatment, and home therapy is the best treatment, probably it is well guided. I will share some videos about these patients who are on these factors. You can play the videos and their feedbacks. Audio.
गोडनी कोच का ठीक कुन जोड़स वोड़स मा करन तत पे दाग बिल्कुल नहीं कह पकन हम बासी फर्क कह बाकी ठीक बासन
मतलब और कलास या
अच्छा
पाने में खाली अक
ड्रेसिंग कर तो गो ठीक मतलब अत लोग तो कोस काल पे लोगमुत से गई पाने फर्क गो अम सैटिस्फाइड दपान ना यह ठीक चलो पक्यू चलो गोर पाक से
They can walk. These are small children. They are.
आपने इसको ये हेम लिब्रा स्टार्ट किया, आपको क्या लगता है बच्चे का कैसा रिस्पांस कैसा रहा?
मैम तब से बढ़िया लग रहा है।
मतलब क्या पहले कैसा होता था, अब क्या आपको लग रहा है, क्या फर्क लगी आपको पहले में और अब में?
पहले जैसे ही खेलता था कूदता था उस समय ज़्यादा वो होती थी
Going to the school at 13 years of age. So these are different videos and.
वगैरह होते थे
ज़्यादा वो हाँ.
One second video. So this is the hemophilia A with inhibitor. This is a very cute child. So he's
हाँ आपको पहले क्या वो इंजेक्शन लगाने से क्या आपको लग रहा था वेन नहीं आ रही थी अब इससे ठीक
So this is the another patient who has a hemophilia And this is the last video how the life has changed because of this drug. You can see our people are playing cricket and they are moving, they are doing wonders. Everybody is saying like this and everybody is experiencing. Although there were a lot of challenges in the beginning, there are so many rumors about thromboembolism and all the complications. But what is reality, truth always wins. So there is a humble submission to the respected PMC Dean because our hemophilia daycare center is being, that has to be disbanded, that has PHE has, this R&B division has made that as an unsafe building and has to be demolished. So we want that our PMC team will give us a renovation of new BDC and a place where the center can be shifted safely. Thank you, ma'am.
Thank you very much, Dr. Bilal, for an excellent talk delivered and as well as excellent work at your college. Really, we congratulate you, and that will inspire so many young doctors, those who are still not involved in hemophilia. So take an interest. You can do. Sky is not the limit. There are lots many things you can do. And congratulations for this. Your home therapy idea is also. This is also we should accept. There are so many apprehension for not to give the home therapy, but it is very easy. Learn from the experience. And I call both of the speaker on the dais for the question answers from the Dr. Hitha and Dr. Vilay. We'll take 2 questions from the audience to our speaker, our speaker.
For Dr. Bilali, in the case of breakthrough hemorrhage, there is accident, patient on emicizumab. Have you any time given loading dose of emicizumab with that condition, you go for the factor replacement therapy.
It depends upon whether your patient is hemophilia A with inhibitor or without inhibitor.
No, A with inhibitor.
With inhibitor.
Yes.
So usually we got a lot of traumatic cases, but fortunately I don't know what is the wonder of this drug. They didn't bleed. We didn't need any factors, bypassing agent or factor 7.
Oh no.
No, because we had cases they have throughout cuts with the emicizumab, but as normal people bleed. So they
ever in your mind came that you should give extra dose of emicizumab that situation?
No. Because emicizumab is a long-acting prophylaxis.
Yes.
So it will not help out. So definitely, if it is bleeds, then you have to use a
No,
bypassing agent.
that is okay. But loading dose, because you know
There
the
have been
concept
some
of loading
studies
is
are there. Some studies are there. They are
Yes.
trying that maybe we are pushing a loading dose at that very moment. That those trials are still going on.
Okay, very nice presentation.
I think I would just like to add one thing to what the gentleman said regarding if the patient has got certain inhibitors. In that case, that basically applies to if there is an acquired inherited disorder. In that case, what usually should be done is that apart from giving, say, for example, we give the replacement therapy, pheresis might be needed sometimes. For example, a patient of SLE, for example, comes up with an acquired bleeding disorder, and the hemophilia level and the inhibitor level is quite high. In that case, maybe pheresis would help, because some centers do that actually.
Hello. Hello, everybody. Good evening. Dr. Bilal, it was great presentation from your side. Really, it was magnanimous and wonderful. I want to compliment you first of all and congratulate you that you are organizing such events, such medical topics you are arranging for the whole medical fraternity. For that, once again, congratulations. I don't want to ask you any question. Just it's a knowledge sharing platform, medical, professional, and ethical. So this is not a question to you, my friend, just a knowledge sharing. I have gone through a study, Indian-American comparative study of hemophilia A, because as we know, it is hemophilia A is common in males. The study was conducted in live males with hemophilia A. They had different scenarios, they have different data. American data is 10 per lakh population, live male births. And in Indian scenario, it is only two per 1 lakh population, live male births. What would be the etiopathogens occurred? Because American, as you know, and we doctors all know that they have a good infrastructure, those American people there, and comparatively in Indian scenario, we don't have like that. What would be the etiopathogens of that? Because they have a big ratio comparative to our Indian scenario. We have 2, they have 10. What do you think, my friend? This is a question, as I said, this is a knowledge sharing platform.
No,
Thank you.
Yes. I don't agree with this because the incidence and prevalences throughout the world is same. It is 1 in 10,000 population and 1 in 5,000 male births. So it should be clear cut, right? So only thing why they are saying 2, I don't know, because the diagnostic facilities are very good there. They are picking up the more cases and we are lacking. And because the diagnostic facilities are very limited, because the coagulation labs throughout the country is very less. And the awareness is also less. Now the awareness is going on, the India is going behind. Now exploring, as I have said already, 2007, what the scenario was is not like that in the current era. So it is like that, it is only the rate of detection. How you detect and then the things move on like it. So only, as said in my slide, only 20% of the people with hemophilia in India are detected. 80% still we are missing. So that is only because of lack of awareness at the level where because it has been said that if the mind doesn't know, eyes can't see. So you have to have awareness about the hemophilia and the bleeding disorders and the diagnostic workup and the clinical history scenario, how to pick up the more bleeding disorders and how to set up the more coagulation labs, because coagulation lab is a very sensitive issue. It's not like CBC and doing biochemistry tests.
Yeah.
It is something super specialty coagulation testing. It needs a lot of, sensitive methods, from collection to transportation to analyzing and to interpreting. So there are so many challenges for that. So that is the era. I think the overall world, because the World Federation of Hemophilia is guiding the whole world, and the incidence and prevalence is same, whether it is in US or whether it is in India.
Thank you, sir.
You can add on that.
Sir.
I just need to add, because what Dr. Bilal has said, it'll bring some clarity. So this study of 10 cases per 1 lakh and 8.9 cases and 2, this has been brought by Alfonso Lorio recently, a few years back. And the reason he brought it was from the data of the registry in some European countries. The difference between what we have been saying right from the beginning, 1 in 10,000 or 20,000 male or boys, is the incidence. That incidence happens to be same across the world. So incidence would be when newborns are born, you diagnose them the cases. Prevalence would be what is existing now. So that incidence has grown with the treatment administered. If it was a better treatment in America, they got a better treatment. If it was not so good here, they didn't get it. So the cumulative incidence accounted for the deaths that might have occurred in between would give rise to prevalence. So the prevalence has been calculated on a modular basis there, and they talk about it, 10.3 per lakh, and that actually gives rise to a very different scenario. That is the number of hemophilia in the world, which was expected to be 271,000 as per the latest figures. And the number of bleeding disorders is 470 something. Now that is supposed to be tripling. So the numbers actually might be more, but the incidence would remain the same.
Thank you, sir. And thank you, Dr. Bilal. And so we'll be taking all the questions we'll discuss it during dinner. So we'll be finishing with this session. Thank you. Thank you so much.
I think we'll go ahead with the inauguration ceremony first, and then we'll go with the scientific session.
Okay. Thank you, sir, for sharing your experience and knowledge with us. We will be holding an inauguration ceremony. For this, I would first like to request the organizing secretary, Dr. Fahim Masnoor, Associate Professor, Department of Pathology and GMC Srinagar, to come to the stage and felicitate the chief guest, guest of honor and dignitaries as I call upon them. Professor Dr. Ruby Rishi, Principal and Dean, Government Medical College, Baramulla. She is the chief guest of today's event. Thank you, ma'am, for your presence. Our guest of honor, Professor Dr. Ifat Hassan Shah, Principal and Dean, Government Medical College, Srinagar and Associated Hospitals. Thank you, ma'am, for joining the occasion. Dr. Naresh Gupta, Chairperson, Hemophilia and Health Collective of North. Thank you, sir, for your presence. Dr. K.K. Cole, President, Hemophilia and Health Collective of North. Professor Dr. Sheikh Bilal Ahmed, Organizing Chairperson, Bleeding Disorder Consensus Meeting 2024. Also the Head of the Department Pathology, GMC Srinagar. Dr. Ramendra Pal Singh Sibia, Vice Principal, GMC Patiala. Dr. Neetu Kukkar, Medical Superintendent, Guru Gobind Singh Medical College and Hospital, Faridkot. Mr. Syed Majid Qadri, President, Hemophilia Society of Kashmir. I request Professor Bilal to present a book to the Organizing Secretary, Dr. Fahim Mansoor. I now request our chief guest, Professor Dr. Ruby Rishi, Principal and Dean, Government Medical College, Baramulla, to come to the stage and address the audience.
Assalamu alaikum and good evening to everyone. Respected Principal Dean Government Medical College, Principal and Dean Government Medical College, Srinagar, Professor Ifat Hassan Shah, our dignitaries on the dais, Professor Naresh Gupta was very, very close to us because he was the pioneer who held our hands in establishing a hemophilia care center at GMC Srinagar. Professor K.K. Kolsa was been a very colleague and associate, and we have been on various training programs and such meetings together and to learn for hemophilia care. And I also welcome all our dignitaries from Patiala, Ludhiana, Amritsar, and all parts of India, all dignitaries, experts, faculty members, staff, and most of all, our, we can say, representatives from the society. It gives me immense pleasure to be here today on this bleeding disorder consensus meeting, which has been organized by the Department of Pathology, Immunohematology, and Blood Center, GMC Srinagar, and the Hemophilia Society of Kashmir. I congratulate Dr. Bilal and his team for putting such excellent efforts in organizing a very well-coordinated, meaningful, and a very learning event at GMC Srinagar. And here today we have been seeing from the afternoon, so much has been talked about the progress of hemophilia care at GMC Srinagar, as well as the experiences shared by our experts from various parts of India. Honored guests, respected colleagues, it is a privilege to stand before you today as we acknowledge the advancement in hemophilia care, a cause that has been close to my heart for many years. I recall the time before 2012 when sadly hemophilia patients in our region suffered greatly due to lack of proper treatment. The absence of a structured care approach led to lifelong disabilities, uncontrolled bleeding episodes, and a significant reduction in the quality of life of these individuals. In 2012, as the head of the Department Pathology and the Blood Center at Government Medical College, Srinagar, I had the honor of leading the establishment of the Hemophilia Daycare Center, a clinic dedicated to changing the course of hemophilia treatment in the valley. This clinic was not just a project, but a mission to ensure the patients with hemophilia were given the care, attention, and most importantly, the treatment they deserved. Before the clinic's inception, patients had limited access to proper diagnosis, facilities, treatment facilities, and the treatment options were very limited and restricted. However, the expertise of great partners like Professor Naresh Gupta and his team and his dedicated team played an instrumental role helping us build this center. They generously provided hands-on trainings, conducted workshops at our center, and shared invaluable insights on how to follow the right protocols of treating hemophilia patients. In addition, our staff members were deputed to the Hemophilia Care Center and Hematology Department at CMC Vellore for specialized training, enabling us to deliver the world-class care to our patients. A critical milestone in transforming the lives of the hemophilia patients was the introduction of the government's free drug policy, which played a vital role given that hemophilia drugs are not, we can say, cost effective, but they are prohibitively very expensive, thanks to that policy. And as you have seen in our previous slides by Dr. Bilal, at that initial, we can say, phase, we were hardly able to register 90 or 93 odd patients, and it gives me immense happiness to see here that we have grown now to more than 400 patients, a testament to the far-reaching impact of accessible care. Under the collective efforts of the team in the Department of Pathology and Immunohematology, a center has grown immensely in its capacity to diagnose, to treat, and to provide ongoing care. This coordinated effort has saved numerous lives and prevented lifelong disabilities. Over these years, there has been tremendous progress in hemophilia care. Today we have access to cutting-edge drugs that offer greater efficacy and long-lasting results. The availability of these drugs, coupled with the advancement in diagnosis and patient management, has dramatically improved the prognosis for hemophilia patients. Complication management and even disability prevention are now achievable goals that we once thought were out of reach. I stand here today not only proud of the progress we have made, but optimistic about the future of hemophilia care. I trust that Hemophilia Clinic will continue to grow, flourish, and touch the lives of countless patients under the capable hands. My hope is that with every passing year, the lives of hemophilia patients will be transformed through coordinated care, compassion, and cutting-edge medical science. It has been a journey, and I look forward for seeing even greater heights achieved by this center as we strive to give our patients the best possible quality life. With these words, I congratulate the organizing team once again for organizing this event, and I also wholeheartedly welcome all the delegates and guests or experts who will be here with us sharing their knowledge on hemophilia care. Thank you very much.
Thank you, ma'am. Before I invite the second guest, I request Medical Superintendent, SMHS Hospital, Dr. Tasneem, to please join us on the stage. I request Dr. Fahim Manzoor to present bouquet to the ma'am. Thank you, ma'am, for joining us. I now request our guest of honor, Professor Dr. Ifat Hassan Shah, Principal and Dean, Government Medical College, Srinagar and Associated Hospital, to take the dais and address the audience.
Good evening. Worthy Principal Dean, Government Medical College, Baramulla, Professor Ruby Rishi, Professor Naresh Gupta, Chairman, Hemophilia Health Collective of North, and Scientific Committee, Chairperson, Scientific Committee, Professor K.K. Cole, President, Hemophilia and Health Collective of North, and ex-HOD of Department of Pathology, Government Medical College, Jammu. Professor Sheikh Bilal, Organizing Chairperson. Mr. Said Majid Qadri, President, Hemophilia Society of Kashmir. Dr. Ramandeep Singh Sibia, Vice Principal, Government Medical College, Patiala. Dr. Neetu Kukar, she's here. Medical Superintendent, Guru Gobind Singh Medical College and Hospital, Faridkot. Dr. Tasneem Shaukat, Medical Superintendent, SMHS Hospital, and Dr. Fahim Manzoor, Organizing Secretary and Associate Professor, Department of Pathology, GMC Srinagar. Guest faculty, delegates, and the ladies and gentlemen, it's a pleasure to be here on the inaugural function of the Bleeding Disorder Consensus Meeting 2024, organized by the Department of Pathology and Hemophilia Daycare Center, Government Medical College, Srinagar, and the Hemophilia Society of Kashmir, and the Hemophilia and Health Collective of North. It is an important day because this is the conference where all of us can deliberate what is new in the treatment of hemophilia. I remember in our childhood, hemophilia was considered to be a disease, and once we were students too, a disease which was very distressing. And today, as I was just seeing Dr. Bilal's slides, like on the topic, our experience, and today I can see happy children. What more can be a happier day for all of us here who are deliberating on this important issue than to see that these kids can live a normal lifespan, at least the quality of life of the patients afflicted with hemophilia has really changed. So that is something that we should all feel happy about, and with the advancement of science, these children can also play, and once they grow up as adults, they can also enjoy the beauty of life. So I congratulate the Department of Pathology, headed by Professor Sheikh Bilal, and the whole faculty of the department, who have played a proactive role in organizing this conference, and also continuing the good work that Professor Ruby Rishi did in the department. I remember the day once I was also invited for the inauguration of the Hemophilia Daycare Center way back in 2012. And I still remember that day. And today, as I see it, over the years, it has grown so much. So big round of applause for Professor Ruby Rishi. She's the person who would be after everybody, that she should have this thing for her department, that thing for her department, and this is the result. So it all looks worthwhile. The effort that Professor Ruby has put into it is really commendable, and we should appreciate it. And the legacy that is there, that has been now carried forth by Professor Bilal, is also something that we should all feel quite appreciative. The whole faculty is of the department is always very proactive, and we should all appreciate it. The advances in the treatment of hemophilia, like I was seeing the monoclonal antibodies that have come up. Nowadays, these monoclonal antibodies, this treatment and the biologicals, they have changed the game. They are the game changers in every aspect. I'm a dermatologist by profession, so we see the game change once we treat our patients with pemphigus and even other disorders where we use biologicals. So you can see the perceptible change. And here also the newer therapy, like the monoclonal therapy that has come up, the results look quite, although there are issues with them also, but then the results are quite promising. And we at GMC Srinagar believe in healing our patients, and we are trying our best. There was some issue somebody pointed out about the space. Of course, we are all at it. Our patients are our priority. Their good health is our priority, and especially for our hemophilia patients. They are all those patients who are afflicted by this disorder are very dear to all of us. And we are looking for an alternate space, and in consultation with of course, with the Department of Pathology. So I wish all the delegates, they must have had a very good scientific feast today, I suppose, seeing the scientific program where your faculty all across the country who have come here. So the scientific feast must already have been there, and I hope there's one more session after the inauguration. So I hope that all of you enjoyed that session too. Thank you.
Thank you, ma'am, for your kind words. I now request Dr. Tasneem, Medical Superintendent, SMHS Hospital, Srinagar, to kindly say a few words.
A worthy Principal, Dean, GMC Srinagar, Professor Ifat Hassan Shah, Dr. Ruby Rishi, Professor Dr. Ruby Rishi, Principal and Dean, GMC Baramulla, distinguished guests, members of the audience, distinguished guests off and down the days, a very good afternoon to all of you. Forgive me the slight disconnect that I seem to feel here, because I've just come from hospital and I wasn't sure I would be able to attend. It's a pleasure and an honor to be here among such distinguished guests, along with people who have worked so much for the hemophilia patients of this state. I remember when I was in college, we had just one hemophilia family. People used to come. I remember they were very, we used to remember them by face because they were the only people we would see. But now, thanks to advances in medical technology and the efforts of everybody here, including Dr. Ruby Rishi, who's done a stellar job, and Dr. Bilal and his department, then the support that is available in forms of medicines and in newer modalities of treatment, we are progressing, and I hope that the academic sessions as well as the other deliberations will be of great help to everybody in enhancing their clinical skills and helping all of us to develop empathy towards the patients who are now almost normal. And because the treatment has now gone from, you can say that preventive, now it is more prophylactic, and then that increases the, living, how to say, living span, lifespan, and makes them more active and makes them more able to enjoy life, as it should be for every human being, and they are no exception, of course. Thank you so much for inviting me. Thank you very much.
Thank you, ma'am. I now request Dr. Naresh Gupta, Chairperson, Hemophilia and Health Collective of North, to say a few words.
Good evening. I feel humbled to be here now in the evening, in the company of so many stalwarts, luminaries, not only in hemophilia, but in any patient-centered approach and care. what they have done for hemophilia is really remarkable. And Dr. Ruby Rishi, principal of the college, I had association and I saw that commitment and passion in her eyes and heart. And she was so joyous when all that first talk of the factor 8 got consumed, and she says, I've already placed the new order. And now I also see the new principal who has taken over is carrying it forward equally well, and along with the help from medical superintendent. It's really, really remarkable. And Dr. Kaul, Dr. Bilal, and Majid, I have all seen them. Of course, Dr. Neetu, whenever I go to Faridkot, I always get that vibes which I get here also, the spiritual vibes. Professor Sibia, I have found he is all-arounder. And that is very important. That is very important for a disease like hemophilia, which we tend to consider as a very rare disease and in small number. But take it from me, the implications of knowing, advancing, teaching, and treating this disease is so widespread that the money is all well spent. We used to face the same dilemma of spending so much money on so few people. But if you look at the hematology and hemostasis in particular, which is very human conscious, human resource conscious testing, it has so many applications. It has so many applications. You take it pediatrics, you take neonatology, ICU, respiratory, gastro, hepatology, everywhere it is there. And those benefits we provide to the other departments much more than the diagnostics we do for hemophilia. Similarly, the treatments that have taught us in hemophilia are so varied that we had the standard half-life factors, extended half-life factors, and non-factors. Imagine using a monoclonal antibody for hematology. I can't think of it. Two persons got the Nobel Prize for that. It's so remarkable. And that particular monoclonal antibody, emicizumab, has now caught up with another national problem of ours, and that is the death in the women from postpartum hemorrhage. The postpartum mortality, which is so high, the commonest cause is hemorrhage. And they can't manage it because the infrastructure for testing is not there. Drugs are not there. And this hemophilia drug, which we've been hearing for the whole day, emicizumab, has come to rescue, and few months back it has been approved for managing serious postpartum hemorrhage. So it is so varied. The learnings from hemophilia is very, very varied. At an administrative level, I find that such explosion of new knowledge comes with anxiety. Comes with anxiety and uncertainty, because the research that has been done has not been able to catch up or keep up with the number of products that are available. And hence, there might be some doubts as to which product to take, which product not to take. We have, of course, come out with the first national guidelines on procurement of these drugs. But more important thing is the benefits of treating this disease from whatever drug you give are unparalleled in medicine. These are the patients who would have died in their first decade or second decade. And it is a kind of resurrection from their grave that you make them climb Mount Everest also. That is the power of this medicine. And if that is the power of this medicine, it should never be denied to any hemophilia. So those unparalleled benefits make it mandatory that we keep providing them the treatment. And it is not a prophylaxis, as he said. It's just like regular replacement therapy. We give insulin for diabetics. So if we keep providing that, their lot will be much better. If we keep teaching this in the schools, colleges, departments, pathologies, and dermatologies also, ma'am, it would be good, because the collateral benefits are very widespread. And I'm very happy to see the progress being made in Kashmir as the head state of the country. And it is really remarkable, and I congratulate all of you sitting on this diet. And currently, Dr. Bilal and Majid. Majid is such a committed person. I call him not dedicated, he's devoted. And we have Sandeep and many others from the neighboring states who also come. So I think the joint power is actually giving dividends and the bright future. Thank you and congratulations to all of you.
Thank you, sir. I now request Dr. K.K. Cole, President, Hemophilia and Health Collective of North, to say a few words.
Adab, Namaskar, good evening. Chief guest of this event, Madam Dr. Ruby Reshi, Principal and Dean, GMC Baramulla. I was fortunate enough to share very important moments during our service career. Principal and Dean of this prestigious institution, Government Medical College and Associated Hospitals, Srinagar, respected Madam Ifat Hassan Shah. She is one of the academic personality, and under her tenure, I think there must not have been any month where some activities have not been there. We have heard several times whether it is a surgery department, whether it is a urology department, and so on. So she is one of the pillars of all the happenings and what we have seen today, this August gathering, and the wonderful systematic approach while dealing session after the session. This was only possible because of the overall leadership of Madam Ifat Hassan Shah. And of course, our Commander-in-Chief, HSCN, Dr. Naresh Gupta ji. He just passed out one line very softly that we formed the guidelines. But don't think that was an easy thing. I'll just highlight one point on that later on. And the other dignitaries on the dais, Dr. Tasneem, Madam, Medical Superintendent of this prestigious SMHS hospital. Why I'm saying? Because I have seen legends coming out of this institution, and the chair where Madam Ifat Hassan is occupying, that has been occupied by renowned personalities of this institution. My family, most of family members are doctors, or many of them are products of GMC Srinagar. They were students, they were in faculty. But I was the exception. I had to represent another prestigious institution, that is GMC Jammu. So I was there as student, as a resident, as faculty, as head, and moved on. Well, Dr. Neetu Kukar, there's no need to, introduce her. She is medical superintendent in the hospital under Baba Farid University of Health Sciences, and she is occupying many more administrative posts. It will take me 5 minutes if I highlight what she is, occupying. And I think you leave at 8 o'clock. I've seen you there, and कब आएंगी मैडम पता नहीं. So there. And at the same time, with the help of Dr. Varun Kohl there, who is also, I think, deputy medical superintendent or something. So it's एक team बनी हुई है वहाँ पर. Then other dignitaries, I think you forgive me, I will not be able to take my friend from Patiala. His previous head was a very close friend of mine. And I have been to Patiala a number of times. One of the pillars of support for hemophilia patients in Kashmir, Mr. Majid Qadri Sahab, as rightly pointed out, he is really a devoted person. I have seen his office, how they are working. Last month I had come. I came to in his office around 5, and I think we left at 8 o'clock, but they were still there. They were still there, preparing everything for one day. So I will just restrict my speech, and I have noticed certain points. And one, Mr. Larson told something which I was forced to think about. And I have noted some of the points. I will skip because we will discuss several times these issues, technical issues, tomorrow also, and today also, we also discuss there. Now, these academic, updates, CMEs, and conferences, which we are holding on a regular basis, are in fact forming these are one of the parts of academic activity, which is in fact one of the core responsibilities of our national-based organization called HSCN. The scientific sessions, these topics, which have been kept for discussion, have been so designed that they are relevant for the current needs for the doctors associated with hemophilia care. And our aim is to give momentum to the transformational research, learning from national and international faculty while discussing different strategies in the management of hemophilia, health economics, treatment outcomes, and recent developments. Another focus will be, of course, on the holistic approach, the importance of holistic approach in the management of hemophilia, and of course, emerging trends. Dr. Naresh softly said we framed these guidelines. But let me tell you, this was not easy. The esteemed executive members of HSCN, they worked very hard over a couple of months, had several discussions, meetings, physically, virtually, and ultimately, we were able to frame these guidelines, and officially, we released in December last year. This was possible only, and I repeat, this was possible only because of the major role played by our Commander-in-Chief, Dr. Naresh Gupta. His depth of knowledge, his constant advice, and a vast experience at national as well as international level were utilized in framing these guidelines. Dr. Naresh Gupta, I consider him, he is a heavyweight. Don't go by his physical weight. He must be 65 or 68 kgs, not maybe less. But he's a heavyweight academic as well as professional champion, because he carries himself huge academic weight and tremendous professional experience. And I'm happy I have been associated with him for the last several long years. Now, Mr. Larson said that we are recognized by hemophilia. I liked his second line, that tomorrow people will say they had hemophilia. You see, hemophilia is a challenge. It is not a punishment. I'll just highlight this statement later. And you see, hemophilia does not define me. It has made me who I am. Hemophilia teaches us to be brave, to be strong, and to never give up. Coming to this first statement, that it is a challenge and not a punishment. Challenge is not only for the patients, challenge is for all of us. It is challenge for the doctors who are treating them. It is the nursing staff which is associated and infusing them intravenously. This is not an easy job. It is a highly skilled and technical job. And representatives of various hemophilia societies, it is a challenge for them. Policy makers, officials of hospital administration, and overall, and above all, the government of the region. We have to come forward, every one of us, as one team and be a support system for all the affected persons of hemophilia. And this we have to do continuously, persistently, till a day comes when the cure is possible. If we do not do this, because if we do this, we are minimizing the miseries. We are making the patient independent. And as Dr. Naresh said, there is a total resurrection from a crippling person becoming a normal. Then it is not only a scientific reason, it is a moral and ethical reason for all of us to treat them. And if we do not do this, I again repeat, if we do not do this, then definitely we are giving punishment to these affected persons. They are born with inherited defective gene on which they didn't have any control. So why punish them for no fault of theirs? And in the end, for all the representatives of hemophilia, please take a message from HSCN today and tell your patients that HSCN is telling you that you are stronger than you seem. You are smarter than you think. You are braver of the all, and twice as beautiful as you ever imagined. So this must be always given to them along with the parents. I have seen broken families in hemophilia. So both the parents as well as the patients should be encouraged, because it is a miserable, lifelong disease. And we have to keep them encouraged emotionally as well as psychologically. And in the end, my friends, my colleagues, brothers and sisters who have come from outside the J&K state, remember, this is middle of October and you are in Kashmir. Please spare some time and enjoy the beauty of this Kashmir Valley. You will always remember October in Kashmir. You see, you will automatically feel those are called as happiness hormones and endorphins, dopamine, serotonin I think oxytocin, which is known as, perhaps we as MBBS student, we used to call it love hormone, oxytocin. You see, these will be released and you will automatically feel a joyous feeling, a feeling of well-being. You know, yesterday, when our plane was flying high and crossing the Pir Panjal range, and we were approaching the Kashmir Valley, I was observing the natural beauty of this paradise on earth. And immediately, one famous Bollywood song came to my mind, sung by legendary singer Mr. Muhammad Rafi Sahab, perhaps written lyrics by Mr. R.L. Rawal, and music was perhaps Soni Komi. हर चेहरा यहाँ चांद, हर जर्रा सितारा, ये वादी कश्मीर है जन्नत का नज़ारा। तो हुजूर घर जाने से पहले इसे देखिएगा ज़रूर। आदाब, शुक्रिया।
Thank you, sir. I now request Professor Dr. Sheikh Bilal, Organizing Chairperson, BDCM 2024, to say a few words.
Respected Chief Guest, Professor Ruby, GMC, Principal Dean, GMC Baramulla. Guest of Honor, Professor Ifat Hassan, Principal Dean, GMC, Srinagar Institute Hospitals. Dignitaries on the dais, dear faculty, patient advocacy groups, and my dear friends, colleagues, ladies and gentlemen, a very good evening to all of you. So it is my pleasure and great honor that we are organizing BDCM 2024 by the Department of Pathology and Hemophilia Day Care Center under the aegis of HCC and HSK in Srinagar, because whenever I go outside, many of my colleagues have forced me that they were very eager to come to Kashmir. So many had apprehensions also about the Kashmir. Is it safe? Is it really safe? So I was really motivating them. Please don't watch the news. Come to, I'm sincerely telling you, you come once. Once you come, you will then regularly come. So those I think what I got the feedback, the first time who have visited the Kashmir, I was just discussing during the tea. They said now we'll come regularly. So Kashmir is known for the hospitality. Kashmiris are known for the hospitality, and really we are blessed to have such great stalwarts and healthy minds and brilliant brains who are having the prosperity of patient care, who have come all across the country. We are very much blessed to have them here, and it is really an honoring moment for us. And we will definitely are available for them. We have given them that you have any sort of difficulty, kindly call us. So we don't want them that they should, we want them that they should come in again and again. And they have really, graced this event, and because of their presence and because of their presence. So these forums are, invaluable platform where, the healthcare professionals, the patient advocacy groups, the end users, the administration, and all those people come in a collaborative mode, because the disease we are talking about, which is hemophilia, is a rare bleeding genetic disorder. So very less is being taught in UG and PG level. So these are the forms, but the stone which has been laid down by the Dr. Professor Naresh Gupta in India. So that legacy has very much grown up. I remember 2007 and 2024, there is a remarkable change. Even I always said that the credit goes also to the researchers. They are putting their blood and sweat in making the new molecules, the new drugs, the trials, they are going on. What the people were, totally dependent on blood and blood products, like FFP or cryoprecipitate, and other products. So that era has gone now. So the factors, plasma derived, I mean, third generation, fourth generation, the EHL, the non-factor, now there are mimetics or monoclonal antibodies, and the gene therapy. The transition is really moving very good. I mean, the people who have the human angle, I mean, they want to save the humanity. So my great salute goes to those who have done this work, and they are really saving the humanity. And what was the mortality of these people who are suffering from the hemophilia? If you go back in 2007 or 2014 and you compare it with 2024, there is a remarkable change throughout India. But much has to be done yet, because there are so many challenges. Hemophilia is not basically a medical defect. It has a lot of challenges. The challenges are at the level of persons who are dealing with it, the caregivers. So that is why we need a very important, the new concept is that comprehensive care center. So it is a all multidisciplinary approach. Hemophilia care is not single man's domain. Having said already that this is a multidisciplinary treat, what we in a new term call as comprehensive care centers. So comprehensive care centers are all modalities are there, starting from your lab physician, from your general physician, from clinical hematologist, pediatric surgeons, neurosurgeons, orthopedics, physiotherapy, nursing, paramedical, so all lab technicians, so they are all part of this thing. So if they work, even the radiology people are there. So everything in one roof, if they are there, so that makes a comprehensive, which is an European standard where you have to establish everywhere as a comprehensive care center. So I will not take much of time. So everybody is hungry, we are waiting for the dinner. So only thing is that this foam, kindly utilize this foam. We have not kept much of the master classes like in the UG level or PG level. So we have made a collaborative discussion. We have made much of the, our agenda as panel discussions. So take feedbacks, take that feedbacks from the treaters who are giving the treatment, because I already said that every patient is not a textbook. So there are many experiences that healthcare providers are having. Kindly share those experiences. Have the discussions, from the patient group. So just exchange the ideas, and so that as a whole, as one country and one treatment, we come up as a very good plan for the patients who are suffering with this bleeding disorder, so that they are also actively living their lives as other non-hemophilics. Thank you very much for it.
Thank you, sir. I now request Dr. Aminder Pal Singh Sebia, Vice Principal, Government Medical College, Patiala, to say a few words.
Thank you so much. Coming to the dais after stalwarts have spoken, I think I'll take a very short time. I'm really thankful to the organizers who have called us all the way over here, and for such a wonderful hospitality. Also, I'd like to say I'm not a hemophilia expert. It is one of the jobs I have been interested in. I'm really was called by Dr. Saab at Faridkot about 3 years back, then at Bangalore, but I missed all of them. तो उसका मेन कारण ये था कि मैं सोचता था कि यार एक दो बार तो यहाँ पे हमारी अपनी कॉन्फ्रेंस थी पटियाला में, तो मैं नहीं जा सका. फॉर द बेनिफिट ऑफ द पेशेंट्स आई विल टेक दिस लिबर्टी ऑफ स्पीकिंग इन वर्नैकुलर. तो मन में था कि ये सब कुछ पता तो है यार, जो नहीं पता होगा तो आई हैव अ फ्रेंड इन पीजीआई, पंकज, ही इज माय क्लास फेलो, तो उसको बुला लेंगे. एंड वी डिड अबाउट 2 to 3 conferences over there with Dr. Joseph John and Pankaj. पर यहाँ श्रीनगर में आके जब हम आप लोगों से सबसे इंटरेक्शन हुआ, पीपल फ्रॉम वेरियस स्टेट, स्पेशली जो आप पेशेंट्स हैं, जो उनके एडवोकेसी ग्रुप्स के हेड्स हैं, तो जो हमारी मेन प्रॉब्लम है वो मैंने रियलाइज़ किया सबकी एक ही है, लॉजिस्टिक्स. और बहुत कुछ सीखने को मिला मैडम से. शी गेव अस अ लॉट ऑफ करेज एंड के देखो हमारे वाइब्रेंट गुजरात में तो इस में आप इजीली अवेलेबल है. तो आई मीन ये रियली एक इंस्पिरेशन है हमारे लिए भी कि, एंड दूसरा कोई भाई साहब आए, वो हमसे बोले कि सर इस बार द सेंट्रल गवर्नमेंट हर एक पेशेंट के पीछे 1 करोड़ रुपया दे रही है, तो दैट इज़ अ ह्यूज अमाउंट. अगर हम उसको ले सकें तो शायद हीमोफीलिया का मैनेजमेंट कैन अंडरगो अ सी चेंज. तो जहाँ मैं बात कर रहा था पहले भी मैंने कहा कि मुझे आज तक मेरे सेंटर से किसी भी पीजी का, किसी भी फैकल्टी का ये फ़ोन नहीं आया कि हमें बता दो क्या करना है. दे नो इट वेरी वेल. फ़ोन एक ही आता है, सर फैक्टर ख़त्म होने वाले हैं, मंगवा दो जल्दी. सो दैट इज़ द क्रक्स ऑफ द प्रॉब्लम. आई थिंक बहुत सारा काम जो यहाँ स्टॉलवर्ड्स बैठे हैं, इन्होंने आई थिंक बहुत काम किया होगा गवर्नमेंट सेक्टर में ये सारे फैक्टर्स लाने के लिए. I think we should be inspired by these stalwarts to take these things forward now, so that जो हीमोफीलिया के पेशेंट हैं उनको ये लगे कि ये बीमारी उनको है ही नहीं. I mean, इंट्रावीनस इंजेक्शन लेने twice or thrice a week सच में मुश्किल है. And then you lose your vein, then finding even a vein becomes difficult. तो सिस्टमैप सबकुटेनियस है, बड़ा ईजी है लगाने में, once or twice a month max. तो दैट इज़ अ वंडरफुल थिंग. जैसे सर ने कहा कि फैक्टर 8 को ये मत समझो कि इट इज़ ओनली एसोसिएटेड विद क्लॉटिंग. इट इज़, इसके और बहुत सी चीज़ें हैं जो हमें वंस जो हमारे पेशेंट हैं इनकी लॉन्जेविटी बढ़ जाएगी, दे विल गो इनटू देयर 50s और 60s, तब हम रियलाइज़ करेंगे कि दे माइट कम टू अस विद एक्सेलरेटेड एथेरोस्क्लेरोसिस, हार्ट प्रॉब्लम्स, पेरिफेरल वास्कुलर डिजीज और कुछ भी. तब हम स्टडीज़ करेंगे सर मे बी कि हाउ टू यूज़ एस्पिरिन इन दीज पेशेंट्स, how safe it is, how good it is, what are the risks involved, mild को देना, moderate को देना, severe को देना, कितना देना, low dose, high dose, moderate dose. So let us plan forward and let us see how the things work out. पिछले सालों में, 10 सालों में, 15 सालों में जो सर ने, मैडम ने मिलके इतना अच्छा किया, और maybe people from our centers also worked a lot. But it's time कि we continue to take forward steps. सर ने कहा कि हमें बैठ नहीं जाना. We'll be dealing with newer problems over a period of time. ये disease जाने वाली नहीं है. Even if we have got the best of the genetic centers, prenatal diagnostic, whatever we may do, there is bound to be ये बीमारी के patient आते रहेंगे because of de novo mutations, females में भी और males में भी. So ये काम चलता रहेगा एंड प्रोबेबली हम लोग बेहतर तैयार हो पाएंगे. एंड आई थिंक वी शुड ऑल क्लैप फॉर द ब्रेव पेशेंट्स हु हैव बीन एंड्योरिंग दिस डिजीज एंड हेल्पिंग अस अ लॉट. थैंक यू सो मच एंड थैंक यू ऑर्गेनाइजर्स अगेन फॉर सच अ वंडरफुल प्लेस.
Thank you, sir. I now request Dr. Neetu Kukar, Medical Superintendent, Guru Gobind Singh Medical College and Hospital, Faridkot, to say a few words.
Good evening, everyone. I acknowledge the presence of Chief Guest, Dr. Ruby Rishi, Principal Baramulla, Dean and Principal GMC Srinagar, Dr. KK Kaul, Dr. Naresh, and dignitaries on the dais, off the dais, faculty members, and all the friends, senior and Hemophilia Advocacy Society members. First, I congratulate the Department of Pathology who have organized such a wonderful academic feast. It was really very wonderful to come to this place and attend this meeting. I think this meeting is mainly for the policy. We need to make policies throughout the country. There should be one policy. In all the states, there should be one policy. First meeting was held in 2023 at Chandigarh. Few agendas were made. After that, work was being done on those agendas. This year also, this is the second meeting. It's held in J&K. After that third meeting, I don't know where it will be. And we need to follow and make policies so that same universal protocol can be followed and all the hemophilia patient can be benefited from the treatment, and even we need to see the diagnostic part also. I feel this is like under the cover. There are few patients which are actually not diagnosed just because there are very few labs in the country. There are, I think, Dr. Varun was telling me there are 26 to 27 labs. There are labs in the states, and this is like very less number. And we need to develop more and more labs so that cases can be diagnosed and they can be treated accordingly. I again thank you, Dr. Bilal, for inviting me for this wonderful feast. Thank you so much.
Thank you, ma'am. I now request Dr. Fahim Manzoor, Organizing Secretary, BDCM 2024, to say a few words.
Ladies and gentlemen, as the organizing secretary, I will have to thank everyone, so just bear with me for a few moments. I mean, in our state, you can clearly see that majority of the dignitaries on the dais are women. And we have, you can clearly see our worthy principal of Government Medical College, Baramulla. We still call her our own, Ruby Rishi ma'am. It's a privilege to have you back here with us. We feel very happy that you agreed to it. And of course, the wonderful teacher that she has been, Professor Ma'am Ifat Hassan Shah. She's a professor of dermatology, and currently she is our worthy principal. And out of her, she's always busy, and she took out the time. We are very grateful to her. Then, of course, our medical superintendent, Dr. Tasneem, she just told us that she directly came from the hospital. Ma'am, we are grateful that you made up the time. Of course, what would I speak in front of dignitaries, teachers? And I in fact, confessed to Professor Naresh earlier on that, sir, I listen to your hemophilia lectures. When I need to learn about hemophilia, I basically listen to your lectures. So it's a great privilege for me to welcome you all the dignitaries. I can't mention everyone by name, but all of them you know, from the doyens of hemophilia, the greats of hemophilia, doyens of medicine, doyens of pathology, and from other domains. But most of all, what is more important, the various the various people who have hemophilia. You have truly graced the event, and these events are basically for you. And one of the persons that I would personally like to thank, there are two people that I would like to thank as the organizing secretary. First of all, the very dynamic HOD of our department, Professor Bilal. I think without him, it's been an honor and a privilege to be his faculty, and it truly rubs on all the faculty as well. And two persons that I would like to really mention by name, first of all, is my dear friend Majid. I mean, what do you say about him? He's an exceptional person, and he has got tremendous drive for the good. And of course, there is a certain person sitting by the door. Can you look at him, that gentleman over there? Dr. Anand Sethi. Give him a big round of applause. He's the one who arranged the things. And it would be criminal of me if I do not mention my own faculty. How can I not do that? I can clearly see the very dashing Professor Latif, as always. I can see Adil Saab. I can see ma'am, who has graced the occasion. I can see our professors. Dr. Shazia is there. Dr. Salma is there. Dr. Shima is there. My friend and my colleague, Dr. Sumaya, is there. And of course, I can see everyone is there. I think, how do I forget the names also now? because I have to speak quickly. Everyone, if I forgot some names, please do forgive me. And of course, ultimately, why do we conduct these CMEs? What is the rationale of having to spend time together? This is ultimately, it is to be successful. And what is it to be successful? As healthcare professionals, as doctors, as medics, what is it to be successful? Ultimately, to be successful is to know that even one person out there has breathed easier because you have lived. That is to be successful. And of course, I won't keep you for lunch for long. We'll just have a very short session of 10 minutes in which we'll be speaking of, it will be a scientific session, and then we'll of course go on to have dinner. Ladies and gentlemen, thank you so much for coming.
With that, we reach the final session of the day, von Willebrand disease, treatment strategies, and clinical hurdles. I invite the panelists for the same. Dr. Naresh Gupta to take the stage. Thank you.
So, smiling faces. Let us look at a different aspect of hemophilia. Problem of hemophilia per se. और अभी भी आपने देखा इनॉग्रल में भी विमेन एम्पावरमेंट देखने को मिली थी. क्या वो वाकई हीमोफीलिया से अछूती हैं? क्योंकि 2 एक्स क्रोमोसोम है तो दूसरा उसको मेकअप कर देता है. इस संदर्भ में इसके अंतर्गत हम एक चीज को भूल जाते हैं कि हीमोफीलिया में एक फैक्टर होता है फोनोलिब्रेन फैक्टर. उसका बड़ा अहम रोल है क्योंकि फोनोलिब्रेन फैक्टर और फैक्टर 8 दोनों के दोनों दोनों के दोनों बड़े अच्छे मित्र हैं. वन कैनॉट लिव विदाउट द अदर. सो यू इन हीमोफीलिया you will find VWF going down. In VWF going down primarily जिसको कि फॉनोलिब्रेन डिजीज कहते हैं, उसमें फैक्टर 8 ऑल्सो नीचे आ जाएगा. तो बड़ा ओवरलैप होता है. लेकिन बात हम उसकी नहीं कर रहे हैं. बात ये कर रहे हैं कि ये भी हीमोफीलिया की कैटेगरी में आती है. नेक्स्ट वाला. ये भी हीमोफीलिया की कैटेगरी में आती है. और अगर हीमोफीलिया की कैटेगरी में आती है तो आर वी मिसिंग समथिंग? नेक्स्ट. अगर आप वर्ल्ड हीमोफीलिया ग्लोबल सर्वे देखेंगे तो उसमें 4.5 लाख मरीज हैं जो कि ब्लीडिंग डिसऑर्डर के हैं, जिसमें कि 271,000 हीमोफीलिया के ए बी या अननोन टाइप है. एक छोटा सा उसमें फिगर और लिखा है 1,03,000 वो फॉनोलिब्रेन डिजीज के हैं. वो ये नहीं देखता है कि वो एक्स क्रोमोसोम से लिंक नहीं है, वो ऑटोसोमल है. तो वो विमेन में और मेन में बराबर आते हैं. बात ये नहीं कि वो बराबर आते हैं. हम लोग जानते हैं कि हीमोफीलिया एक सबसे कॉमन ब्लीडिंग डिसऑर्डर है, एक्स लिंक्ड. लेकिन अगर आप पूरे ओवरऑल देखेंगे ऑटोसोमल मिला के तो सबसे कॉमन जेनेटिक ब्लड डिसऑर्डर है फॉनोलिब्रेन डिजीज. हीमोफीलिया से वो कई गुना ज़्यादा है. आपने सुना कि 1 लाख में 10 हीमोफीलिया की प्रेवलेंस होगी. जो फॉनोलिब्रेन है उसमें 100 में 1 है. वो विमेन को अफेक्ट करती है, मेन को भी करती है, बट विमेन को ज़्यादा करती है. और उसके बारे में चर्चा करने के लिए हम थोड़ा समय लेंगे सो दैट वी कम टू द प्लेटफॉर्म कि ये सारी चीज़ें जो हैं जो हम दिखती है उससे थोड़ा परे है. अब अगर हीमोफीलिया से के कंपैरिजन में फॉनोलिब्रेन डिजीज कई 100 गुना है तो ये नंबर दिखना चाहिए. इवन वर्ल्ड हीमोफीलिया डे के नंबर में नहीं आता है. नेक्स्ट. तो डॉक्टर पारुल, व्हाट इज दिस मिस्ट्री कि फॉनोलिब्रेन डिजीज होनी कॉमन चाहिए पर दिखती नहीं है? नेक्स्ट. Next. Oh yeah.
Yes, sir. It is been on less diagnosed. However, it is called as a common bleeding disorder, common in male and female both. But here, as because it affects the von Willebrand factor is attached to the related to the platelet dysfunction, and there is a patient is this von Willebrand factor deficiency patient are also having factor 8 deficiency or less function of it. So most of the time it is been not diagnosed, not suspected as a bleeding disorder. And most of the time there is a history is very important. Mainly these patients are having a epistaxis is most common symptom. So when we get the patient of epistaxis or nasal bleeding, 68% patient are having epistaxis because of von Willebrand disease factor deficiency. And we, how many of you are suspect von Willebrand in any case coming to the for epistaxis? Most of the time we never. We suspect it is because of the sunstroke, or it may be because of some injury, and sometimes it is because of hypertension. So it is been not suspected. That is lack of knowledge is the main factor for not diagnose so commonly this disease. And secondly, as it affects the quality and life of the this thing, factor 8. So it has been also been not diagnosed in factor 8 deficiency also. So because one deficiency we found out, we just thought that we have diagnosed the case. But all the hemophilic patients, those who are having factor 8 deficiency, should be screened from today onwards. If we are not, should be screened for at least once to rule out von Willebrand factor deficiency. So these are the reason, because of lack of suspiciousness that this disease can be happening. And in menorrhagia patient, a female who is presenting as a menorrhagia is a chief complaint. How many of you are suspecting von Willebrand disease in that case? Less, very less. Very intellectual doctor may suspect, or something like a hematologist only are the appointed to suspect such disease. So we usually DUB, something like a polycystic kidney, PCOD, these are the things. So in these two common conditions, we should be more high degree of suspicion, and factor 8 deficiency patient should be screened for at least once for von Willebrand. So knowledge and the more suspiciousness and family history of bleeding tendency and simple bleeding tools can help you to diagnose these things. So that is the cause that the numbers are showing less.
That is why the numbers are showing less, because we don't suspect. एपिस्टेक्सिस होता है वो तो हो जाता है, नक्सीर आता है, कोई ऐसा चिंता का बात नहीं है. मेनोरेजिया होता है, एनीमिया हो जाता है उसकी वजह से, लेकिन कोई बात नहीं, ये तो कुदरती है. उसमें ये von Willebrand फैक्टर बहुत रोल प्ले करता है. और अगर इसका इलाज हो जाएगा तो वो जो एनीमिया होता है, जिसके लिए कि काफ़ी वीमेन और बॉयज़ एंड गर्ल्स, आई विल कॉल इट, क्योंकि ये भी बचपन से ही होती है, उनको ट्रांसफ्यूजन लेना पड़ता है आरबीसी का. डॉक्टर फाइव, ये जो नंबर कम है, सस्पेक्ट कम करते हैं, क्या हम टेस्ट भी कम करते हैं क्या?
सर, जहाँ तक ओवरऑल ब्लीडिंग डिसऑर्डर्स की बात है, आई मीन दीज डिसऑर्डर्स आर द वंस इवन दैट physicians have very little knowledge about. When we talk about inherited bleeding disorders per se, there is a lot of misconception regarding them. Lot of them go undiagnosed, but obviously things are improving. अब जो इसमें एक चीज़ होती है regarding von Willebrand's disease is that von Willebrand by itself, if we understand what von Willebrand is, von Willebrand is a large protein, it's a multimer basically. लेकिन ये इसकी एक कमाल की बात ये है कि in the circulation ये अकेले नहीं जाता है, it takes its friend along with it, which is factor 8. इसीलिए हम ये देखते हैं कि जब अब von Willebrand disease के there are various types, there is type 1, type 2, type 3. अब जो ये टाइप 3 डिजीज़ होती है वो बहुत सीवियर डिजीज़ होती है. हमारे पास 29 पेशेंट्स हैं वॉन विलेब्रांड डिजीज़ के. लकीली हमारे पास कोई उतना सीवियर फॉर्म नहीं है, विच बिकम्स अ चैलेंज टू ट्रीट इवन विद मॉडर्न थेरेपेटिक मोडालिटीज़. इसमें क्या हो जाता है कि जब वॉन विलेब्रांड बहुत ही कम है, ये अपने साथ अपने दोस्त को ले ही नहीं पाता है, फैक्टर 8 को ले ही नहीं पाता है, क्योंकि फैक्टर 8 बाई इटसेल्फ सर्कुलेशन में नहीं घूमता है, वो हमेशा अपने दोस्त के साथ घूमता है. सो व्हाट हैपन्स इज दैट व्हेन देयर इज अ सीवियर डेफिशिएंसी ऑफ वॉन विलेब्रांड फैक्टर 8 के लेवल्स भी बहुत कम हो जाते हैं. तो इसमें ये है, देयर इज अ फंक्शनल डेफिशिएंसी ऑफ फैक्टर 8 विच ऑल्सो ऑकर्स. और वॉन विलेब्रांड का जो अगर हम मेन रोल देखें, व्हाट्स द मेन रोल ऑफ वॉन विलेब्रांड इज रिगार्डिंग प्लेटलेट एडहीजन, यानी कि जो प्लेटलेट्स होते हैं वो हमारी जो वेसल्स हैं एंडोथेलियल वॉल्स के साथ चिपक कैसे जाते हैं, हाउ डू दे काइंड ऑफ एडहेयर टू द endothelial surface. Now what happens is that जब भी हमें for example if there is a breach in the endothelium, मानी breach in the endothelium का ये मतलब है कि जो endothelium की या blood vessel की जो अंदर की लाइनिंग है वो उठ जाती है. उसमें एक मोइटी होती है जिसको हम कोलेजन कहते हैं. जब कोलेजन एक्सपोज हो जाता है टू द फ्लोइंग ब्लड, क्या हो जाता है कि वॉन विलेब्रांड जो फैक्टर है वो होशियार हो जाता है. That what happens is that it attaches to the sub-endothelial collagen. अब this attachment, इसके बाद क्या हो जाता है, ये प्लेटलेट्स को बुला लेता है. इसके कुछ और भी दोस्त हैं प्लेटलेट्स, उनको बुला लेता है. जो प्लेटलेट्स लेकिन इसके साथ ऐसी दोस्ती नहीं करते हैं, उनके कुछ अलग ग्लाइकोप्रोटीन्स होते हैं, उनके कुछ चिपकने के एजेंट्स होते हैं जिनको हम ग्लाइकोप्रोटीन 1B कहते हैं, 2A कहते हैं, 3A कहते हैं, इनके कॉम्प्लेक्स नेम्स हैं. तो बेसिकली ये क्या करते हैं, ये मदद करते हैं वॉन विलेब्रांड को चिपकने को जो एंडोथेलियम ब्रीच हो गया है. फिर एक और चीज़ हो जाता है, फिर इसमें कोआगुलेशन कैस्केड स्टार्ट हो जाता है. वंस द कोआगुलेशन कैस्केड स्टार्ट हो जाता है, फिर इसको क्या करना है, एक फिब्रिन थ्रेड बनाना है. मैं इसको जितना भी सिंप्लीफाई कर सकता हूँ, जस्ट टॉकिंग इन लेमैन टर्म्स सो दैट मेजॉरिटी ऑफ द पीपल अंडरस्टैंड दिस. सो व्हाट हैपेंस इज दैट, तो इसमें अल्टीमेटली एक प्लेटलेट प्लग फॉर्मेशन हो जाता है. लेकिन मजे की बात यह है कि वॉन विलेब्रांड डिजीज एक वॉन विलिब्रांड डिजीज़ में क्या हो जाता है कि इसमें हमारा ब्लीडिंग, इसमें प्लेटलेट काउंट नॉर्मल रहता है लेकिन ब्लीडिंग टाइम इज़ प्रोलॉन्ग्ड, ठीक है। तो ब्लीडिंग, जो हम नॉर्मल ब्लीडिंग टाइम हम करते हैं, ब्लीडिंग टाइम इज़ प्रोलॉन्ग्ड। अब ब्लीडिंग टाइम सिर्फ वॉन विलिब्रांड डिजीज़ में प्रोलॉन्ग नहीं होता है, ब्लीडिंग टाइम कुछ और डिजीज़ है, जिसको एक को हम मेडिकली उसको कहते हैं देयर इज बर्नर्ड शोलियर सिंड्रोम, द अदर वन इज ग्लांसमैन्स थ्रोम्बोएस्थीनिया। नाउ एक जो होता है ये एडिशन डिफेक्ट है, दूसरा इज एन एग्रीगेशन डिफेक्ट। अब इनका एक सिंपल टेस्ट होता है जो हम मॉडर्न डे टू डे प्रैक्टिस में करते हैं, उसको हम कहते हैं RIPA, रिस्टोस्टिन इंड्यूस्ड प्लेटलेट एग्रीगेशन। हालांकि द फिजिशियंस वुड नो द एग्रीगेशन टर्म बाय इटसेल्फ इज अ मिसनॉमर बिकॉज बेसिकली इट्स नॉट एन एग्रीगेशन टेस्ट, इट्स एन एडहेजन टेस्ट, बट समहाउ द नेम हैज स्टक। सो व्हाट हैपेंस इज रिपा जो होता है इसमें देयर इज, जब हम ये रिस्टोस्टिन बेसिकली वाज डेवलप्ड एज एन एंटीबायोटिक, ये बेसिकली क्या करता है, ये इन विट्रो यानी कि बॉडी के बाहर इट मिमिक्स व्हाट हैपेंस इन वीवो। अगर हम रिस्टोस्टिन देते हैं तो ये क्या करता है, ये वॉन विलिब्रांड को एक्टिवेट करता है एंड देन वॉन विलिब्रांड हैज टू मेक इट्स एक्शन। सो इफ there is a conformational reduction in the von Willebrand levels, or there is a conformational defect in von Willebrand, yani ki if its levels are normal but it's defective, what happens is that aristostin induced platelet aggregation is defective. Lekin this is not the whole story. The other disorders which I talked about, Bernard-Scholier syndrome, Glanzmann's thromboasthenia, they also would have not Glanzmann's, basically Bernard-Scholier syndrome, it would again have a prolonged RIPA. Usme fir the basic thing that, kyunki ye clinical practice mein we see a lot of these things, how do you differentiate, say for example, how do you differentiate Bernard-Scholier from say a classical case of von Willebrand? Look at your peripheral blood smear. Giant platelets are characteristic of Bernard-Scholier syndrome and May-Hegelian anomaly. प्लस आजकल हमारे पास फ्लो साइटोमेट्री है, ऑब्वियसली ऑल आवर फिजिशियंस वुड नो व्हाट फ्लो साइटोमेट्री इज। उसमें जो हमारे पास दीज रिसेप्टर्स होते हैं, से फॉर एग्जांपल बर्नर्ड शोलियर सिंड्रोम में देयर इज डिफेक्टिव GP1 रिसेप्टर नहीं होता है, उसका एक एनालॉग है, एक मोनोक्लोनल एंटीबॉडी उसके अगेंस्ट बनाई गई है जिसको हम CD42B कहते हैं, वो उसमें डेफिशिएंट होती है। तो वो differentiate, that helps to differentiate, say, a pure case of von Willebrand's disease from Bernard-Scholier syndrome. So to answer sir's question, what happens basically in tertiary care centers, these even von Willebrand's is misdiagnosed. That's the primary reason, I think.
कितना सुंदर वर्णन कर रहा है, like a good artistic painting, आपको समझ आए ना आए, लेकिन ये जरूर है कि इसमें वाकई ही साइंस आ चुकी है और नॉलेज आ चुकी है। दूसरी चीज जो डॉक्टर फाइम ने कन्वे करना चाहिए, हीमोफीलिया का अपना डायग्नोसिस बड़ा आसान नहीं है। वी हर्ड अबाउट 24 सेंटर्स बीइंग सेड, वी आल्सो हर्ड सम ऑफ द स्टेट्स वेयर दे हैव द ट्रीटमेंट, उनके पास वो हीमोफीलिया का डायग्नोसिस नहीं है। तो ये डायग्नोसिस जो है von Willebrand डिजीज का, ये ज़्यादा कॉम्प्लेक्स होता है। ज़्यादा कॉम्प्लेक्स के अलावा ये ज़्यादा एक्सपेंसिव भी होता है। तो जब ये एक्सपेंसिव होता है तो लोग इसको दिक्कत कॉर्नर्स की हल्की सी ब्लीडिंग है। अनलाइक हीमोफीलिया वेयर यू कैन हैव माइल्ड, मॉडरेट एंड सीवियर, इसमें टाइप 1, टाइप 2, टाइप 3 होती है। टाइप 3 सबसे ज़्यादा सीवियर होती है, बट फॉर्चुनेटली वो सबसे कम होती है। नेक्स्ट स्लाइड प्लीज। वो सबसे कम होती है। टाइप 1 सबसे ज़्यादा कॉमन होती है, जिसमें कि हल्की ब्लीडिंग होती है। जनरली विमेन को ज़्यादा होती है, मेन को कम होती है। नेक्स्ट, ये और दिस वी हैड डन ए स्टडी ऑन, जब हमने शुरू करा था हीमोफीलिया तो हमको ये लगता था कि ये von Willebrand का भी हमें देखना चाहिए कि कितना है। तो हम लोगों ने गायनेकोलॉजिस्ट से मिलके, जो प्यूबर्टी मेनोरेजिया होता है, प्यूबर्टी मेनोरेजिया मतलब जब से उनकी वो मिनार्की ब्लीडिंग शुरू हुई है, मिनार्की तब से ही ब्लीड वो चल रहा है, उसमें देखेंगे कितना von Willebrand डिजीज है। सो कुछ उसका डेटा है, बट विल बाईपास दैट। अगला, नेक्स्ट 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 या। सो वी टॉक्ड अबाउट द डायग्नोस्टिक चैलेंजेस। नेक्स्ट, अब आता है चैलेंजेस फॉर मैनेजिंग ट्रीटमेंट। डॉक्टर पारुल, आपके यहाँ जो सीवियर की भी बात करी है आपने, जिसमें कि डीप ब्लीड भी हो सकती है, सुपरफिशियल भी करी जो टाइप 1 में जनरली है, तो मैनेजमेंट के कोई इश्यूज हैं अवेलेबिलिटी ऑफ ड्रग्स के एंड नॉन ड्रग मैनेजमेंट के?
Actually, there is von Willebrand factors deficiency. We have to treat by the drugs and the factor replacement. But the von Willebrand factor replacement is not available at our state, because again we right now since last 10 years I am there as a professor and head of medicine. I don't found any patient who is been diagnosed as a von Willebrand factor deficiency. So that is why we are also not been able to procure it. So that factor the replacement therapy is not possible for us. And desmopressin and all these are also we are not able to use it. Only thing we have make a policy at our hemophilia daycare center, which is running 24/7 daily at our institute, in which if any patient come with a report from outside as a von Willebrand, something like from Mumbai, or he come to the Gujarat and then there is some issue, he's having some bleeding or trauma or anything required tooth extraction. At that time, then we only replace the factor 8. That is what we made a policy. So right now, however, we have not insisted. That's why these factors are not available, because it's very, very, still we are not been diagnosed any case. That is only baki. Otherwise, if it is so, we will able to make it possible.
So जो diagnosis में भी थोड़ा सा ढीला है और treatment में भी थोड़ा certain नहीं है, that is von Willebrand disease. Dr. Faim, you are from the Apex Center also. You want to add something for the treatment, or?
See, as far as the treatment of von Willebrand disease is concerned, a majority of the centers do use desmopressin. Basically, it's a vasopressin analog. What it does is that it acts on हमारे endothelium में there are granules. They are known as the Whipple pellet granules, जिनमें there is von Willebrand's factor. So what it does, this drug acts on them and it releases von Willebrand factor. But the problem is, if there is no von Willebrand factor produced, what do we do? That's the problem. What basically is being done is that there is something which is known as plasma-derived factor 8 concentrate. Now this, as I told you earlier, the story which I told you earlier about, is that von Willebrand's factor has a friend, which is factor 8. So basically, if we extract human, and it comes at a high cost, obviously, if we extract human factor 8, what it does that it also contains some amount of von Willebrand's factor. But the problem is that von Willebrand factor is a huge protein. And once we extract it from in vivo, only parts of the von Willebrand factor are extracted. So that can be one of the things which is given. Nowadays, as far as I know, in 2021, there is a drug which has been approved by the FDA. It's a recombinant von Willebrand factor. It's artificially made. And what is the beauty of it is that it contains all the subunits. Now, it is basically, if my memory serves me right, it is known as Novocog in the US and Novonod in Europe. So that is being used. And of course, it would require a long discussion to discuss what are the newer modalities which have come in von Willebrand. There is something which is known as gene therapy. But the problem with gene therapy is that von Willebrand is such a huge multimer that there is no vector currently available to kind of cause the genetic, to repair the genetic aberrations. But one of the things, and I will end it there, is one of the things which has one of the cutting edge technologies which has come, and Professor Bilal is always after cutting edge technologies, I can tell you that, is one of the things which even won the Nobel in 2022 is something which is known as CRISPR. Now, what is this CRISPR? Basically, there were two ladies who won the Nobel for it as well. So this CRISPR has revolutionized genetics. It's known as epigenetics. ये क्या कर लेता है? It basically copy paste. आपकी जो न्यूक्लियोटाइड सीक्वेंसेस है, आपको कुछ चीज़ पसंद नहीं आते, आप व्हाट्सएप पे मैसेज लिख लेते हैं, ये मुझे पसंद नहीं आ रहा है, आप उसको कट कर लेते हैं, बाकी को कॉपी पेस्ट कर लेते हैं और वहाँ कुछ और डाल देते हैं. वैसे ही ये टेक्नोलॉजी है, it basically cleaves the genetic material and then inserts some other genetic material and then it hopes that something good happens. So it's a long, basically it's a long medical discussion, but I think we'll leave it there, sir.
Okay, so before we leave, it is very remarkable कि जितना रिसर्च हीमोफीलिया में हो रहा है उससे कम इसमें नहीं हो रहा है. Cas9 technology has been used, not so much for here, but the related disease, thalassemia and sickle cell disease, are being cured. It's a kind of a substitute for gene therapy. It's easier also, so they will be cured. When it comes to von Willebrand disease, there is this von Wende and many products that are available which are recombinant VWF. Recombinant factor 8 is expensive, but it has become cheaper. It is not considered expensive because it was much more expensive 20 years back. This is several times more expensive and it is not even approved in India. So what is done कि जो factor 8 होता है उसके ना generation उसकी भी होती थी, purity होती थी, intermediate purity, low purity. तो जितना कम प्योर होगा उसमें जो impurity होगी वो फॉर्मुलेबल डिजीज का एक उसका हिस्सा होगा. तो things that were less pure had phonolubrant factor, and they write there on that vial how much is there. So there are 3 names that is, one of them is available here, but it's difficult to get. That impure plasma derived factor 8 is used as a cheap substitute for recombinant factor 8. Now I must also say that one of the recombinant, one of the plasma derived factor 8 which is procured very often in the hospital, which I don't know how it comes, they claim that it has VWF, but VWF in impure factor 8 should be of a given reproducibility कि 100 IU per ml मिलेगा आपको, अगर नहीं मिलेगा तो वो नहीं क्वालिफाई करेगा. थोड़ा बहुत किसी में मिलेगा पर वो एक बैच में मिल गया, उसका एक दूसरे लॉट में नहीं मिला, वो नहीं चलेगा. सो देयर इज़ वन प्रोडक्ट दैट्स अवेलेबल. लेकिन ज़्यादातर लोगों को ब्लीडिंग सीवियर नहीं होती है, क्योंकि जिनको सीवियर होती है हीमोफीलिया में 2/3 को सीवियर होती है, इसमें टाइप 3 को होती है जो कि आई थिंक 5% 8% ऐसे कुछ होगा. तो इसकी ज़रूरत नहीं पड़ती है. इसकी ज़रूरत नहीं पड़ती है तो माइल्ड में आप लोकल हीमोस्टेसिस, प्रेशर, लोकल थ्रोम्बोटिक एजेंट्स, non, what do you call it, anti-inflammatory, no, antifibrinolytic drugs आप वो जो यूज़ करते हैं एप्सिलॉन अमाइनो कैप्रियोक एसिड, ट्रेजेस्मिक एसिड, वो सब यूज़ कर सकते हैं. एंड डॉक्टर फाइम ने बड़ा अच्छा बताया कि अगर आप डेस्मोप्रेसिन यूज़ करते हैं तो जो अंदर स्टोर्ड फॉर्मुलेबल फैक्टर होता है और उसके साथ में फैक्टर 8 भी होता है बाय द वे, तो वो रिलीज़ हो जाता है. तो शॉर्ट टर्म, बट रिलीज होने के बाद उसको आप रोज रोज नहीं इस्तेमाल कर सकते, क्योंकि रिलीज हो गया तो अगले दिन तो मिलेगा नहीं. लाइफ तो प्लेटलेट्स की भी एक हफ्ते से क्या होगी ज़्यादा, बाहर 10 दिनों की होगी लाइफ में. तो उसको आपको शॉर्ट टर्म जैसे डेंटल एक्सट्रैक्शन करना है या डेंटल ब्लीडिंग को रोकना है तो आप 1, 2, 3 शॉट उसके दे सकते हैं. वो माइल्ड हीमोफीलिया को भी दे सकते हैं, फॉर्मुलेबल को भी दे सकते हैं. एंड दिस इज अवेलेबल एज ओरल, नेजल एंड इंट्रावेनस, सो दैट कैन बी गिवन. So most of the time treatment is simpler, local pressure. But if it is a severe bleed, then you have to give the replacement factor. If it is required for a short time, then you can use the desmopressin. Of course we are giving. No, factor 8 नहीं, आप VWF कहिए. हाँ, जो उसमें है. I think Dr. Taim has got a answer to that. You have some patients.
To be very honest, I'm not aware of. To be very honest, I'm not aware of that. I think Dr. Bilal would take that. I'm not aware of that.
I thought somebody showed some cases on prophylaxis. They are 40.
Yes, we can give a prophylaxis factor 8, one milligram.
1 second, let me. No, that's okay. Hemophilia or fondue.
No, I don't think.
No.
Because you cannot give type 3 von Willebrand with factor 8 concentrate, because
That
it is
again
primarily
increase.
the factor, von Willebrand deficiency. We have the product available with us, which comes with a factor 8 with von Willebrand concentrate. But some people are promoting plasma derived factor 8. They have the justification that plasma derived has always some sort of small amount of one, but that will not take.
You can ask from a RKS local purchase in one exceptional case.
No, he made. No.
That will again reduce the von Willebrand factors level. That should not be given.
Sir, recombinant has no formulation factor in it.
You can give some sort of plasma derived, but you cannot.
You cannot get. See, recombinant has no VWF in it. can never use it.
It is
Plasma
only
derived, 8 out of 10, you cannot use it. To my knowledge, only one is available now, Hemate or what is that, Hemate? Immunate. So that, and you see there, it would have a consistently so much of IU of VWF. There is one that somebody purchased as this Reliance का जो आता है, क्या आता है?
There is alpha rate
उसमें लेकिन वो VWF नहीं है, उसमें किसी बैच में आता है, किसी में नहीं आता है.
BPL का आता है.
वो BPL का आता है और वो टकेडा का आता है, दो आते हैं.
Takeda and BPL.
Which one?
But they
No,
might
no,
be
no,
working in
no, no.
type 1.
Let me clear it up. Sir, बोलिए.
Outside hospital, and then post-op he was bleeding from this side. Then they evaluated, they found it to be, there was 1 milligram deficiency, and they gave for 1 week or 2 weeks of this immunate, and then discharged. And then again they came with a bleeding to our hospital. So initially we also gave like 1 week, since there was a minor bleed. But then again he started having, like, HB started falling. So that's the time I got very concerned. Then we thought, because locally the surgeons will hardly any bleed, just a small ooze kind of thing. Then I asked my gastroenterologist to do upper GI and lower GI to see if he is having any bleeding, like coagulopathy type bleed. There was a large clot in the colon till up to like it was going up. So initially we thought probably it's bleeding from the top. We did a capsule was also negative. Then we struck us probably what we are dealing is maybe it's a large vessel bleed or something. Patient was almost was about to arrest, like we were giving factors. The one good thing was when we were giving this 1 milligram factor and we tested with the PGI, the activity was increasing. Like then I could get up to 200% activity. I continued on that dose. Then we did the angiography and we saw we blocked the interventionally, we coiled these hemorrhoidal arteries. Then the patient survived. He was intubated, taken into the interventional radiology lab. Then we did the coiling, and afterwards he survived. So, and then we gave for about 2 weeks, 3 weeks, and then so now I'm not giving him anything. He is not bleeding now. So we qualified him as type 2, not the type 3. So, but he bled only because of the surgery. But he was otherwise, when we retrieved his history, he gave some 10 years back. He had some dental procedure where he had a little prolonged bleeding, which was associated with some antifibrillary. So sometimes even type 2 can become a life-threatening disaster like in our case. But what product we used was this plasma-derived product. One is the Reliance one and the Takeda wala product. It actually gave good results. It could save this patient. But the problem is availability of this plasma-derived factor in the market. So I literally, we exhausted all the whatever is available in the local market, and luckily, lastly, the Haryana government came to our rescue because they had plasma-derived factor in their inventory. So I spoke to the Hemophilia Federation of the Haryana and then took some vials from them. So, so I want to say definitely this low purity viral factor, plasma derived, because recombinant definitely it will not work. So only the plasma derived, because recombinant 1 milligram factor is not available in India, we are left only with this plasma derived products. So the companies have to make some amount of plasma derived products and be available in the market for such kind of patient, otherwise it will be a disaster.
Agreed. So one thing, let me put it out very clearly. I don't know whether you have checked it.
the consistency of the presence of von factor in a plasma-derived factor VIII product, which is to be used for BWD, the consistency must be shown. And that consistency, once again, let me complete. Consistency is shown on the product, the vial. And they will clearly write it. Now the literature has it that all other products which don't show consistency cannot be used because their predictability cannot be guaranteed.
Yes, sir.
And that is the case with Reliance. And they write there it is not to be used for von disease. And if there is one, I'll come back to you. If there is a severe von disease, they would need regular treatment. The only problem is you'll have to decide how to give it. Because the recombinant product is not approved in India. Probably they think there would be no market because of the cost. Sir, boliye.
My only thing is, like what you said is absolutely, we have to go by their project. But in my case, practically it was proven by giving the factor, and I could see the rise in factor level from like 13% to 200 and 400%. So that's how we could save this patient. Otherwise, he would have bled to death.
Very good.
Sir.
Now this is one limitation with the experience. Long time back when we were residents, we used to get salmonella, typhoid fevers. So one was hospitalized because he was losing so much from it. These residents, colleagues, they cut a hole in the bed. He couldn't go there. He said, "Niche हमने लगा दिया, आप वो कर लीजिए." He was from village. So our professor said, "देखो भाई बहुत serious है, हम इलाज तो शुरू कर दिया है, लेकिन लगता नहीं कि हमें बचेगा, पर फिर भी देखिए." 3 weeks later, he got up. He moved out. He says, "आप बड़े लकी थे कि दवाई काम कर गई." कहता है, "सर दवाई का तो मुझे पता नहीं है, पर मैंने जो प्रेयर करी थी वो जरूर काम कर गई है." Single case benefits are very good to learn and to convey. But I think they can't make a rule. We can use it, but if the leaflet says it is not there, if the science says it is not there, but it does not mean it is not there. They say it is there, but there is no consistency. So you probably were fortunate in getting something that had a higher value. Sir.
Sir, we have about 96 cases of von Willebrand in our society registered. 44 are women. Every month is a problem. And we have mid-cycle ovulation bleeding.
96?
Yes. Diagnosed at CMC
Sir, let's
Vellore.
Dr. Kaur, let's hear him. Yeah. 96, yeah.
Yes. And we have mid-cycle ovulation bleeding in about 4 cases where we've opened. We have used Optivate BPL product and we successfully conducted surgeries in those 4 patients. And another case yesterday we could organize for a hysterectomy because severe menorrhagia in that case, and 2 cesareans are also performed through the Vijayawada chapter. We have used Optivate or BPL 85.
So over how many years have they been diagnosed? Is 96 for a couple of decades or longer?
No, since the inception of the society.
That is when?
Somewhere 93.
So, no, I'll tell you why I was asking this. Sir, you were wanting to make a comment. Yes, you should be rightly surprised. You should also be rightly surprised. You know, sir, I'll give you a story which I am just disclosing for the first time. When this matter was being fought in the Honorable High Court in 2006-07, then the societies were also made part of it. Actually, they are the ones who filed all this. So when the Honorable High Court decided that the treatment should go to treaters who are qualified treaters, and it came to us. They put one clause, very wise guys these chief justices are. They said, भाई आप लोग तो इतना साल से करते हैं ना, आपको सोसाइटी तो बहुत लंबा चौड़ा है, आप उसका डेटा जो है डॉक्टर साहब को दे दीजिए. And I got a CD. I was surprised. You are saying 96, I think they had more than 100 cases there. And they had all kind of cases. Women hemophilia also were there. And women hemophilia is a rarity. But they had some 200 some cases. So the problem that arises is 93, if even in 2023, we heard from Dr. Sonal Shah, it's not easy to make a diagnosis of hemophilia. There must have been some issues with the diagnosis also, because the infrastructure was not so widely available. I don't know, I'm just conjecturing. But the numbers by themselves do not imbibe that confidence.
All over India, let me tell you one.
No,
all over
because-
India, it
well,
is
in-
745 patients only diagnosed right now. This is data I have.
ये तो उनके 96 है ना, वो ज़्यादा 700 से ज़्यादा नहीं करे. सर बोलिए.
All over India से आपका कितना % हो गया?
Yeah, you are right.
No. I must grant him what he's saying. I must grant him, because von Willebrand disease is supposed to be common. In US, they expect out of 100, 1% is von Willebrand disease.
Yes.
The question is only diagnosing it.
Right. That is the limitation.
Right. If you are diagnosing it within a country where the lab facilities are likely to be of the same standard, if you will pick up 96, then she should pick up also 96 or few hundred, and somebody else also. But we didn't find that data. So you could be right, but that just tells us that we should look for the diagnosis of von Willebrand disease with the open eyes and open mind.
So any cost there, free of cost, or how much charge you? We will send some patient. if it is-
Are you doing
how
it?
much charge you? Any charge? Because I think Vellore it is a not non-government institute, na? How?
9,000.
9,000. Okay. Okay. Then we will share with some patients
So-
those who are really.
No, so patient pays it or society pays? Patient pays. Okay, so you got the idea that we have issues with the diagnosis, we have issues with the treatment, we also have issues with suspecting it, and we also have issues with confounding the diagnosis with hemophilia A. Yes, Dr. Jintal.
Sir, we have very few patients with von Willebrand. We have two siblings who are coming with von Willebrand disease. They have been diagnosed. Their von Willebrand antigen as well as the retrocession cofactor assay both are been done and they are diagnosed. So they come to us very frequently with bleeds and we keep on giving them FFP only. We have no other options with us. And their main concern is they should get a disability certificate for the same. So, but we are not able to grant it because we have no such guidelines for giving disability certificate to one. So this is another issue with these bleeding disorders. As it is a forum for a bleeding consensus meeting, so I thought this is a good point.
Very, very nice thing, very nice thing. I think it is not the government that will give this. And this I've said some time earlier also. When we are speaking of these hemophilia meetings and boys and hemophilia, we should move away from here. We should not leave the women, because even if von Willebrand disease is a little more common, let's say 60-40 in women, but I think they suffer much more because they naturally have this regular monthly bleeding. So they get into anemia more often. So they show up as a case with some complication much more often. So we should stop calling them hemophilia bleeding. We should call them meeting of bleeding disorders, right? Or if you are wanting it hemophilia, call it hemophilic also. After all, VWF and factor VIII, as Dr. Fahim said, they are good friends. That being the case, we as a group, here and everywhere, maybe now that you have given it, we can bring it in our hemophilia booklet also, next version. We as a group should tell them that VWD is a variant and it should be classified under the hemophilic disorder. So the word I used was hemophilic disorder. And if we use the word hemophilic disorder, then it may qualify for those Right of Persons with Disability Act 2016, December 2016. So then it will automatically come in there. No. The factor 8 level is 8%, somebody said 3%, some said 13%.
The factor 8 level is quite low, and there is the patient has von Willebrand disease. You mean that? In that case, what ideally is done is that you would add emicizumab as well, because there are some centers in Europe who have started doing that. They have started giving the biphasic monoclonal antibody, so that because the factor 8 is already there, von Willebrand disease is not there, and you then give exogenous von Willebrand factor. In West, because they have, of course, they don't have any resource constraints, what they are doing currently is that they are giving emicizumab and they are adding the recombinant Novocog, which is von Willebrand factor. That they are doing. One thing, just if can I add one thing more? I think one of the things which should be kept in mind is that what was said regarding history taking in bleeding disorders. As we know that, for example, hemophilia is an X-linked recessive disorder. So हमें बचपन से ही बोला गया, right from our first year in med school, that males are the sufferers and females are the carriers. But now we know that 25% of hemophiliacs are because of de novo somatic mutations. Therefore, you find a lot of females with hemophilia. As well as Sir was saying, there are a lot of females with hemophilia apart from somatic mutation. That would be because of X chromosome inactivation, which is known as medicine as lionization. So those are two of the things which we should always keep in mind.
I think another thing to remember here is that many a times there is no history of bleeding, you see, and patient is 65 years old. What you told somatic, there are certain autoimmune diseases also, which result into secondary. So this is
right.
Also.
I think one of the things what you brought about is very important. We have, without naming the patient, she was in the hall itself a few moments back. She's a doctor as well. So what happened is that you just, because you mentioned it, so I'm mentioning it. What happens if you see all of the physicians, all the pathologists, anyone, if you see a patient who has an inherited bleeding disorder and that has phenotypically for the first time it has manifested in the later stages of life. You should always think that it is it might not be an inherited defect. It might be an acquired defect. For example, SLE. And one of the things which which I remember profoundly from 2014, I was just a resident at that time. We were sent from SKIMS to PGI. I saw a case, it's known as Hades syndrome. In Hades syndrome, because of the narrowing of the aortic valve, aortic stenosis, the shear stress is so much high because of the Adam 13 TS coming into play. It causes something which is, and these patients have vascular gastric angiodysplasia. They bleed profusely. So I think we'll leave it there. It's a long medical discussion.
Yes,
so you said it right. There are issues which are called acquired disorders. Renal failure has got this involvement of multimers of VWD, very common, VWF. So there are many.
And one thing you must remember also, von Willebrand disease type 2N.
Yeah.
Which is also called as autosomal hemophilia. This can be misdiagnosed as hemophilia.
Sir, last comment.
Sir, thank you, Dr. Naresh Gupta, sir, for your magnanimous and vast knowledge and good development in today's medical talk. Dr. Fahim, I should say also thanks to you because you forced me. Dr. Fahim, I would like to thank you also because you forced to think me about one of the essential issues.
You're welcome there.
Regarding physicians and other medical officers, they don't have proper training and proper diagnosis regarding this hemophilia because it's a disorder and patients coming to in every OPD, either in surgical OPD or in a medical OPD with, for example, a simple this epistaxis and other these disorders. So you made me to submission Professor Dr. Sheikh Bilal, my colleague and my best friend and my buddy, to make a submission to government to depute kindly medical officers and other physicians for training sessions to your Department of Pathology, GMC Srinagar, for their upgradation of knowledge so that they can patients can be benefited from your side, from the Department of Pathology, so that we can serve better
in our country and for the patient care. Thank you very much,
I
and
support it.
love you, and may God bless you all.
I support it. Thank you, the panelists, for educating us
Thank
on
you.
BWD.
But I just want to leave you with one thought or question or your homework or something like whatever you call is regarding the von Willebrand diseases. How will you prepare a female patient who is having pregnancy with von Willebrand disease? Just go on thinking of this. What preparation will you make? Already diagnosed and having pregnancy? How will you discuss with the gynecologist? What preparation will you do? Thank you. Thank you.
Thank you to the moderator and panelists. This provides a graceful conclusion to the day, encouraging engagements for tomorrow's session. Thank you all for your patience and participation. Also, those who have to leave tomorrow, kindly check out in the morning. Dinner is served. Kindly proceed for the same. Thank you once again.